machine. So basic principle, the plasma exchange blood is pumped out of the patient's circulation and is transferred to the filter separating plasma from the blood cells. So afterwards, blood cells are pumped into the patient's vein. Patient's plasma is substituted by human albumin and or FOP because plasma consists nearly 55% of the total blood volume. So it is very important to replace the plasma. So for that, certain things essential. First is vascular access, like hemodialysis. So the same thing. This method is vascular access. So most of the case, central veins, catheters are used in plasmapheresis, especially in acute conditions. They can be placed in interjugular, femoral or subclavian veins. However, if long-term treatment is needed, like ideal apheresis, arteriovenous fistula may be created, like chronic dialysis. So techniques. So nowadays there are two techniques are available. So for plasma exchange, that is only centrifugal. This is very commonly used in blood bank. So it has been they are using for a long period to separate plasma from the blood. And another is hollow fiber membrane separator. This is like hemodialysis, that is hollow fiber. In addition, more selective methods also are developed nowadays. So in centrifugal separation, the separator is a disposable rotating centrifugal bowl. Blood runs into the bowl and centrifugal force separates blood cells from plasma. Blood cells are pumped back into the patient's circulation, whereas plasma is separated in sterile bags. There is no upper limit for the size of the molecules removed by centrifugal plasma exchange. Usually the blood flow ranges between 90 to 150 ml per minute. A major disadvantage of centrifugal plasmapheresis is a platelet count reduction, which may reach up to 50% reduction of the platelet count. Then commonly used is a membranous plasma exchange like hemodialysis. In this type of plasma exchange, highly permeable hollow fiber membranes filters are used. Like in hemodialysis, the fibers have pores with the diameter ranging from 0.2 to 0.5 mu. As blood runs through the fibers, plasma is separated from the blood cells, which are returned in patient circulation. All immunoglobulins are effectively cleared by this method. However, the effectiveness is poor in immune complexes and cryoglobulin. The risk for platelet count reduction is less, yet there is a risk for hemolysis, especially if faster blood flow is used. Synthetic membranes are used. Plasma fibers should not be reused as in hemodialysis. Hemodialysis, we can reuse the filter. So, technique. The above mentioned plasma separation techniques remove plasma from the whole blood, thus causing loss of normal protein, especially coagulation factors and albumin. To reduce protein loss, selective plasma exchange techniques are introduced in practice. So anticoagulation. So we are taking the blood out of the body, so it should not clot. So that's why we have to use anticoagulants like in the hemodialysis process. Commonly heparin will be used in this hollow fiber hemodialysis, plasma exchange. We can use low molecular heparin also we can use, but in the centrifugal, so this plasma exchange, the citrates are used. Substitution fluid, this is very, very important because we are removing plasma from the body which contain all toxins, all immunoglobulins or these immunocomplexes. So large volume of replacement fluid is required. A single procedure was found to reduce plasma macromolecules level by 60%. The use of crystalloids is ineffective as they are not capable of preserving the intravascular oncotic pressure. Gelatin-based plasma expanders have limited practical importance as they have shorter half-life. Therefore, the most widely used substitution fluid is human albumin. Replacement volume reaches 50 ml per kg. The major disadvantage of albumin replacement is the lack of coagulation factor. Therefore, fresh frozen plasma can be infused after plasma exchange. So substitution fluid. So FOP only used as substitution fluid in certain procedures. For example, hemolytic uremic syndrome, thrombocytopenia. So other indications for FOP use are reduction of plasma fibrinogen level below 1.25 gram per liter, increase of prothrombin time more than 2.5 above the normal value, and increased risk of bleeding, especially pulmonary hemorrhage. So 48 hours after surgery or biopsy, only FOP should be used as a replacement fluid. FOP should be used with caution as its application is associated with hypotension, citrate-associated paresthesia, urticaria, anaphylaxis, and blood-borne infection. So frequency of plasma exchange. So plasma exchange usually performed daily or alternate days. So daily in acute conditions like TTP, AADP, 2 to 4 hours per session, but may vary according to the patient's general condition. It may vary. So the duration of treatment 5 to 7 sessions over 1 to 2 weeks, but it can be guided and by clinical outcomes and laboratory results. So autoantibody titers and platelet count. So plasma exchange mechanism of action already I have told. Elimination of pathological constitutions. So allow antibodies, autoantibodies, paraproteins, circulating immunocomplexes, toxins. Substitution of plasma protein, clotting factors, so hormone carrier protein, immunoglobulins, and so on. Modifying immune cell function. So deblocking of reticuloendothelial system and modifying lymphocyte response. So plasma exchange immunosuppressive treatment. So despite the mentioned beneficial effects, plasma exchange is not effective in immune diseases when it is used alone. So it influences pre-existing pathological molecules and has no influence on their formation. It was established that the procedure causes rapid decrease in antibody titer, which is followed by increased antibody production and beta cell proliferation. So in addition to combination costlier procedure, it is a life-saving procedure in certain diseases. A more interesting perspective is the development of
complications like hypotension and arrhythmia, because we are completely exchanging the plasma. That is one of the area which has to be concerned and tailored to individual patient, according to the individual patient. And any question from the audience? Thank you very much.
So once again, thank you all.
Next, I call upon the speaker on management of high-risk bleeding by Dr. Raja from Chennai.
A short power cut for 2 minutes, sir. So we can have the discussion for the first half now before we ready with the second talk, because there's going to be some electrical problem that's going on. For 2 minutes, there will be a power cut when we won't have the LED wall for the second talk. So if you want to finish the discussion for the first talk, we can do that at that time. Thank you, sir. Any questions for Dr. A.S. Mohan?
antifibrinolytic should be avoided. So then treat the main cause. Last one is hemophilia. Hemophilia is inherited X-linked disease, bleeding disorder, which is deficiency or lack of the factor 8 or factor 9, hemophilia A and hemophilia B. Incidence of hemophilia, so hemophilia A more common 1 in 5,000 male in the newborn, and hemophilia B more common in 1 in 25,000 to 30,000 male, and in India at least 1,675 new hemophilia babies every year born. Severity of hemophilia we can divide into the 3: mild, moderate, severe according to the factor concentrations. Mild, it will be severe if it is less than 1% of factor, if it is present, severe. Moderate, 1 to 5% of factor. So if it is 6 to 40% of factor present, we can call it as mild. Hemophilia B also we can divide into three according to the factor level. Treatment, general measures, Prince therapy, protection, pressure and rest, ice formation, compression and elevation, and also the physiotherapy and psychological counseling how to do. So factor replacement, so main on-demand factor replacement or prophylactic therapy we are giving. Types of factor therapy, it's a plasma derived factor concentration and recombinant factor concentration, which is short-lived and longer half-life factors available nowadays. Calculating factor 7 replacement, so 1 unit of calculating factor 8 replacement, 1 unit of factor 8 raise the plasma level 2%. So factor 8 we can calculate like weight into desired increases by 2. So this desired factor 8 replacement, and calculating factor 9 hemophilia for hemophilia B, this one unit will raise 1% of factor level. So the body weight into desired factor 9 increases into 1. So various desired levels available in chart. So how to administer the factor? It's IV bolus. Do not dilute with the DNS, NS, and oral. Slow infusion we have to give, never intramuscular. So we can give the factor 8 every 12 hours. So because of short acting, so 10 to 12 hours. And factor 9 we can give we can give every 24 hours. Last one is emicizumab. It's a non-factor replacement therapy. It's nowadays available. It's a very good drug. So emicizumab is a humanized 5-specific monoclonal IgG antibody designed to recognize and simultaneously binding to the factor 9 and factor 10, leading to activation of the factor 10. It's the same like factor 8. Emicizumab is a routine prophylaxis to prevent or reduce the frequency of bleeding episodes in adult and pediatric patient, hemophilia A with or without inhibitors. Dosage of emicizumab, recommended dose 3 mg per kg by subcutaneous injections once weekly for the first 4 weeks, followed by 1.5 mg per kg once weekly, or 3 mg per kg every other week, or 6 mg per kg every 4 weeks. This long acting we can give every 4 weeks. We can give prophylaxis as well as the treatment. Long-term management of hemophilia, we should monitor for the inhibitor titer every month. No signs of allergy and nephrotic syndrome we should evaluate, and no new bleeding should see every month. Take-home points. High-risk bleeding is complex process, multifactorial, associated with multiple system and multiple conditions. Not only the hematological, associated with the surgical, obstetrics and gynecology, and central nervous system, CVS, and pharmacological, like all systems are involved. Assess the bleeding risk and assess the amount of bleeding. Act immediately to treat the patient, restore the volume and clotting factors. High risk bleeding or life-threatening condition, if not treated promptly, find the cause and associated with the other disease and treat immediately. So thank you for giving me the opportunity. Thank you, sir.
Well done, Raja. Sorry for the inconvenience caused to you. This is a vast subject. Definitely you cannot cover it in the short time. If any questions from the audience, please. If there is no questions, we will call the next speaker, Dr. Prabhu. Dr. Prabhu is from Chennai. from Apollo. He is going to talk on thrombocytopenia, demystified, an update.
Thank you very much. I think my previous speaker, Dr. Raja, very comprehensively covered several aspects of blood coagulation and how it has to be treated. So I think the topic given to me is thrombocytopenia demystified. We'll just go. What I thought I'll do was to put together certain typical case scenarios that arises where thrombocytopenia is a problem, and we have to kind of demystify in terms of finding out the exact cause and thereby formulating a proper management plan. So, yeah. Okay. So they're mostly cases. In fact, they're all cases. So if you feel like shouting out what you think, that's absolutely fine. So it's moving. Huh? Okay. So this does appear like a very complicated slide. Like my previous speaker said, there are two aspects to hemostasis, primary and secondary. Primary hemostasis is when the area of denuded endothelium comes in touch with the platelets. And these platelets will interact with the endothelium. And because of that interaction, there will be changes in the membrane that will release several coagulation factors. It's a complicated slide, but it's just to tell you what is the initiating event in when there is endothelial injury. Subsequent to that, there is platelet-platelet interaction, and because of that, there is a platelet plug that is formed. So this is primary hemostasis. If you were to stop with, if physiology stops with primary hemostasis, the clot will be stable only for a few seconds. After that, there will be renewed bleeding. So in order to enforce the clotting mechanism and enforce the strength of the clot, you have secondary hemostasis, which involves several coagulation factors that Dr. Raja just mentioned. So I think we'll just straight dive down to a few cases. As I said, there are a lot of young people around. So if you want to shout the answer, please feel free. You can sit close to a mic. It'll just make things interesting. So thrombocytopenia is a very common occurrence in practice. It can be an emergency, it can be just in your office sitting and seeing patients, and it can be challenging sometimes, but knowing all these situations will help. So 28-year-old athlete in robust health presents with few blood spots in both his legs. Okay, he comes to the ER and or to your clinic. CBC shows hemoglobin of 14.5, total count of 8.2, and a platelet count of 8. As always, you just check renal liver function test. That's all normal. PT, APTT, fibrinogen is normal. Examination apart for that, for those few petechiae is completely unremarkable. So anyone wants to take a guess what it could be? Okay, if not, we'll. So when you see such a patient, you have to first, there is thrombocytopenia. First thing to ask yourself is the patient symptomatic? Is there a bleed? And in this particular patient, the answer is yes, because there are a few petechiae. Nature of the bleed, is it mucosal bleed or tissue bleed? Like my previous speaker said, mucosal bleed will be skin bleed, hematuria, gum bleed, etc. Tissue bleed will be muscle hematomas and joint bleeds. So muscle hematoma, joint bleed tends to occur with coagulation factor defects. With thrombocytopenia, generally mucosal bleed. So that is the next question you ask. Then you ask yourself, is the patient well or unwell? That's again an important thing to ask yourself. There are many medications that can cause abnormalities of platelets, both in terms of function and in terms of numbers. So you have to take a clear history in terms of medication. Personal habits. There are several things that can contribute to low platelets. So what is the laboratory test that you need to do, and what are the answers you're seeking from the laboratory? First thing is the thrombocytopenia real? So this might come as a surprise. Is there a false thrombocytopenia? Yes, there is. Because sometimes when you put sample in EDTA, platelets aggregate. So this aggregation is in vitro. You don't see that aggregation in vivo. Because of that, with a few patients, when you do platelet count from EDTA sample, because of the in vitro aggregation, you can get falsely low platelet counts. So you always have to examine a peripheral smear to see if there's any aggregation, because that is very important. Otherwise, you'll get worried and you'll probably use inappropriate investigations and treatment. The next question to ask is, if this abnormality that you've noticed in the CBC is an isolated abnormality. So in this particular patient, it's an isolated abnormality. Are the coagulation parameters normal? Like my previous speaker, Dr. Raja said, in DIC you will get abnormal PT, APTT, low platelets, etc. So you ask yourself, when you see someone with low platelets, you want to know whether the other coagulation parameters are normal. You want to see if you want to find out if the platelet count, low platelet count is part of a wider disease like DIC or anything else. So these are questions you have to ask. Any abnormal biochemistry, like an abnormal LFT and renal function, etc. So we talked about, pseudothrombocytopenia. The slide which says EDTA dependent pseudothrombocytopenia tells you that there is aggregation. So this patient has normal platelet count, but the machine will estimate it as low. So someone has to look at the peripheral smear. If you find pseudothrombocytopenia, you can do the peripheral smear and the count on a heparin sample. Whenever you see such severe thrombocytopenia, it's very important to look at a peripheral smear. So without that, if you proceed, you're likely to miss a lot of abnormalities. Unfortunately, I don't have a pointer. Oh, it's here. So if you look at this slide, this slide is just put up to just tell you how much information that you can get from a peripheral smear. You may not have all of this, but you need to look at the peripheral smear in a very systematic manner. You may get nucleated red cells, teardrop poikilocytes, anisopoikilocytosis, abnormal cells, etc. And sometimes we have a lot of tropical infections. Even they can have thrombocytopenia. You can have malaria, intracellular parasites. So a very good peripheral smear examination is absolutely 100% necessary. So what are these cells? Anyone wants to take a guess? The one that pointed? Yeah, schistocytes. So schistocytes, you can see schistocytes. Like we talked about plasma exchange in TTP. So you can get schistocytes. So these things will be missed if you don't look at the peripheral smear. You don't have to tell what the cell is. Of course, there are faggot cells and all that. So it is acute leukemia. Sometimes I have seen patients who have missed, whose diagnosis of acute leukemia has been missed. And basically, they've come to see me as ITP, etc. So this is what is case 1 for us. So case 1 has got isolated severe thrombocytopenia in a very well person. So this is immune thrombocytopenic purpura, ITP. So further investigations, generally you don't need any further investigation. But if you want to look for coexisting disease, etc., then you have several other tests to do. So petechiae, purpura, and a big blood blister. So ITP treatment, not all need treatment. If platelet count is above 30,000, you don't need treatment. If they are not bleeding, you don't need treatment. Steroids and IVIG in the initial period, when you have to treat them acutely. Subsequently, if you have to, long-term treatment will be, the acute phase treatment will involve steroids. If they don't respond well to steroids or if they relapse, then you have second-line treatment like rituximab. And I'm sure you would have come across the thrombomimetic agents like romiplostin, which is a parenteral agent, subcutaneous, and L-thrombopag. There are some new splenic tyrosine kinase inhibitors, and sometimes, very rarely, you have to resort to splenectomy. So I know that we only got 7 minutes. There are several cases, but even if we do 2 or 3, that's sufficient, I'd say. So 55-year-old lady with fever for 5 days, severe fatigue, body ache. She is afebrile. Hemoglobin 13.5, total count 2.1, platelets 15. PT, APTT normal. LFT, there is transaminitis. Creatinine, mild renal impairment. So this is definitely not your first patient. This is an unwell patient. Then hence that question, whether the patient is well or unwell. So unwell patient, low platelets, leukopenia, abnormal liver and kidney function in a person with a recent febrile illness. Can be anything, dengue, NS1 antigen came positive in this particular patient, but this is a tropical infection that you're thinking about. So Case 3, 28-year-old primary, 36 weeks, IUGR, reports to emergency with lack of fetal movements for 3 days. Fever, large bruises, anemia, total count 18.5, neutrophilic leukocytosis, platelets 32, mildly elevated prothrombin time and APTT, and the fibrinogen is low at 121. Any guess what we are looking at? DIC, IUGR, retained dead fetus DIC. So this is completely different to our first and second patient. So this patient has got multisystemic problem. There's consumptive coagulopathy in the form of increased PT, APTT, and reduced fibrinogen. And patient also probably has sepsis. So this is low platelets, coagulopathy, abnormal renal and liver function in a complicated pregnancy. This was disseminated intravascular coagulation. This particular slide tells you different causes which you can easily find in any textbook. So in the interest of time, we'll just not go through the exact nature of DIC and everything, but we've got 20 minutes, so I'm just illustrating various clinical situations where thrombocytopenia can occur. Okay, this again is not unusual. 56-year-old bank manager, routine health checkup, comes to you with a hemoglobin of 13.8, total count 7.6, and a platelet count of 98. The normal being 1,50,000 to 4,50,000. So this patient's platelet count is 98,000. He's very well. TMT positive. They are planning a CABG. So the cardiologist and the cardiothoracic surgeon send to you in a panic, knowing his platelets are low. How are we going to manage? The peripheral smear is normal. Everything else is normal. So this is a patient with isolated, moderate, low, large platelets in a well middle-aged professional, let's say. Could be anybody. So this can happen. See, platelet count 1,50,000 to 4,50,000 is the normal count. But there are a lot of people who have platelet count between 100,000 and 150,000 with large platelets, and they don't bleed. So in this particular patient, when the cardiologist or cardiothoracic surgeon refers to you, you take a history. There is nothing more important in assessing patients than history of hemostasis. So you have to, when you see somebody with a suspected bleeding disorder or clotting disorder, you have to ask how they have performed when they have been exposed to hemostatic challenges. So in a woman, it will be whether they have menorrhagia, if they've had children, how did they behave when they had vaginal delivery or cesarean section. These are the important things. In men, if they've had surgeries, circumcision, if they've had circumcision, how they behave. This history is very important. This is more important than the numbers. So this patient had major surgery a few years ago, no bleeding. So you just reassure and tell them, look, you can take this patient up for theater, you can treat them with antiplatelet agents. So 2 minutes. 72-year-old male patient, diabetic, hypertensive, flu-like symptoms for 1 month, pain in the left hypochondrium, anemia, white cell count of 1,42,000 with a platelet count 34,000, splenomegaly, multiple lymph nodes. So these are large lymphoblasts with lots of vacuoles. So what are they? Burkitt's-like cells, let's say L3. So this patient clearly is totally different to the previous all patients. This patient, when you see, your first step is to immediately get rid of him and send him to a hematologist. So low platelets as one part of many hematological abnormality in a patient with enlargement of lymph node and spleen. Okay, I think primary, this is the last case, let's say. 32-year-old in pregnancy, thrombocytopenia is very common. So 32-year-old primary, 32 weeks pregnant, a known case of SLE brought into emergency with seizures. BP 160 by 110. There's proteinuria. So we are looking at someone who could have PIH, let's say, with seizures. So it could be toxemia of pregnancy or many other differential diagnoses. So hemoglobin 7.2, total count 3.9, platelets 41, LDH 920. Anybody wants to guess what this could be? Huh? HELP. Yeah. Anything else? But HELP usually doesn't cause seizures. HELP is definitely in the differential diagnosis. This is definitely the last case. So this is another area where thrombocytopenia in pregnancy is quite a difficult area. Very often you have gestational thrombocytopenia which doesn't cause any major issues, and they would just carry on with their pregnancy. Then ITP complicating, but there are also other diseases where you tend to have, major complications. This patient had occasional cystocytes and polychromasia, which means there was microangiopathic hemolysis. Now, anyone? Okay. So this patient could have, I don't think there's one single diagnosis that you can come to, deliberately made complex. Very often these kind of patients present to you in this very complicated way, and you have to basically discern as to what they could be. It's definitely not ITP. It's an unwell patient with lots of abnormalities. Definitely not ITP. HELP syndrome. Can it be TTP or HUS? Yes, it can be. TTP mainly. Can it be acute fatty liver of pregnancy? It can be. So, or it could even be catastrophic antiphospholipid antibody syndrome. This is a very challenging situation, which is not uncommon. In a tertiary hospital, you'll tend to see a few every year. So there are many ways to differentiate between these syndromes. We've got to the last few minutes. So again, you can look it up. So it's very important to differentiate between acute fatty liver of pregnancy, HELP, and TTP or HUS, because the treatment varies. With HELP, acute fatty liver of pregnancy, supportive care, and deliver the baby. That will help. In TTP or HUS, you have to intervene with plasma exchange and other immunosuppressants. In TTP, if you don't intervene in time, you're likely to lose a patient. Last spotter, 75-year-old man had a CABG 10 days ago, now presents to the ER with darkening of toes on the right leg and dusky discoloration of toes on left leg. Hemoglobin 11, total count 12, platelets 32, renal liver function test, coagulation tests are normal. Anyone you can guess at any time and shout the answer from that corner. Cholesterol emboli. Anything else? Yeah, heparin-induced thrombocytopenia. So Doppler right side shows iliofemoral DVT. So heparin-induced thrombocytopenia. CABG was exposed to heparin, is developed heparin-induced thrombocytopenia, and therefore there is DVT. So there are situations where you can have paradoxically low platelets and thrombosis. One such situation is heparin-induced thrombocytopenia. What are the other situations? TTP, we just saw, no? TTP, you can have low platelets, you can have thrombosis. And antiphospholipid antibody syndrome and vaccine-induced thrombocytopenia, I heard that. And that is a very new phenomenon with all our mRNA vaccine. So treatment issues, dangerous or safe platelet count depends upon the clinical context. A platelet count of 30,000 is dangerous for neurosurgery, whereas it's okay for a dental procedure, let's say, scaling or something along those lines. Always find out if they're on concomitant drugs, like aspirin. You have to take a drug history. So and any comorbidities. Prophylactic platelet transfusions only if platelets less than 10,000 or less than 20,000 if they're unwell with fever. So therapeutic platelet transfusion if they are bleeding. So there is I think with that we can finish. So thank you very much. And if you have any questions, I'm happy to answer.
Thank you, Dr. Prabhu, and really you demystified the thrombocytopenia, because after this, a lot of dengue patients, the thrombocytopenia is totally, everybody is getting alarmed and they go for a platelet transfusion, all those things, without looking into all these things. That is very common, and you made it very elaborate and as well as simply understanding to everyone, and it's quite interesting. Thank you very much.
Thank you.
Any questions from the audience?
Thank you very much.
We will close the session. Thank you.
Thank you, sir. Now, may I request our chairpersons to kindly present a memento to Dr. A.S. Mohan as a token of appreciation.
Good morning, everyone. We are happy that we have started in time, and our chairpersons are there. And please, we request our President, Tamil Nadu State Session of API, to give away the memento to the speaker. First, Dr. A.S. Morgan, sir. Morgan. Dr. Raja from Chennai. Dr. Prabhu from Apollo Main Hospital. Please come, sir. I request our President of Tamil Nadu API chapter to present memento to our chairpersons, Dr. Rajsekaran, my dear friend from Erode. And our affectionate friend, Dr. Gunasekar from Trichy. As a token of gratitude, I call upon Dr. Prabhu to the stage. It is customary to felicitate the guest speakers who have come on their own from all the way from Chennai, Apollo Hospital. I request our president to greet Dr. Prabhu with a salve and this. I request our chairman of the organizing team, Dr. Sukumar, to garland Dr. Prabhu, sir. It's a great privilege that we have got several speakers from city and other areas, even including Trivandrum, and it is our duty to felicitate them. Thank you very much. We'll adjourn to the second session. It's a time after the fertile land, witnessed the fertile land in hematology, we are going to sow the seed. We'll be watering to the brain with a lot of scientific materials. Now it's high time that we are inviting our president of Tamil Nadu State Chapter of API, which is the backbone of Vellore District Branch of API, to host this grand event, TAPICON 2025. TAPICON 2025 feels elated and feel garrulous and hilarious to invite our respected president to the stage to perform the oration, presidential oration, Vertigo demystified, a clinical approach for physicians. I request our eminent organizing secretary to read the citation, and I request Dr. Gunasekharan, our secretary, to give the medal to Dr. Balamurugan. Please come to the stage.
It's a great pleasure for me to read this presidential citation for for Dr. N. Balamurugan. Customary to read about.
And for the session, I request Dr. Selvaraj from Tuticorin and Dr. Gunasegaran from Pattukkottai and Dr. Narsimhan sir from Schollinger to be the chairpersons.
It is customary to, before the presidential oration, to give a short introduction about the speaker. Today's speaker, orator, is Dr. N. Balamurugan. The Association of Physicians of India, Tamil Nadu chapter, with great pleasure, is pleased to honor the prestigious TAPICON presidential oration for the year 2025 to Dr. N. Balamurugan, MD, DM. He is the current chairperson of the Association of Physicians of India, Tamil Nadu chapter. Dr. N. Balamurugan studied MBBS in 1992, did his MD General Medicine in 1997, special training in neurology in 93 from Tanjore Medical College. He did his DM Neurology from National Institute of NIMHANS, Bangalore. Dr. N. Balamurugan is the Fellow of Indian College of Physicians from 2015, Fellow of Royal College of Physicians, Glasgow from 2019, Fellow of American College of Physicians since 2021. He is the Director and Senior Consultant Neurologist in the Department of Neurology, SIMS Chellam Hospital, Salem. He was the head of the Department of Neurology in Sri Gokulam Hospital and Manipal Hospital, Salem. He is a teacher, trainer per excellence in neurology. He was a lecturer in medicine at Raja Muttaya Institute of Health Sciences, Annamalai University, Chidambaram, and postgraduate senior resident in neurology at National NIMHANS, Bangalore. Lecturer and reader in neurology for DNB program at Sri Gokulam Hospital in Salem. He was a course director for fellowship in neuro emergency, one-year program by the Indian College of Emergency Medicine between 23 and 24. He is an orator at local, regional, national, and international meetings. He has presented more than 9 lectures internationally, 61 lectures nationally, and delivered more than 125 guest lectures. He has contributed a lot to Tamil medical literature. Few are the books on headache types and varieties in Tamil language, books on Parkinson's disease, and book on stroke, pamphlet on epilepsy written in Tamil language, etc. He published more than 11 publications in medicine update books, critical care update in 2001, textbook of emergency medicine in 2012, reviews in neurology in Dijon, the Dijon neurological examination, localization in clinical neurology by Jose Biller, etc. Dr. N. Balamurugan innovated many first in Salem district, first to administer clotbusters, that is IV thrombolysis for acute stroke, first to start botulinum toxin therapy for movement disorders, first and the only center for deep brain stimulation therapy for Parkinson's. He has received many honors and awards starting from the gold medal in MD General Medicine, Dr. Leela Krishnamurthy Memorial Award, Dr. S.V. Subramaniam Endowment Oration, Ibrahim Bailim Oration, Best Paper Award at Association of Physicians of India Conference in 2005, Best Secretary Award for IMA, Dr. P.K. Kesava Rolling Shield for Tamil work in medicine for books on Parkinson's disease, Nadakku Vadam in Tamil language, Teacher per Excellence Award, Doctor's Day Award, Physician's Day Award from the Department of Medicine, Government Mogana Kumaramangala Medical College, Salem. The Association of Physicians of India, Tamil Nadu State Chapter, takes immense pleasure and honor to award the presidential oration to Dr. N. Balamurugan at the 21st Annual Conference of APA Tamil Nadu State Chapter, TAPICON 2025, hosted by the Vellore branch. Thank you, sir.
With a small correction to what Vertigo was telling, Dr. Balamurugan is chairman of Tamil Nadu API, not president. President is the only president who is all India president. With that, I hand over mic to Balamurugan.
A very good morning to you all. It's both pleasure and prestige to stand before you to deliver the presidential oration as chairman of Tamil Nadu APA chapter. My special thanks to Professor Sukumar, Dr. Satish, and Vertigo sir for the excellent scientific feast and academic lectures. And we go on to the oration topic, Vertigo demystified. In neurology teaching, we always say, where is the lesion, what is the lesion? Suppose the patient comes with facial palsy, we say, is it LMN or human? If it's human, where is it? Is it in the cortex, is it in the subcortical, or the brainstem? Can you tell in the vertigo, if a patient comes with vertigo, can you say it's the cortex, it's the brainstem, or especially vertigo alone? That's a problem with vertigo. That's the reason Barani Society has said it's not a vertigo, it's vertigo as a symptom complex. The patient may come to you with vertigo or dizziness. For all practical purpose, these two things are used interchangeably. Don't split too much because it doesn't give any localization value or any prognosticate value. This is perceived at the cortical level as an illusion of spinning of self and our environment or spatial disorientation. That's all you have to know. In addition, because of its connection to the other cerebellum or especially oculomotor nuclei, they may come with blurring of vision or oscillopsia, especially when they have bilateral cerebellar involvement. So they may go to the ophthalmologist or they may go to the orthopedician with a fall because of its connection with the cerebellum and spinal tract, so vestibular spilum, they have a fall or near fall, or they may go to the psychiatrist because of the problem of nausea, vomiting, sweating, fear complex, or they may go to the cardiologist. So this is a symptom complex. That is the reason it causes confusion or it causes fear among the physicians when a patient comes to the emergency department with acute onset vertigo. So we'll try to demystify. Nearly 20% of ER physicians worldwide report vertigo top priority for developing better diagnostic tool. What do you mean by better diagnostic tool? Whether we need MRI, already done. MRI was there, diffusion weighted MRIs are there. What else we need? Dizzy and vertigo accounts for nearly 5% of ER visits in a common. If it's a neurology, it accounts for nearly 30% of the visits. Among them, nearly 10% are stroke. That's a problem. With this, how to approach acute vertigo when they come to your ER and emergency medicine. And we go with a titrate approach. We don't split with vertigo, spinning, or dizzy, or giddy. So titrate approach is very simple. We have to remember timing, triggers, associated symptoms. We have to recognize only 4 patterns and then targeted examination. So it takes just 4 to 5 minutes to complete your examinations. This is a clinical lecture, and go with the timing. If it is less than a minute, in seconds, think about vestibular paroxysmia, cardiac arrhythmia, benign paroxysmal positional vertigo. If it is minutes, less than 20 minutes, the most common, the prototype here is TIA, it could be BPV. It is minutes to hours, it could be migraine or menias. If it's ongoing vertigo, hours together, the most 2 important differential diagnosis would be vestibular neuritis or stroke. Next is, once you are very clear with the timing, next is trigger. What triggers? When a patient says he gets spinning sensation from getting up from sitting position or lying position, it could be positional vertigo or partial vertigo. To differentiate that, if the patient says even on lying down or turning in the bed, if he gets a vertigo, it is positional. It has to be benign paroxysmal positional vertigo. Whereas if the patient says it on getting up from sitting posture, it is a partial, most commonly it is orthostatic partial hypotension. So with this simple trigger, we can say is it a benign paroxysmal partial vertigo or partial hypotension, because both can present to ER with hypotension or giddiness on standing. So next, with this we can go with pattern recognition. There are only 4 patterns. Acute vestibular syndrome is nothing but ongoing vertigo. They may come at the end of 3 hours, 4 hours, or 10 hours, but they may be having ataxia or nausea, vomiting associated nystagmus. Whereas the same symptoms happens in minutes to seconds or hours, but episodes. When you examine, the patients may be absolutely normal. So with these 2 major, and we have again classified into sub, like acute vestibular syndrome can be toxin-induced, trauma-induced, very easy to make the diagnosis because you know the history. Most often trauma or toxins or anti-epileptic drugs. if it is a spontaneous acute vestibular syndrome, there is no trigger, there is no toxins, then there's a problem. Is it vestibular neuritis or stroke, which is more common? Vestibular neuritis is 5 times more common than the stroke. If it is episodic vestibular syndrome, it could be spontaneous or triggered. Triggered, the best example is benign paroxysmal positional vertigo, and spontaneous, if it is in seconds, think about cardiac arrhythmias. If it is minutes to hours, think about TAA or vestibular migraine or menias. Now, with this, you have 4 symptom complex or 4 patterns. Trauma and toxins we know how to deal with. Spontaneous AVS, the one examination is hints. If it is a triggered EVS, you have to do positional testing. Canal-specific positional testing, canal-specific nystagmus, and canal-specific treatment. That's all. So with this, we can complete all the vertigo, only 2 focused examination depending upon which category you are dealing with. That's the reason the recommendation by academia emergency medicine is that emergency patients should receive training in bedside physical examination technique for patients with acute vestibular syndrome, hints, and if it is episodic vestibular syndrome, Dix-Hallpike test and Epley's maneuver. That's a recommendation, strong recommendation. What is acute vestibular syndrome? From 1998 onwards, this has come popular because when a patient comes to the ER with ongoing vertigo, medically, legally, is it a stroke, whether I should go for thrombolysis or not within 4.5 hours? That question comes. So this become popular. Any ongoing vertigo with nausea, vomiting, ataxia, and spontaneous nystagmus, we call as acute vestibular syndrome. Then you go with hints. Before going with hints, if the patient has obvious central, what mean be stroke signs like motor weakness, sensory weakness, dangerous diplopia, dysarthria, dysphonia, or severe ataxia, or new onset headache or neck pain, very clear you are dealing with stroke. There's no need of going for hints examination at all, isn't it? But if the patient comes to you with isolated vertigo, the frequently asked question is that if the patient comes to with isolated vertigo, ongoing vertigo, no other cranial nerves, so there is a chance that 10 to 20% may have stroke, and approximately 10% of the patient with isolated cerebellar infarction present with isolated vertigo. Where exactly the localization you can fix? Stroke in the following 5 areas may present as isolated vertigo. Again, I repeat, isolated vertigo means there is no other associated cranial dysfunction or long-term signs. If it is the infarct is in the 8th nerve entry zone, commonly happens in anterior inferior cerebellar artery infarct, or if it involves the medial vestibular nuclei and nucleus preposition hypoglossy, or if it involves the cerebellum nodular region or floccular region, or finally, I said that the vertigo is perceived as abnormal illusion in the cortex, so insular cortex. That's the reason some of the patients with stroke, especially middle cerebellar artery, middle branch involvement, they have constant vertigo. So these 5 areas, they can have only vertigo. If it is isolated vertigo, what's the chance of picking up with CT? Very less. MRI, of course, 80% sensitive, 96%, but it can miss 20% of acute posterior circulation stroke if MRI diffusion weight is done within 24 to 48 hours from the symptom onset. Diffusion weighted images misses 50% of acute posterior circulation stroke if the infarct size is less than 1 centimeter in diameter. So what we need now? We need more sensitive, more specific. There comes your hints examination. Hints is nothing but head impulse, nystagmus, and test of skew deviation. If the patient has a normal hints, no corrective seconds, direction changing nystagmus, and test of skew is positive, you are confident that it is a central, it is a stroke. Whereas if the hints is abnormal, that means head impulse is abnormal, there is a corrective second, or if the nystagmus is a peripheral type, unidirectional horizontal or torsional, worsen with the removal of the fixation, or test of skew is negative, you are pretty sure that it's a peripheral. To say central, any one in the yellow column is there, any one positive, you have to say it's central. To say periphery, there should not be anything for the central. All has to be periphery only. So it takes us the sensitivity for stroke recognition 96%. Still we are not happy, so they added one more thing, acute onset hearing loss. I've said that hyperacute hearing loss with vertigo, probably you're dealing with stroke ICA, anterior cerebral. Still not happy, they added ataxia. If the ataxia is grade 2, grade 3, that means they need support or they can't walk without support, grade 2, grade 3, definitely it's a stroke. So now with the hints plus, we can make a clinical diagnosis of stroke nearly about 99 to 100%. That's one message. So, ladies and gentlemen, you should know how to do a head impulse. That's the crux of this particular talk. So here, this is a case present with spontaneous, acute, prolonged vertigo or acute vestibular syndrome. You can see here, I'm doing head impulse, a fast movement, 15-degree alone. So towards the left, nothing, normal. And I am doing it right, you can see catch-up circuit. Are you able to appreciate this? Turning to the right, again I redo it. Initially, first I do a head impulse turning to the left, no, normal, normal. Turning to the right, there is a catch-up circuit. That means head impulse is positive. So this is easier than your Babinski. It is more specific and sensitive than your Babinski. And you should learn this because this helps you to say, is it a central or peripheral, whether you have to go for thrombolysis or not, because in the era of thrombolysis, it has a medical, legal significance. This patient had, in addition, left beating horizontal nystagmus. You can see here. Spontaneous nystagmus, I'm sure that you won't be able to appreciate. When he's looking towards the right, no nystagmus. Whereas when he's looking towards the left, there is a left beating horizontal nystagmus with a mild torsion component. But when I removed the fixation, when we took the patient to the vent, you could see even the spontaneous, looking straight, he's having a slight left beating nystagmus. So removing the fixation, the grade increases from 1 to 2 or 2 to 3. So this patient have grade 2 horizontal nystagmus with a torsional component. It tells that this is more likely a peripheral one, and this patient was not having any ataxia, able to do a tandem walk. So this says that this patient is having hints towards periphery. So this is vestibular neuritis. Whereas the case 2 presenting as again spontaneous AVS, here this patient is having a normal head impulse to the right and left, and he has, so normal head impulse takes me towards the central, but the vertigo, this nystagmus is unidirectional, horizontal. So unidirectional, horizontal, it could be central or peripheral. So this I put towards the periphery because it's unidirectional. It is not direction changing, so it's periphery. But this patient had obvious Q deviation. You could see here, one is up, another is down, in addition to the nystagmus. So this patient needed support, the grade 2 nystagmus, so grade 2 ataxia. This tells some of the features are for central and only one for periphery. You vote for central or periphery? When this picture comes, any one positive in the central, it's central. Any one positive, any one tick in the central has to be considered central. This patient had a strategically located an infarct in the pontomedullae. That means the entry zone of vestibular fascicle. That's the area that causes this much symptom, but it can be easily missed if MRI done, even if the diffusion variant images within 24 hours. So these patients may have a block in the basilar artery. We are worried about that, not with the small infarct. That's the reason these hints become popular over the last 10 years, and every emergency physician should know about the head impulse, which is very easy when you perform routinely. With these hints, we have completed the first column. And now we go with triggered episodic vestibular syndrome. When it's triggered, that means some position. We have 3 semicircular canal, and do you have audio? Okay, so we have 3 semicircular canal, and lateral and anterior and posterior. Semicircular canal has endolymph. There won't be any particles. But the utricle has the particles. The utricle, when there is a damage in the utricular system, so this happens, the particles may enter in any of the semicircular canal. When it enters the semicircular canal, it produces nystagmus. When it's not moving, there is no nystagmus, there is no vertigo. So when the patient comes to you with intermittent vertigo, you have to move the particle. How do you move the particle? We have to put a particular position. That's the reason I said the canal-specific positioning, we do that. The best for posterior canal and anterior canal is Dick-Salpik. The best for horizontal canal is supine roll test. So here, I'm putting the Dick-Salpik, turning 45 degrees to the right, right Dick-Salpik, and down nearly 135 degrees. You could see a beat right torsional. Once I put in that particular position, there was no nystagmus spontaneously. There was no vertigo. he was having intermittent vertigo episodes. I have precipitated, triggered by doing Dixalpic. So once, again I show that because most important, we should learn how to do a Dixalpic. Just now you see again carefully. Within few seconds, after latency of few seconds, you get an upbeat and right torsional. It tells it's the right posterior canal BPV. And I go with Siemens rather than Eplis because Siemens is easy. At our couch itself we can do. We don't need a bigger cot. When it's the right posterior canal, the Siemens laboratory maneuver. So ask the patient to lie on the right. The right occiput and ear has to touch. So you can see here. So turn and right occiput and right ear has to touch. Just look up. So he'll be getting nystagmus. This is called Siemens diagnostic. So that also again will be a bit right torsional. So telling the right posterior. So once it settles, that means the particle has moved. You have to shift the patient 180 degree to the other side where he has to lie on a left eye and left frontal region. That's all. The all particle will come out of the posterior canal to the utricle. That's the purpose of this positioning maneuver. So now this is the most important step. It has to be very fast because we need an inertia to move this particle, and Siemens is this is a fast way, and the eye and frontal region of the left has to be down for 2 minutes. That's all. You can do it 3 times. 80% of the patients say that this got absolutely relieved. So 20% they need repeated maneuvers. So sometimes we go for Epis when we find difficulties, or when you have a broader bed, you can go for Epis. This is a lab that where the advantage of having a lab is that you can see the nystagmus, you can see the particle moving in terms of them. The particle is moving, I could see the person is having nystagmus. When the particle moves, it stimulates the hair cells. When the hair cells stimulated, it produces nystagmus. So I can see that whether the particles are moving or not. I have put the Dixalpic. So you could see that again, a beat, right torsional nystagmus. Yeah. So then from there, Dixalpic is converted into Eplis. So from there, we can shift to 180 degree, and then again 90 degree nose down. This is Eplis. Eplis, we need a broader bed, and then patient should be comfortable. So, but Eplis was the first procedure for invented or advised for posterior semicircular canal. Now we go for Siemens or extended Siemens. And practical tip is that when you see that the person is having a position vertigo, you put the Dixalpic, you are not getting. So still you are confused with the Dixalpic or not. I always say that wait for 30 seconds. So you have to wait for 30 seconds because the otolith starts moving slowly. It needs inertia. See, I have put the patient in Dixalpic. There is no nystagmus at all. Wait, wait, wait before concluding that Dixalpic is negative. So at the end of 22 seconds, you could see person having a robust upbeat right dorsal. So why the delay? Because the particle has to move. It needs an inertia. Now you could see here. Immediately, if you bring the patient back, Dixalpic negative, don't say that. This is a common mistake I say that, and they said Dixalpic is negative. So you need a patience of at least 30 seconds. Beyond 30 seconds, it means that it is not a posterior canal. Sometimes it may not be possible to elicit in the bedside because you have the lights. So we have to remove the fixation. In lab, we remove the fixation, and this is a way that you can see how the head goes down. Then 1, 2, 3, 4, 5. Yes, after 5 seconds, you can see the upbeat and right torsional nystagmus. So these are the 2 practical tips. When clinically you are not able to wait for 30 seconds in the Dixalpic to get that nystagmus, or remove the fixation by Fresnel goggle or a bright torchlight, or when you are recording with your cell phone, I ask them to put the lights on. When the lights are on, they can't see anything. So you are removing the fixation. That's the easy way of doing it rather than the lab. So 80% of posterior benign paraxional positional vertigo are posterior semicircular canal. Another 10 to 15% are horizontal. Horizontal posterior semicircular canal, they have nystagmus when they turn around, right or left. This patient is not having nystagmus when he is sitting supine, no spontaneous nystagmus. I made the patient to lie down, so no nystagmus, looking right and left. Now I am asking the patient to turn right. Now you could see a violent right beating nystagmus. That means I am stimulating the right horizontal canal. It produces a right beating nystagmus. So this is beating towards the right and towards the ground. We call this a geotropic nystagmus. This lasts for about 40 to 60 seconds and it settles slowly. And when I take the patients towards the left, shifting to the left, it is left beating. So you can see here, now I am shifting, turning the patient, not asking the patient to look left, turning the head to left. Turning the head to the left is a semicircular canal. So you can see that here left beating. So on turning to the right, right beating, on turning to the left, left beating. So it is called position related direction changing. It's not direction changing alone, it is position related direction changing, what we call geotropic. It indicates the person is having horizontal canal BPV. So I would stress you focus on posterior canal dexalpic. If it is negative, if the patient says that when I roll over, I have a nystagmus, that's probably horizontal canal you can do. And the maneuver that we advise is Guffoni. Want of time I have not put that particular video. Once you are clear about the episodic triggered, then episodic spontaneous. I call this is a little bit dangerous because when episodic spontaneous happens in seconds, think about arrhythmias. So highly recurrent vertigo, dizzy. So people say that vertigo sensation won't happen in pre-syncope. No. Cardiac arrhythmia should be considered in any patient with spontaneous EVS, even if the presenting symptom is true spinning vertigo. And the next one is Minister of us commonly asked question to me is that could it be TIA, sir? VBA, TIA, recurrent vertigo. 50% of the pre-monitored TAs of posterior circulation stroke are isolated vertigo. Among them, again 50% had vertigo more than 1 hour. The new definition of TIA, earlier we used to say 24 hours, now it has come to 1 hour, isn't it? So this is not obeying the new definition also. The TA of posterior circulation may last more than 1 hour. So generally, TA lasts less than 20 minutes. So we have the leverage till 1 hour for all thrombolysis purpose. This TAA may last more than 1 hour. TA in ICA distribution causing labyrinthine ischemia may cause acute onset auditory symptom, so that we may be thinking hearing loss, vertigo, Meniere's, but it could be TAA. Similarly, they can have a neck pain with vertigo. It's not cervical spondylosis, it's vertebral artery dissection, or it could be Meniere's, especially when they have photophobia, phonophobia. So when a patient comes to you with spontaneous episodes of vertigo, chronic episodic headache, we think migraine, chronic episodic vestibular symptom, we think it's Meniere's. When both are there in a patient, it is vestibular migraine. Because vestibular migraine is yet underdiagnosed cause of episodic vertigo, 10 times more common than Meniere's. That's the reason otoneurologists or neurotologists say that before treating Meniere's, treat as vestibular migraine. It's a treatable one. Second, the timeline you have to ask is that typically in childhood they would have had travel sickness, and 20s, 30s they may be having migraine, they would have forgotten about the migraine episode. In 40s and 50s they come with episodes of vertigo. So this is a very classic of vestibular migraine, and this is one type of vertigo with a variable duration from minutes to hours to days, and this one type of vertigo has a severe motion travel related sickness, and when they go to the mall, when they see escalator, when they see the movie, they have vertigo and headache. Ask the patient to take selfie video at home during the attack. This is a way that when it is spontaneous, you are not able to see anything, let it be epilepsy or any other phenomena. Tell that because everyone is having a camera. So ask the patient. So here is the patient who had absolutely normal when I was examining. So working diagnosis was episodic migraine and vertigo. I thought it could be a vestibular migraine. And he said that I get severe attack once in a month. So I said, better you record it. So it is at home. So he had the attack. Immediately, he asked his daughter to record. You could see During attack, he is having a left beating nystagmus. This lasts for about 1 minute. So in addition to that, he had photophobia, phonophobia, and severe neck occipital pain. This suggests that this is a vestibular migraine. I think with this, ladies and gentlemen, the carry-home message is very clear. When a patient comes to the vertigo, try to localize. Is it peripheral or central? In terms, is it stroke or not stroke? That's our question. So go with titrate approach. Don't try to split these symptoms. Is it dizzy, giddy, vertigo, spinning of self or environment or surrounding? Nothing. So go with the titrate approach, timing, trigger points. Then you have 4 groups: traumatic acute vestibular syndrome or toxin acute vestibular syndrome. The next group is spontaneous acute vestibular syndrome. In spontaneous acute vestibular syndrome, you have 2 important major areas: vestibular neuritis and stroke. Though vestibular neuritis is common, 5 times common than the stroke, stroke, you know, the medical and legal implications if you miss during thrombolytic period. Second, episodic vestibular syndrome, again, you should be able to differentiate. Is it triggered? If it is triggered by head movement, it is benign paraxial positional vertigo. If it occurs spontaneously, the 2 important things, if it is in seconds, never forget the cardiac arrhythmia. We go for Holter if the ECG was normal, and we pick up this type of spontaneous EVS. Minutes to hours, we are worried about TAA, but the most common in this group is vestibular migraine. I think this red one is 3 things we have to be very careful in our evaluation. And hints and positional testing is the crux of my oration. With this, I thank my team for the recording, and I thank the TAPICON, all the organizing team, and all the delegates for your patient listening. Thank you all. I can take up questions, though orations generally say that the questions should not be asked. So,
You can ask personally.
no question, I understand, sir, because we have students. I'm ready to talk, because we have another 2-3 minutes time. I can do that rather than.
Thank you.
Because this is the clinical neurology. Still, we have a clinical neurology. I have not put any diagnosis based on the MRI or any other imaging.
Thank you, Dr. Bala Murugan. As it is a oration, there is no questions, but still he has agreed for questions. 1 or 2 questions are allowed.
I am in the medical field for more than 50 years. I am serving in the rural area. Nowadays, for the past 20 years, I am seeing a lot of vertigo, daily 1 or 2 cases, especially the rural population. They are doing a lot of works. The BP is usually 90/60. The patient is all right. Whenever I turn the patient, they feel giddiness. Then if you turn the patient the opposite side, all right. What is the treatment I can give? I usually give IV fluids and Vertin tablets. They are all right. And CT scan done, everything is normal. What is your opinion? Why we are getting a lot of vertigo cases in rural population? They are doing a lot of works in fields.
Yes, sir. Thank you. That's a good question that when you start seeing more and more vertigo, it means that your practice is picking up. That's one thing. So you're having a maximum number of patients, so that relatively the more vertigo you see, that's one thing. Second, we get more migraine now, more and more migraine in 20s, 30s because of the stress factors. So the stress factor of sleep disturbance, the stress factor of travel, and dehydration, the migraine. That may be the one reason. But Sad has said that, gave me the clue that the BP was on a lower side. So when you have a BP on lower side, the person may be having autonomic dysfunction, especially in the elderly population. You can do a tilt test examination. If the systolic BP drop 20 or more than 20, or the diastolic BP drop 10 or more than 10, you can brand them as a partial hypertension. One of the important causes, it could be drug-induced, it could be dehydration, or it could be autonomic dysfunction. That's the one thing you have to address. Second, when they have nystagmus or vertigo, when you turn right and left, it cannot be partial. That's the message I told you. When getting up having a vertigo, it could be partial hypertension. Lying down in the bed, turning right and left, it is most likely posterior canal or horizontal canal. You can do this maneuvers, very simple Dixalpic or supine roll test, and you can make the diagnosis. Whenever they have vertigo, in my first slide I said that it is a vestibular or vertigo symptom complex. Whenever they have vertigo, it stimulates your limbic system, it stimulates your reticular formulation. Invariably, they will have nausea, vomiting, fear, sweating, and hypertension. Yeah. During that episode, don't give much importance. So they may be having a transient drop in the BP or transient rise in the BP. Thank you, sir.
What is the treatment you can give now?
So treatment, I said that depending upon, if you are dealing with positional vertigo, benign fractional vertigo, posterior canal, the treatment of choice is either EPIs or CMONs, nothing else. If it is a horizontal canal, you can go for your Guffoni. If it is a horizontal canal of apogeotropic, you can go for Appiani. So these are the maneuvers. I say repeatedly, benign fractional positional vertigo is the only disease you can make diagnosis at bedside, you can confirm at bedside, and you can treat at bedside, and you can cure at bedside. No other disease you can do at bedside itself. All those things you need a lab or some scan, or you have to ask the patient to take medicine. It's the only disease you can diagnose, you can confirm, you can treat, and again you can confirm. But we have to learn about your EPIs maneuver or CMONs maneuver in the posterior canal. Posterior canal is common. If you learn the posterior canal, that's enough for your practice. Thank you, sir.
Thank you.
Sir, one question. A patient presenting with vertigo, I strongly suspect clinically TAA. You touched upon the topic of
TAA and stroke.
legal problem. So, legal issues.
Legal, yes, yes.
Legal issues. I strongly suspect TAA, but without documenting any evidence, based on clinical suspicion, can I thrombolize the patient?
Yeah, this is a wonderful question, but the person had TAA, we are supposed not to do thrombolysis. If it is an ongoing stroke, we have to do that. So if I think Sir is asking that person has come to you with 3 hours of ongoing vertigo. So you have to do CT, it will be normal because it's a posterior circulation, you do an MRI, I said that 20% of the MRI may be normal, even diffusion weighted images may be normal. If you have hints towards central, you have to do thrombolysis. That's the reason I stress that. So the MRI, nothing else. If you have done hints, you have documented the hints is towards central, you are justified and you are supposed to do thrombolysis. If it's a TAA, that means that the person has recovered. That's the thing that you are saying, that the person has recovered. It is a transient. In the situation that you have to evaluate for the cause for TAA, whether the next TAA will come or not, you can start an antiplatelet, or whether there is a tandem occlusion in the basilar artery, which is dangerous, that we evaluate with angio.
No more questions. We profusely thank you, sir. Thank you very much.
Again, once again, I thank TAPICON organizers and all the delegates for the excellent opportunity given. Thank you all.
Thank you, sir. Announcement. The final round of the quiz is taking place in Focus Hall. It will start by 10:30 a.m.
Next, I invite Dr. V. Palaniappan, our academic committee chairman. I am going to talk about secrets of living to 100 with type 2 diabetes in rural India and 3 decades of experience to evidence.
Good morning, ladies and gentlemen. Thank you very much, Dr. Vetrivel, Sugumar, and Dr. Sadish, entire organized team, for giving me this opportunity. Thank you very much, chairpersons, for their kind introduction. Today, my topic is living to 100 in rural area with diabetes, my 3 decades experience to evidence. The previous. So, as per 2012 statistics wise, the Indian longevity is only 66 years. Now it's around 69 years actually. Next slide. So, we have to live to 100 even with the diabetes, how to do that. So, here the major important 3 globally, actually Japan, Hong Kong, Iceland, they are living more than 80, 82 years. But how to live to 100 in India? Yeah, next slide. So next, even with the diabetes as well as pre-diabetes also, because pre-diabetes also equally important, you have to give importance. Then only you can prevent macrovascular complication. Yeah, next slide. So remission of the type 2 diabetes or pre-diabetes is the need of the hour. If you do the remission, you can actually the remission is possible. You cannot reverse the diabetes. You can get a remission. If you have a remission while treating diabetes and pre-diabetes, it is possible. Why it is need of the hour? Next. Because diabetes is equivalent as a first heart attack. Heart attack. Diabetes and the first, which considered the first heart attack. Within 7 years, the second attack chances is 20%. If the patient is not having diabetes but having MI, the next attack will occur within, chances for getting the next attack will be 20%. That's why diabetes is considered as a coronary heart disease equivalent. Next. And the Asian ethnicity actually is a high risk ethnicity, and acute coronary syndrome, it occurs 10 years earlier than the Western population, and 40% of the acute coronary syndrome occurs less than 40 years old, and 25% of the sudden cardiac death occurs in the less than 40 years old. So 70% of the type 2 diabetes mellitus people in India, they are dying due to the coronary artery heart disease. And here treating the diabetes is important. Even pre-diabetes and pre-diabetes also very, very important, because subclinical atherosclerosis develops even 10 years before development of the type 2 diabetes mellitus. Next slide. So subclinical atherosclerosis develops even earlier during pre-diabetes and pre-diabetes itself, because in India it's one of the important capital for the diabetes and coronary artery disease also, and 25% of the death in India due to the cardiovascular death, and 100, that's a 10 crore population, it's a diabetes incidence, around 11 crore population they are suffering from the CKD, 1 crore population they are suffering from the heart failure. Next. And diabetes, if you want to live to 100, definitely in the management of type 2 diabetes mellitus, you have to treat all 8 etiologies. And here, can you get the remission? Definitely it's possible, because at the time of type 2 diabetes mellitus, almost 50% beta cell are already gone. So you have to preserve the remaining 50%, then only you can prevent, you can get a remission, and you can prevent future macrovascular complication. And here nowadays in the diabetic management, glucose management is not that much important. All pre-diabetes and type 2 diabetes mellitus patient, you have to reduce the weight, you have to reduce the weight loss is very important, and obesity management is much more important than, equally important in managing not only the glucose level control, you have to reduce the weight, obesity also should be addressed simultaneously, then only you can get the remission. And here remission, usually remission is possible when the type 2 diabetes mellitus duration is less than 6 years, not on insulin, and obese population you can get a remission better than the lean population. There are 5 clusters of diabetes. Diabetes is there actually. Severe autoimmune diabetes, severe insulin resistant diabetes, severe insulin resistant diabetes, and deficient diabetes and resistant diabetes, mild obesity diabetes, and mild age-related diabetes. Here MOD, MARD, completely you can get a remission. Its remission is possible. But SIRD, to some extent you can get it. But severe autoimmune, you cannot get it. Insulin deficient also, you cannot get the remission. So here SIDD, more prone to develop retinopathy, and SI resistant diabetes usually more prone to develop CKD. And MOD is a mild diabetes, you can manage with lifestyle therapy with oral anti-hyperglycemic medication. So what is the criteria? These are all the various criteria. It's published in 2021. You have to reduce the A1C less than 6%. Pre-diabetic remission means 6 to 6.4, and remission, and again you can get a relapse if they are not adhered to the lifestyle therapy. And remission is possible with lifestyle therapy, bariatric surgery, and metabolic surgery and pharmacological therapy. And actually they did Professor Roy Taylor studied in 2008 study by twin cycle hypothesis. And counterpoint study, very low calorie diet, 600 kilocalories per day, he has published in 2011 study. So main type 2 diabetes mellitus because of fat accumulation in the liver and fat. That is the main culprit for development of the type 2 diabetes mellitus. If you reduce fat content in the liver and pancreas, definitely you can achieve the remission. So that's the main culprit. It was studied by Professor Roy Taylor. And here pancreas and liver dry acylglycerol, if you reduce, you can achieve the remission. So by this counterpoint study, they gave 600 calories. It's a very low calorie, more prone to develop sudden death, kidney failure. That's why it's failure later on. So very, very low calorie diet, that is 600 calories. Actually with this 600 calories, they can able to reduce the fat content in the liver and pancreas. So hepatic, actually it inhibits the pancreatic inhibition in the triglycerides, and actually fasting plasma glucose also reduced, hepatic glucose output also reduced, and hepatic triglyceride contents also reduced, and pancreatic triglycerides reduced, and first phase insulin suppression is improved with the low calorie diet, and fat content in the both liver and pancreas is reduced by doing the MRI scan. And remission is possible with intermittent fasting also, and very good hydration also. Because in ancient grandma, grandfather, usually they will take only 2 times a day. 12 hours gap will be there. This also you can get a remission. Because fasting, intermittent fasting 2 times a day instead of 6 times a meal actually decrease the gluconeogenesis, and weight also reduced, and fasting C-peptide also improved, and A1C reduction, fasting glucagon also reduced, and fasting plasma glucose also reduced, and MCR also reduced, and OGIS also reduced, and resting energy expenditure also reduced with 2 times a day. So intermittent fasting, if you advise, they can live to 100. And hydration, adequate hydration, excess 2 liters of water if you take, actually HEK1 is the main culprit. If you suppress HEK1, definitely you can reduce the weight by 2 kg over 1 year duration, unless it's contraindicated. And remission is possible with lifestyle intervention, because suboptimal intake of suboptimal intake of food, diet is the main cause of the type 2 diabetes mellitus. So diet is very important. It has been studied in the 184 countries. What are the suboptimal? Increase intake of that is refined rice and wheat, and processed meat, unprocessed red meat, and sweetener beverages, and potatoes. More intake of potatoes, especially in the North India and East India, and fruit juices. It is you have to reduce these 6 important things. You have to increase the 5 important diet, that is whole grains and yogurt, fruits, whole fruits, and non-starchy vegetables, nuts and seeds. If you modify these 11, definitely diabetes will not come. Even if you get a diabetes, if you follow this dietary pattern, definitely you can get a remission. And direct trial published in 2017, it's a open label cluster randomized study. It's a robust study published in 2018. Here actually 23 patients intervention, 26 control. Here type 2 diabetes with hypertension, no diabetic drug, no anti-hypertensive drug. They have put them on 825 to 850 calories per day for over 2 months, and slowly increase the food, started increasing the food. With this study, it was done in England and Scotland, and with this study, they can able to reduce the weight by 15 kg. 86% people, they achieved 15 kg weight loss, and 46% over remission over 1 year, and 78% people, they are actually off, no anti-hyperglycemic therapy, these people. So it's a robust study published in 2017, and stronger scientific evidence. And the metabolic remission also possible with the metabolic surgery, bariatric surgery. With all this surgery, we can get a robust evidence. But after that, the recently, whether medical therapy is superior or surgical therapy is superior, lot of debates are going on. Definitely, I vote for the medical therapy. But surgical therapy, earlier study, 1995, 83% remission. In 2009 study, it shows 80% remission. 2009 study also 46 remission. The diabetic duration is less than 5 years. You can get the remission with bariatric surgery by 95%. 5 to 10 years, 75%. If it is more than 10 years, definitely 54% remission is possible. But various side effects, surgery, one important Cinefield person after bariatric surgery died. Still, the doctor is in the litigation. And lot of sepsis, all that thing, and long-term vitamin deficiency, vitamin B1, B12, and gallstone prone, protein deficiency, everything is possible. And anti-obesity drug actually, remission, actually pharmacological intervention is possible. Nowadays, lot of drugs are available for the anti-obesity. With the anti-obesity drug, you can get a remission. So what, actually, it's a misnormal remission if you use the drug, but actually it's possible. So here, nowadays, if you know metabolics, if you reduce the weight, if you reduce the obesity, you can get the remission of the diabetes. So management of type 2 diabetes mellitus, weight reduction, as well as you have to reduce the weight. Here, you have to address the stage 1 obesity. Actually, overweight 23 to 25 itself you have to address. And adequate sleep, quality of sleep 7 to 9 hours. And important thing is smoking cessation, quality of sleep, and medication, proper medication, physical activity 5 days a week, 45 minutes per day, 5 days at least a week. And all 40 years people with the type 2 diabetes mellitus, before advising any exercise, do TMT and cardiac, whether the cardiac side is normal, then only they have to advise all the type of resistant exercise. And stage 2 obesity, all type of ABCD complications should be addressed simultaneously, then only they can live to 100. Because A to Z actually, HUF-REF, hypertension, obesity, dyslipidemia, OSA, asthma, COPD, GERD, or gallstones, MAFLD, and that's any CKD patient, CKD stage 1 to 5, all the thing, OAKJ, subfertility, PCOS, all the things you have to address simultaneously when you are managing the obesity, adiposity. Because ABCD complication should be addressed simultaneously, then only these people will live to 100. And nowadays, lot of drugs are there. Oral semaglutide, 100 rupees, and it's available. 3,714 milligram. It's available. You can get a 10 kg weight loss. Injectable, you can get better benefit. Liraglutide, dulaglutide, all the things is available. Nowadays, that is GLP-1 and GIP combination agonist actually, that is tirzepatide is available. You can get a remission of diabetes in 65 to 81%. And you can live to longer if you, these countries they are living. The main secret behind that, move naturally, right tribe, right outlook, eat wisely. And vegetarian diet, lot of fruits, lot of vegetables, nuts, and excess intake of water, and move naturally, and downshift. Avoid the stress. Stress is the inflammation. Downshift. You have to reduce the workload, work less, slow down, take vacations, and a small plate, you take lot of fruits and avoid nuts. Everything. You have a lot of nuts and fruits and all these things, and 20% less if you eat, they will live to 100. Wine also, this is an antioxidant with low quantity. And identify your inner circle and family first. Work-life balance is very, very important to live longer, and have more sex to live to 100. And stress management also very important. All type of exercise depends upon the target organ damage you have to give. Flexibility exercise, especially elderly people. And live to 100 is a very, very important thing is actually poor adherence to the therapy. Inadequate adherence to the therapy. They are keep on changing. They are skipping the medicine for weeks or 2 days. So inter-day BP variability, glycemic variability, lipid variability only kills the patient. So adherence to the therapy is very important. Forgetfulness is very, very common. Morning they are not taking, evening only they are taking, afternoon I have forgotten, shall I take the medicine? Even afternoon you take the morning medicine, no issue at all. And hypoglycemia, don't use the sulfonylurea insulin yearly. Only yearly insulin therapy is indicated in the newly detected type 2 diabetes mellitus. You ought to use, if the patient is having ASCVD, lifestyle therapy, SGLT2 inhibitor, then only metformin, after that DPP4 inhibitor, AGAs like that. So don't overuse sulfonylurea where it is not required. It should be the fourth choice or fifth choice. In our hospital, this is my clinical practice. That's why in my rural area, there are many people without sulfonylurea. They are taking more than 25 years. They are taking anti-hyperglycemic therapy without sulfonylurea. They are living more than 25 years in my clinical practice. At least 50 patients they are living like that. So this is my practice. So sulfonylurea, fourth choice. Insulin also fourth or fifth choice if necessary. When there is a requirement in the sick days or acute kidney injury, definitely insulin has got a role. After that you have to switch over to all the thing. So this is all the secret began, and all the type diabetic patient or pre-diabetic patient adequately vaccinated with influenza, COVID and pneumococcal vaccine, all 2 vaccines, and zoster vaccine, TAB and hepatitis vaccine. To conclude my talk, so live to 100 in pre-diabetes and diabetes. So important thing, many times they will not adhere to the diet. You change such a way, give the medication, adequate metformin. Automatically, instead of 8 idlis, they will take only 3 idlis. And take adequate dose, tolerable dose of metformin. HLT2 inhibitor will reduce the weight. If patient is affordable semaglutide and injectable, purely depends upon the pocket money, then only they can live to 100. And initial management itself, all executive mast cell checkup with whether the patient is having macrovascular complication. According to that, you have to select a therapy. The SGLT2 inhibitor, if you don't prescribe, you are actually under litigation. Like that, it will come. Even type 2 diabetes mellitus, nowadays, primary prevention, not aspirin, it's a statin is the primary prevention. Nowadays, in type 2 diabetes mellitus, that's a target LDL should be less than 50, not 100. So primary prevention drug, the number 1 drug is statin. Statin is underutilized. So even the lipid profile is normal, put them on statin to live 100. So thank you very much for the patiently listening. Thank you very much. Any questions?
Dr. Palaniappan sir, 100 ஆண்டு காலம் வாழ்க, நோய் நொடி இல்லாமல் வாழ்க.
Thank you, sir. Any questions, sir?
Thank you, sir.
No questions. We will close the sessions with immense thanks to Dr. Palaniappan.
Thank you, sir.
Over to the organizers.
Thank you, sir. It's our pleasure to welcome Dr. Jyotirmoy Pal from Kolkata, National President, API.
I now invite our chairpersons to present a token of appreciation to Dr. N. Balamurugan. I request Balamurugan to present a memento to our esteemed chairpersons in appreciation of their presence and support.
Mm-hmm. 20 minutes. 20 minutes.
With that, we conclude and invite you to join us for the next session, session 3, Budding and Maturing, Guest Lecture and Oration. Now, I request the chairpersons, Dr. S. Sukumar from Vellore, Dr. Ald Ilanjeriyan from Chengalpet, and Dr. Palanivel Rajan from Pattukottai to chair the session on budding and maturing.
Good morning all. We welcome you for this session.
I request Dr. N. Subramani, Dr. Satish Kumar K. to chair the session.
So I take immense pleasure in welcoming Dr. R. Gopinath sir from Madurai, senior physician, to present the topic Management of CKD by a physician. Over to you, sir.
So good morning, respected chairpersons and dear audience. At the outset, thanks to the scientific committee, organizing committee, and special thanks to Vertigo for this golden opportunity. The topic is very important because there is a huge imbalance between the nephrologist community and the CKD population in India. So every physician, practitioner must know this management of CKD to a certain stage. This is very important slide starting. So the people must be checked for renal function every year. Very important. The diabetes stands first. So very important slide. These are the people. Of course, there will be some more population, but these are the very important population who should be checked for annual renal function. This is again very basic. What do you have to check? You have to check for markers of kidney damage or GFR. This is the latest 2024 guideline. And next is very important is albuminuria. Again, the standard criteria. You can have two things. You can have excretion rate. Either you can have excretion rate or you can have albumin creatinine ratio. There are two things. But we more follow this ACR, and there are different units, milligram per mol and milligram per gram. Don't get confused, but this is very important. Don't go for any other parameters. The different labs still follow some different things, but this is the latest. Or sometimes you can have what is called protein ratio, protein excretion rate or protein. What is the difference in albumin and protein? Protein is non-specific. So many things can be excreted, but albumin is glomerular. So albumin is very important. But not all albuminuria or proteinuria is kidney disease. There are some non-specific factors which will produce transient proteinuria or albuminuria. This is a very important list. Transient proteinuria, you must rule out these things. And this is again a blunt slide. After making a diagnosis, place your patient one of these rectangles. Very important slide. The numbers indicate how many times you have to see the patient, and the colors indicate the severity. And the word even is there, refer. This is very important. You have to know when to refer to your nephrology because of this medical legal issues. If you refer very late, if the nephrologist put a word, you come to me very late, you will be in soup. So this is a very important slide. This is the most important slide. You have to place your patient after diagnosing in one of these rectangles. Causes of CKD, multiple, but most still important is diabetes, hypertension, and drug-induced. And this is also called CKD of unknown etiology. For example, impure water, environmental pollutants, pesticides, so many things are there. You have to little work hard to diagnose CKD as a basic physician. But what is most important is look for retinopathy. Retinopathy will give information. There is retinopathy, you must be a diabetic or hypertensive. If there is no retinopathy only, then you have to work hard to find out diagnosis. This is very basic. Don't refer to a nephrologist without doing an ultrasound for any CKD patient. It gives a lot of information. So every abnormal parameters must undergo. And this is unfortunate. Symptoms of CKD. I don't know why God created like this. Up to 90% of kidney function may be lost before any symptom comes in. That's why don't look for symptoms. It's only a doubt. But there are symptoms attributable to this, what is called manifestations of CKD. There are so many non-specific, no symptom is specific to CKD. So many non-specific symptoms. It's only your clinical acumen. You have to doubt and do the renal test. Coming to the point, what are the aims of management of CKD by a primary care physician? This is for primary, not for nephrologist. The 6 pillars of aims of management of CKD by your physician. Look at the first point. Just delay the progression. You will do 90% of the job. Delay the progression. Very important. Avoid cardiovascular risk. Avoid drugs. And identify patients who need replacement therapy and manage complications. The first 3 stages belong to you. The first 3 stages belong to the primary care physicians. And this is the basic. The foundation is primary care. And this is a very important slide. Up to how much GFR you can manage as a preclinical. It is roughly about 45 ml of GFR. At the maximum, you can keep the patient with you. After that, please refer to your nephrology friend, because delayed referral causes a lot of complications. Delayed referral, believe me, make it a point. Coming to the my topic, proper strategies to record progression. So many things, this is a very important slide. So many things will take part in progression. So many things. This is called Women's octet. Of them is some are non-reversible, that is male, sex or genetic factors, but majority are reversible. For example, lifestyle, drugs, kidney factors, and systemic diseases like hypertension, diabetes. So please make a note of this, where you can intervene and avoid acute kidney injuries. This is a very, very important point. Lifestyle modification, diet, blood pressure control, glucose control, nephro-safe drugs, nephroprotective drugs. This is very important. This is what the primary care physician has to do. Strategies to delay CKD progression. And this is a very important slide. Preference to plant proteins. than animal proteins because they delay the CKD progression and also reduce the incidence of hyperkalemia. Again, the acidosis rate is less with plant-based proteins. So this is very important. This point you have to emphasize to the patients. And coming to alcohol, there is no specific indications. Better avoid or moderation. This is the most important slide. The nephroprotective drugs. A physician must know the 5 pillars of nephroprotection by a primary care physician. The RAS blockers, statins, SGLT inhibitors. The first 3 drugs on the left side for any CKD population. The 4th and 5th are for diabetic CKDs. Very important slide. Spend some time here. The most 5 pillars of pharmacotherapy of CKD progression retardation. And you have to start earlier. These drugs should be started very early. Don't start at 30 ml. You have to start it at 60 ml or 70 ml. Then only they play a major role. And hyperkalemia, please check potassium once in 3 months or 6 months. If it is more, don't play. Please refer to your nephrology. And diabetic kidney disease is still the first. Still the majority is DKD. 50% of diabetics have got kidney disease. So please use these drugs. Keep it in mind. These are the nephroprotective drugs in diabetic population. There are 7 drugs. The latest recommendation. The 7 drugs nephroprotection for diabetic kidney patients for a primary care physician. Metformin, we had a nightmare. We thought it will produce lactic acidosis. We'll be surprised. It is antifibrotic. The latest paper says metformin is antifibrotic for kidneys. That's why the guideline is now up to 15 ml. Up to 15 ml of you can use this drug. It's a new point now. We are about 30 ml. Up to 50 ml, 5 milligram OD can use. Avoid this nephrotoxic drugs, at least transiently. You have to stop doing the acute stress so that you can protect the kidneys. What is called sick day management for any kidney patient. Avoid acute kidney injury because they worsen the CKD. These are the factors for acute kidney injury. And you'll be surprised, a big list, this list may be incomplete. Nephrotoxic drugs. You'll be surprised that is PPI. There is a PPI here. But the market is flooded with PPI. Every specialty uses drug. Unfortunate. PPI are not kidney safe. Know this point, it can produce kidney injuries. And these issues are common. You have to manage by the primary care physician. Acidosis, of course, you have to refer. Please monitor the bicarbonate. When it touches 22 or 20, start bicarbonate. Anemia, you can give only maximum oral iron or IV iron or blood transfusion. Don't give this erythropoietin stimulating. This is all the job of the nephrologist. Depression, no specific recommendation. You can use any drugs. Hyperuricemia, unless it is symptomatic, do not interfere. Hyperkalemia, dangerous, life-threatening. Monitoring the potassium once in 3 months or 6 months. When it is more than 6.5, refer to your nephrology. Don't treat. And these all drugs can produce hyperkalemia. So be aware of these drugs. So you use them cautiously or avoid in CKD patients. Coming to statins, lipids are very important. Not only cardiovascular system, but renal system also lipids are important. Lot of lipid changes take place in the kidney disease. And even LPA get increased. So, say triglyceride goes up in kidney disease. So, this is the guideline, latest guidelines, use statins. You have to use statins for any CKD patients, preferably atorvastatin. And these are the targets for LDL less than 70 or less than even 55 in high-risk patients. And these are the guidelines. Sometimes as the CKD worsens, you have to adjust these lipid drugs. But atorvastatin is the safest, no dose adjustment as much as possible. And this is mineral bone disorder. This is not our job. Only thing monitor. But when something is wrong, calcium is low, phosphate high, you have to refer to nephrologist. Muscle cramps, no specific treatment, as in the general population you can manage. Fluid overload, of course, diuretics. When it is resistant, you have to send for dialysis. Pain management, non-specific pains are common CKD. Avoid NACDs. That's the most important. Avoid NACD. Pruritus, very common in kidney. So there's no specific drug, but you can think of this gabapentin. Gabapentin for uremic pruritus. Sleep disorders, no specific guidelines. Restless syndrome, common in CKD. Levodopa, non-ergot dopamine agonist, low-dose gabapentinoids. Uremia is not our job. You have to refer to a nephrologist. When the creatinine goes, this is very important. CVD is CKD and CKD CVD. So you have to manage BP, you have to manage glycemic control lipids. Because every CKD patient is a CVD patient. So we have to take care of the cardiovascular system because majority of the patients die before they reach the dialysis. Chronic kidney disease is atherosclerotic. CKD is atherosclerotic. And this is the most important, when to refer to a nephrologist. This point every physician must know. The correct level of these causes and don't the cause of kidney, hyperkalemia, acidosis, anemia. And this is the overall management of CKD by a primary care physician. Probably next time we will be discussing some of these newer drugs. And this is one slide. This is not in guidelines, but my nephrology friends, even Dr. Panlipan may be using these drugs in his practice. But they are effective, but not in guidelines. They are effective, but not in guidelines. But I will refer to this last drug, taurine, every drug, even nephrology use this drug. But this is the latest paper in 2025, World Congress of Nephrology. There was a paper, even they mentioned the trade name, Nephrosafe. And this is a beautiful paper. They say it is useful. It is useful. There are 6 big hospitals in India, 6 kidney centers have taken part. They have shown Nephrosafe is effective in kidney disease. So primary care physician can use this drug up to the stage of 3. 6 big hospitals. I am proud Meenakshi Mission Hospital from Madurai was one of the part of this hospital. So CKD has to be managed to a greater extent by primary care physicians before referring to the nephrologist. This is my major references. Thank you.
Thank you, Dr. Gopinath sir. So quite a lot of learning points and summary quickly within 15 minutes. Just one comment from my side. Pentoxifylline we use, for stroke, but now it's for renal. So how does it help for the renal fibrosis? 3
actions: anti-fibrotic, anti-inflammatory, antioxidant. Okay. The 3 words are mentioned: anti-fibrotic, antioxidant, and anti-inflammatory.
Thank you.
Very good drug.
Yes, sir. Any questions from the audience? If not, we'll thank again from the organizers as a great talk. Thank you, sir.
It's our pleasure to welcome Dr. Vertigo sir from Vellore. He is one of the pillar of API Vellore and is a scientific committee chairman to present the guest lecture on topic gut microbe. So mainly to SK Raju oration for the topic gut microbe, a forgotten organ. I think I request Sadish sir to read the oration.
It is customary to read about the oration before the talk begins. I request Dr. Subramaniam to honor him with the medal of the oration. It's my great pleasure to introduce Dr. Vertigo. and the oration. He being from our branch, it gives me more honor. Dr. S.K. Rajan oration. Dr. S.K. Rajan Memorial Oration has been instituted in honor of the Professor S.K. Rajan, who was an eminent physician and pulmonologist in Chennai for more than 35 years. He was the professor and head of the Department of Internal Medicine and Dean of Stanley Medical College. He was also the Vice Chairperson of APA Chennai chapter. He was the founder chairman of City Physicians Association and decorated with Eminent Physician Award by the government of Tamil Nadu. He has contributed to Davidson's textbook of medicine as an international advisor. The Association of Physicians of India, Tamil Nadu State Chapter, with great pleasure, is pleased to award the prestigious Dr. S.K. Rajan Oration for the year of 2025 to Dr. Vetrivel, physician MD. Dr. N. Vetrivel studied MBBS from Chengalpattu Medical College in 1975 and did his MD General Medicine from Coimbatore Medical College. Currently, he is working as a senior consultant physician and diabetologist at KH Apollo Hospital, Melvisharam. Dr. Vetrivel was born to the son of an Indian military officer in the rank of honorary captain and belonging to the core number of military personnel family. He did his postgraduate diploma in hospital administration in Indian Institute of Social Sciences and Research, Krishna Devaraya University in 1985. He did his diploma in industrial health in 1996, postgraduate in diabetology in 2005, postgraduate diploma in advanced cardiology and ECG from Royal College of Physicians, and postgraduate diploma in advanced diabetic care and clinical endocrinology, again from Royal College of Physicians, and he also did his Master of Arts from Madras University. He is a fellow of Association of College of Chest Physicians of India, fellow of International Medical Sciences Academy, life member of Indian Medical Association, Associations of Physicians of India, Indian Society of Hypertension, Hospital Association of India, Research Society of Study of Diabetes in India, and faculty of American Academy of Continuing Medical Education. He has written and published 5 books of public health importance to the needy and distributed them, importantly, free of cost to the public and patients. Few of the books are Blood Pressure and Treatment Methods, including prevention in regional language Tamil. Healthy Heart is a matter of personal care for prevention of coronary artery disease. Beat the Blood Pressure Blues for prevention of hypertension. Chase the Invisible Nemesis for prevention of diabetes and lifestyle modification measures. He was awarded as a best talented physician in City Physicians Association in Chennai in 2001. The Association of Physicians of India, Tamil Nadu State Chapter, takes immense pleasure and honor to award this prestigious Dr. S.K. Rajan Oration to Dr. N. Vetrivel at the 21st Annual Conference of State Chapter, TAPICON 2025, hosted by the Vellore APA branch. Thank you. Another important fact is, I had mentioned that he has written 5 books. Now he has written another book on gut microbiome. The 6th book, I request Dr. Shanmugavelu to release the first copy of the book to our national president, Dr. Jyoti Marpal, as to receive the first copy. The first copy is going to be released by Dr. Shanmugavelu to our national president, Dr. Jyoti Marpal. The second copy will be released to Dr. Sukumar, our Vellore treasurer of APA. We request Dr. Shanmugavelu to release the third copy to Dr. Paranivel. Now I request Dr. Vertigo to continue his oration.
Respected seniors, my dear colleagues, and respected chair, Dr. Satish, Dr. Nelanchayan, Dr. Subramaniam sir, my mentor, Dr. Sukumarji. It gives me great pleasure to stand before you to talk on an emerging subject, gut microbiome, a forgotten organ to be remembered now. Next. My association with Professor S.K. Rajan speaks volumes. When I released this book, you could imagine Dr. J. Subramaniam and Dr. Lekha Pathak is on the stage, and my mentor, Dr. Samsi B. Moses, and my mentor, Dr. S.K. Rajan is there. Next slide. There are the two doyens who helped me to shape my academic career. Next. Dr. S.K. Rajan is a versatile speaker. When he introduced the speakers on the CME program, a lot of things will be there, inculcating the personality to whom he is referring and who is introduced. I adore his English language. Next. So he has helped me to disseminate the healthy subjects, knowledge on healthy subject to the needy public in various forums, because it has allowed me to disseminate knowledge to the needy public, more than 150 public health lectures and more than 25 TV lectures. Next. These are the stalwarts in one of the such meeting. You can imagine ranging from doyens from Mumbai Circle up to a Kodambakam cine actor, all are inculcated in the dissemination of public health lectures. Next. Now, I pay tribute heavily and profusely to my mentor, Dr. S.K. Rajan, so to say, my mentor, Dr. Samsi B. Moses. Next. See, the researchers have found in Indian scenario, the Indian guts have been damaged to the core by unwanted lifestyle and blunderbuss diet schedule and producing a lot of havoc in the form of physical and mental ailments because of this disturbance in the gut microbiota. Next. See, the gut microbiota has evolved with the human being. Trillions of microbes living in the gut. The gut microbiota play an important role in human biology, because if you don't have a good microbiota, you are not healthy. Next. So, it is an organ which we have forgotten, which we have undermined, which we have overlooked, is emerging like a science, microbiome science. Next. It is our father, Hippocrates, and Louis Pasteur, and Antony Leeuwenhoek, and Elie Michnikov, our forefather, Dr. Avicenna, and Galen are to be remembered vividly in this occasion. Next. Father told all disease begin in the gut. Health is determined by microbiome, our gut. Intestine is the paradise of disease. Death sits in the bowels. Yeah, bad digestion is the root cause of all evil. This is about 2.5 million back. But the pity is that now only we are at the door of opening the science. Next. The gut microbiota, which science is exploding amazingly. We are all moving with a bag of 1.5 to 2 kg microbiome in our body. Human microbiome, you know, people are sampling their own stools for the purpose of science, taking probiotic, prebiotics, eating lot of yogurt, kombucha, kimchi, and try to foster a good health. The science is exploding like anything. We are just at the early stage of making some sense of it. Next. The hidden forgotten organ, which is allobiont. We are really more than a bug. We must understand humans are microbiomes, 10 to 100 trillion microbes in human intestine, composed of 3 million genes, which I told you 2 kg weight, 300 to 100 species of bacteria makes these, which control almost all bodily functions. Next. We must differentiate what is microbiota, what is microbiome. Microbiota is the organ itself, whether it is fungus, virus, or bacteria, or archaea. But microbiome is the one including the microbiota and their genes, genome, and the specific environment, biome, plus theater of activity. Because of this microbiota releases in the course of their biological environment several byproducts which are known as microbial metabolites, which decide our milieu interior of Glad-Bernard. Next. This microbiota is made up of 4 phyla, which are very important: Firmicutes and Bacteroidetes, and Actinobacter and Proteobacter. Firmicutes, which are nice, made up of Bacilli and Clostridium. Actinobacteria of medical significance as notable source of antibiotic itself, naturally, endogenous antibiotic. Example, Bifidobacterium. The Firmicutes, Lactobacillus. The other 2 groups are imparting some good functions, but they are imparting bad functions too. Next. So these are the things. When the potential beneficial bacteria, you can understand they aid in digestion and metabolism of food and drugs. Production of short-chain fatty acids, which I will be alluding in detail. And potential tumor markers they show. When you come to the negative part of it, they produce endotoxins, which is a cause for endotoxemia, which we will discuss. And they are allowing the pathogen to eclipse the good bacteria. Next. These are this. When you say good bacteria, they are Escherichia coli, Bifidobacterium, Lactobacillus. When you go for the bad one, Clostridium difficile, and Enterococcus, and Lymphobacer. Next. So these are the functions which I will be alluding in the next slide. See, it performs various important functions. First, defense. It defends against infections. It defends against the leaky gut syndrome, which we'll be alluding. So, by secretion of various chemical factors like defensin, bacteriocin, they avoid infection from the pathogens. And they modulate the immune, whether it is T cell or B cell immunity. They perform immunomodulation, which will be helpful for maintenance of infection-free body and a good cardiometabolic health. Then they aid for digestion and absorption of food and drugs. In cardiometabolic sector, whether it is hypertension, whether it's diabetes, obesity, or whatever the NASH or MASH. So they are helpful in preventing these disorders. But you must know the gut-brain axis, which is going to be helpful for normal neurodevelopmental, normal neurodegeneration in the body. So overall, if you see our mood, our stability, everything depends upon this. There is no function which is not performed by a microbiome. Next. But pity to the occasion, these good bacteria, so-called microbiome, is spoiled by our modern civilization. The diet is a crucial factor which decides about the microbial this thing. And drugs like proton pump inhibitor, steroids, statins, antibiotics to the core spoils the microbiota. Geographical location, it varies from American, African, and Southeast Asia like that. Lifestyle changes, what the kid has, the robust diversity that is not in the the elderly years. So birthing process, baby born on vaginal delivery is having a very good microbial diversity and it has got a potential anti-inflammatory, anti-infective. A baby born on cesarean section is deficient of diversity of microbiome. And feeding method also. Bottle-fed baby, they don't have good amount of microbiome in their body. whereas mother's fed baby has very good microbiome. But another side, stress, whether it is exercise or whether it's metabolic or psychological, impairs and determine and modulate the content and the diversity of the ecosystem. Next. So I told you diet is the one which is the crucial factor, because you all know from the diet, there are good things are happening. Next. So this type of bacteria, when it's disturbed in population, diversity or complexity, it is going to be produce some havoc. What is that? Trillions of microorganisms, including bacteria, fungi, virus, eukaryotes, archaea, colonizing our gut. They should live in harmony. If the balance is disturbed, what we call it as dysbiosis, gut dysbiosis. An imbalance in the balanced microbiome content, pathogen or commensal, the dysbiosis is going to produce various cardiometabolic, various gastrointestinal disorders, various neural and pulmonary, even skin also. Next. So by establishing a crosstalk between other organs, for example, gut-brain axis, gut-brain endocrine axis, gut-heart axis, gut-lung axis, gut-liver axis, gut-pancreatic axis, gut-muscle axis, gut-skin axis, gut-reproductive axis, gut-kidney axis, gut-bladder axis. They establish a milieu by crosstalk. Let us see. So when they are disturbed, when you have gut dysbiosis, ranging from neurodegeneration, like you will have Parkinsonism, multiple sclerosis, motor neuron disease, amyotrophic lateral sclerosis, Alzheimer's disease. These are the neurodegenerative disorders. On the other side, you have autism, psychiatric disorders. These are the gut-brain axis is disturbed. When the gut-heart axis is disturbed, you will have atherosclerosis, thrombosis, heart failure, hypertension. And gut-lung axis, asthma, COPD, lung cancer, and other infections in the lung. In metabolic sector, if you disturb the gut, liver, or gut pancreas, whatever you will have obesity, diabetes, mitochondrial dysfunction of diabetes, and cancer. So cardiometabolic disorders. So an array of systemic disorders are emanated because of gut dysbiosis. Next. So I want to tell about gut infections. What is that? See, by colonizing resistance of the pathogens, by training the immune system, by producing bacterial compounds like bactricin, defensin, they protect us from the infection, especially immunomodulation on T regulator cells and B regulator cells. Next. So the role of gut microbiome in neurological disorders, because, in the form of various metabolites, they create a conducive atmosphere by neurocrine, endocrine, and immune-mediated signaling pathways. They help for synaptic development, synaptic transmission, and not to avoid degenerative changes in the disease I alluded to. Next. So in the gut, I am just giving some examples because if I dull, it will out of our scope of the volume. So mitochondrial entry pathway, altered receptor activity, altered neurotransmission, and this spoiling the immune system, neuroendocrine system, enteric nervous system, circulatory system through the vagus, they spoil the entire communication from gut to nervous system. So also they modulate the secretions of the neurotransmitters, so producing all the disease which I alluded to. Next. So gut microbiome with cardiometabolic disorder. Here I want to tell you, cardiometabolic disorder, especially one example I'll give. If somebody takes non-vegetarian food, which contains L-carnitine, betaine, and acetylcysteine, this is going to be converted into TMA, trimethylalamine. This trimethylalamine, if it is in the conducive of dysbiosis, is going to be converted into trimethylalamine nitrous oxide, TMAO, which is very toxic to the health. This TMO, which is converted from TMA by flavin oxygenase in the liver, is going to the precursor for atherosclerotic menu. So not only that, the chemical changes out of TMA is going to produce hypertension, heart failure, and atherosclerosis and prothrombotic events. Next. This is the one which I already told you. Next. So, in the vicinity of cardiometabolic disorders, hypertension, atherosclerosis, heart failure, diabetes is going to produce. Next. 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 Now, before going to the weight management of this gut microbiome, we have to know that there is a process known as short chain fatty acids. When we take good food, which rich in fibers, these fibers are not digestible by our regular enzymes, which can be digested if a good microbiota is there, producing what we call it as short chain fatty acids, which comprises of butyric acid, propionic acid, and acetic acid, which take care of prevention of leaky gut syndrome and energy harvestation from the food we eat and protecting the endocannabinoid system of the intestinal epithelial integrity. The story goes like this. The short chain fatty acid, especially butyric acid, is going to kindle the L cells in the intestine to produce endogenous GLP. This endogenous GLP is going to prevent accumulation of fatty acids in the liver through what we call it as the Takeda G protein receptor 42, 43, and also pernicides receptors. So there is no fat accumulation, prevention of insulin resistance in the liver axis. In pancreas, the GLP produced from the short chain fatty acids is going to prevent apoptosis of beta cell, and it will give the insulin secretagogue action, and it will regenerate the beta cell. So metabolically friendly effect of this short chain fatty acids, one side. Another side, if you have bad elements like gram-negative, what they produce, what we call it is LPS, lipopolysaccharide, from the wall of the gram-negative bacteria. This lipopolysaccharide LPS is kindling through the toll-like receptors 2 and 4, and they will traverse through the junction, which are gated by occludin and suboccludin in the zona occludens. So they pave way to exit of LPS, lipopolysaccharide. This lipopolysaccharide is an endotoxin. When it enters into the circulation, what we call it as metabolic endotoxemia. Metabolic endotoxemia is a pro-inflammatory state which will emanate various cytokines, IL-6, tumor necrosis factor alpha, and chemokines, this thing, our patykines, the lipokines. So emanation of cytokines, chemokines, lipokines is going to be hindering on the insulin sensitivity, producing enormous amount of insulin resistance. So you can understand this insulin resistance increase, you will have fat accumulation, and you will have diabetes, your insulin sensitivity is in soup. So cardiometabolically, TMAO and short chain fatty acids, which works through the endocannabinoid system to disturb the weight balance. So obesity, hypertension, and diabetes are the three end results of gut dysbiosis. Next. So overweight, obesity, undernutrition, and the respective sequelae have devastating tolls. Particularly, obesity is a massive health problem. Traditional approach for treating this condition with diet, exercise, drugs, surgery. In recent years, increasing evidence linking obesity to gut microbiome has been reported significantly. Owing to the transformative advances in sequencing, bioinformatics, and gonobiotic experimentation, we now understand gut microbiome play a major role in the weight neutrality. Next. So you can understand this obesity, this LAGO will inform you how the gut epithelium is disturbed, as I told you, insulin sensitivity and the gut epithelial barrier disruption, and these are the gut dysbiosis. Next. In diabetes, it is the same way as I told you. Next. So when you have dysbiosis, decreased butyrate production, it will have impairment on the beta cell function, development of diabetes, increased permeability, what we call it as leaky gut syndrome. Whenever LPS leaks out of the junctional barrier, you could see increased LPS, activation of toll-like receptors, and low-grade inflammation, and thereby development of diabetes. And changes in the bile acid pool, they produce bile acid disturbances, secondary bile acids, which impinge upon the receptor known as perniciod X receptors and creating disturbance in the insulin sensitivity. So, and also they will emanate lot of branched chain amino acids and also disturb the insulin sensitivity. There is a lot of connection between gut dysbiosis and the diabetes mellitus. Next. So these are the things which I do not want to dwell again. Next. So this is the thing. Gut microbial dysbiosis, LPS, metabolic endotoxemia, inflammation, insulin resistance, and type 2 DM. Next. So one has to understand the gut microbiome. Next slide. You can the short chain fatty acid through the activation of olfactory receptors, or they will increase the renin and stimulation of RAS system and increase the blood pressure. On the other side, when uremic toxins are there concurrently, you will have arterial calcification, systemic vascular resistance increased. Here, vasoactive hormones by the gut dysbiosis also produce vasoconstriction. Here, TMA, which I was alluding, TMAO to effect of increase the angiotensin 2, impinging upon the vasculature, producing so blood pressure is also to be, because researchers have found clearly that the action of anti-hypertension are mitigated or modulated by the action of gut microbiome. Next. This is the one which I already alluded. Yes, next. Now, gut microbiota through the way of dysbiosis produces what we call it as small intestinal bacterial overgrowth, SIBO. The SIBO will disturb the gut permeability, which will form gut leaky syndrome, endotoxemia, rise of bacterial dislocation, and increased lipogenesis and obesity, insulin resistance. You can understand liver injury, you will have MASH. Next. Not only that, the production of ethanol because of certain abnormal pathogens, microbiome in the family produces aldehyde. So those persons who have not taken alcohol also will have more aldehyde because of gut dysbiosis, and that is also one of the causes for MASH. Next. So pulmonary, lot of COVID people we have treated with probiotic and prebiotics and got success. But you should understand the pulmonary vascular pathology through the tryptophan, pyridoxytryptamine, and the circulation through the short chain fatty acid and tryptophan. You could have gut microbiota. You can form lung conditions and probiotic and prebiotic, and they will form a shield to the infection because of lot of immunomodulation is done by microbiome. If the immunomodulation is deficient, you will have lung infections. Next. So what you are going to do, in order to resume the normal function of this gut microbiota, you have to replenish the gut microbiota deficiency and make the balance all right. So the WHO recommends to reduce the use of antibiotics. You must see, you should not misuse, blunderbuss use of antibiotics. So they recommend what we call it as natural remedy by infusing pre and probiotics. Next. So now we have to give prebiotic and probiotic or symbiotic. What is prebiotic? Prebiotic is a food to the living organism. Probiotic is a replenishing of a living organism for the deficiency of microbiome. When prebiotic and prebiotic, probiotic join together, we call it as symbiotics. So the treatment of various conditions, including diabetes, pseudomembranous colitis, that this Clostridium difficile, or even autism is getting success because of usage of symbiotics. Next. This is the same thing. Next. So implication of this knowledge of replenishing the gut microbiota by use of prebiotic, probiotic, symbiotics. Now, fecal microbial transfer. Amazingly, you must know, Hong Kong has developed toilets for the surrounding people. They are paid $500, Hong Kong dollars, to go and defecate in the toilets, which will be collected by the authorities to have our fecal microbial transfer. This, when I was interacting with Dr. Nageswar Reddy, Professor Nageswar Reddy of IIG Hospital, Hyderabad, he is the one pioneer in India, emerging as a person who advocates the knowledge of gut microbiome, and is going to establish a gut microbial college. Next. So, some more important probiotics naturally available. You could understand tomatoes, anticoags, onions, garlic. In our setup, in our practice, we advise plenty of this fibered food, rich food. Onion, garlic are very good. Those days you could understand a farmer will take porridge and another onion. He didn't have any diabetes or hypertension. That is the basis of this. You can understand chicory, dandelion, asparagus, leeks, berries, bananas, flaxseed, legumes, all these are imparting very good prebiotic activity, which is useful for our day-to-day practice. Here come the probiotic food, sauerkraut, kimchi. The kimchi is nothing but a pickles made up of cabbage. You can understand. Then the kefir. Kefir is another yogurt, buttermilk, cottage cheese. All these, kombucha. Kombucha, the kombucha is sold. Kefir is also sold. So you can understand miso soup, which is served in the star hotels. They are the very good probiotic food. So when you have a natural probiotic, prebiotic in food, we can avoid gut dysbiosis and avoid those diseases listed. Next. So whole wheat products, rice and potato. If you eat potato with cover, with the skin, it is helpful. What our forefathers, our grandmother used to say. Nuts and seeds, again, prebiotic food, onion, garlic, anticoags, beets, Brussels sprout, and we have in our practice, we are advocating this dragon fruit, which has white or red pitta, which has got a very good prebiotic activity, and it, I tell you, fasting blood sugar, postprandial blood sugar, A1C reduction, we are witnessing amazingly. Next slide. So, diet is a crucial regulator for all these things because fiber-rich food, by the way of emanation of lot of short chain fatty acid because of saccharolytic fermentation by the common salts will be yielding more amount of short chain fatty acids. So, gut flora is a forgotten organ. Whenever we talk in conference also, they say it is not important. But whereas our RSSDA, I think you can understand, as asked to improve the knowledge on gut health in this year. So gut health is determined by good microbiome content. Next. So you can understand our Indian laboratories have developed what we call it as 16S rRNA sequencing, which is useful to decide which organism is not there. So it is the one gut instinct, introducing India's most advanced gut microbiome test. Decode your gut DNA with your next generation sequencing system available in all the leading cities. Next. I am thankful. We have to justify the honor to our forefather, Hippocrates. Let food be the medicine. Medicine be thy food. In Tamil they say, Unave Marundu. This is the one which I told you. He was tell all the disease starts from gut. Intestine is the seat of all the diseases. Now he says, this is from 450 BC. Let be the food, medicine be the food. Next. Thank you very much.
Thank you, Dr. Vertigo, sir. It's a really amazing oration and my eye-opener for many of us. So it's a customary not to have any questions, but you can chat with him in the break time. And once again, we thank the scientific chair and also the organizers for giving us this opportunity to chair this session. Thank you.
Thank you, sir. Now I invite Dr. R. Gopinath onto the stage. Now I request our chairpersons to present a token of appreciation to Dr. R. Gopinath. We request the chairpersons to kindly felicitate Dr. N. Vetrivel by presenting a memento. Dr. Satish to present a for our upcoming session.
Good morning, friends. It's a time to have our eminent speakers on the dais. I call upon Dr. M. Sanmugavelu sir, who is a doyen in the field of internal medicine. In addition to that, he is a very good diabetologist, friendly to all of us. He will be having his guest lecture, Professor S. Arul Raj guest lecture, Surmount Living with Obesity and a Helpful Tripartite. Dr. Sanmugavelu sir, you will read the topic. Before that, I request our Vice President of API, Dr. V. Palaniyappan.
Citation.
I request Dr. V. Palniappan sir to read the citation of Dr. Arul Raj, guest lecture, to be delivered by our Dr. M. Sanmugavelu sir.
Thank you. Dr. S. Arul Raj guest lecture has been instituted in honor of Professor Dr. Sundaram Arul Raj, who was a former adjunct professor of medicine in Tamil Nadu MGR University. He is an honorary national professor as well as the chief patron of the IMACGP and chairman of Commonwealth Health Association. He is the recipient of prestigious PC Roy awardee. He continues his active medical practice in Tuticorin and has a special interest is the cardiology and critical care. The Association of Physicians of India Tamil Nadu State Chapter, with great pleasure, is pleased to award the prestigious Dr. Arul Raj guest lecture for the year 2025 to Dr. M. Sanmugavelu, MD FICP, FRCP, Glasgow FRSSTI. Dr. Sanmugavelu studied MBBS in 1980, MD General Medicine in 1985 from Kilpauk Medical College, Madras University, Chennai. He is a physician, diabetologist, and chairman cum managing director of Trichy Diabetic Specialty Center, Trichy. And he served in government medical service between 1981 to 1992. Dr. M. Sanmugavelu is the fellow of Royal College of Physicians, UK in 2015, fellow of Indian College of Physicians, FICP 2016, and fellow of Research Society of Study of Diabetes in India, FRSST 2020. Dr. Sanmugavelu is the life member of Indian Medical Association, Association of Physicians of India, Diabetes in Pregnancy Study Group in India, Research Society for Study of Diabetes in India, All India EC member, EAST, ADA, and ACP, and Diabetes UK. And Dr. Sanmugavelu is the teacher for excellence, and he is the conjoint overseas faculty, University of Newcastle, Australia. Facilitator in short course in diabetes care, TUNNDA, Bangalore, and regional faculty for many Public Health Foundation of India. Dr. Sanmugavelu has published articles in JP, other national and international journals, contributed chapter in RSST textbook of diabetes mellitus, 5th edition, Microlabs books on diabetes, presented papers at national, international level. Dr. Sanmugavelu received many awards, starting from Professor Samji B. Moses Award, and Economic Times Inspiring Diabetologist of India Award, Dr. M.S. Asraf Doctors Day Award, RSST 2015 Commemorating Oration Award, Professor V.T. Balraman Oration Award, Outstanding Contribution to Diabetes Education Award, and Medal of Excellence at Hello Diabetes Academia. Dr. M. Sanmugavelu participated as a principal cum co-investigator in numerous phase 3 and phase 4 clinical trials, including several epidemiological and post-marketing and observational studies. And he is the key opinion leader in many pharmaceutical companies, member doctor committee for PhD scholar, SRM Medical College and Research Center, patron, panelist, scientific chairman of Diabetes Club of Tiruchirappalli. The Association of Physicians of India Tamil Nadu State Chapter takes immense pleasure and honor to award the prestigious Dr. S. Arul Raj guest lecture to Dr. Sanmugavelu at the 21st Annual Conference of API TAPICON 2025, Tamil Nadu State Chapter, CMC Vellore. Thank you. Medal.
respected chairpersons, National President API, members of Tamil Nadu Chapter API, organizing committee members, senior doctors, my doctor friends, and of course postgraduates, undergraduates from various medical colleges. It gives me an immense pleasure and happiness to stand before you on this red letter day to give a talk on Professor Dr. S. Alraj guest lecture oration. So Thanksgiving message. Thank you for this well-deserved recognition. Words cannot express my gratitude for this honor. I am deeply grateful for this award. This award is a testament to my hard work and dedication. This award motivates me to continue striving for excellence. So my special thanks to Tamil Nadu Chapter API Office Bearers, Dr. Balamurugan, Dr. Gunasegaran, and TAPICON 2025 Organizing Committee, Dr. Sugumar, Dr. Satish Kumar, and Dr. Vetrivel. And of course, if you look into the UK 2-pound, you can see standing on the shoulders of the giant on the edges of this particular Sterling Pond. So I'm standing on the shoulders of giants, my own hospital, Diabetes Club of Tiruchirappalli, API Trichy Tanjore Pudukkottai chapters, Diabetes Club of Dindigul Tanjore Madurai, Metabolic Club of Kumbakonam, of course, RSD Tamil Nadu chapter, API Tamil Nadu chapter. With these few words, let me So the topic given to me, it's a corporate symposium, industry-supported symposium, sponsored by Eli Lilly and Company, surmounting obesity with tirzepatide. I thank our organizing committee member for their kind invitation, also the Eli Lilly and Company. Of course, before I deliver this particular topic, the disclaimer, the program is sponsored by, and I'm giving a talk, that is presentation, on behalf of Eli Lilly Company, and we remind you that during this meeting, the topics covered will be exclusively with the scope of the indications provided and approved prescribing informations in India. Of course, one important housekeeping announcement, please do not take any photos or videos or screenshots or post anything on social media. So this session is sponsored by Eli Lilly. So my topic, before I take this topic, let me give a brief introduction. Obesity is a multifactorial disease. It's a multifactorial disease with various phenotypes, clinical presentations, and treatment response. The prevalence has doubled at the same time. It contributes significantly to the disability-adjusted life years. Obesity has biological underpinnings. It is closely related to a complex interaction between environmental and the genetic factors. So the gene expression, its functions, rare genetic variety, the so-called syndromic variety or the monogenic variety of obesity. And of course, treatment in terms of weight reduction reduces the risk for and the outcomes of the many of the complications of obesity. That is very important. Second important thing, body weight. It is primarily determined by the energy balance. Energy balance is equal to energy intake, that is caloric in, and caloric out, that is the energy expenditure. It is regulated by the brain. Of course, brain controls appetite, and brain regulates the three types of the food intake, namely the hedonic, number two, the homeostatic, and number three, executive function. Several centers of the brain, they control, they regulate appetite. They play an important role with reference to food intake as well as energy expenditure. We have the hypothalamus, prefrontal cortex, we have the mesolimbic area and other systems. Very important thing, though perceived as a disease, it is not commonly treated as disease. Only minority of the patients, they are given clinically proven lifestyle intervention, pharmacological interventions, surgical interventions. And above all, management of obesity is challenging. That is, whenever we treat obesity, physiological response to weight loss, that leads to weight gain. So that is going to be challenging. So a long-term approach for obesity management is very much important, and the sustainable weight reduction maintenance plays an important role in terms of appropriate nutrition, physical activity, and sustained motivation, and next is continuous and meticulous monitoring. So the proposed roles of GIP and GLP. So we have lifestyle intervention, pharmacological interventions like orlistat. Next is we have the incretin-based therapies, namely GLP-1, liraglutide, dulaglutide, and of course we have the liraglutide 3 milligram, and we have the semaglutide, both oral formulation as well as injectable formulations. So primarily the incretin hormones. We have the GIP, which are released from the K cells of the duodenum, and GLP from the distal part of the ileum. All these years we have been focusing our attention on GLP. It acts predominantly on the central nervous system, reducing the food intake, induces satiety, and also induces nausea. So the nausea is primarily mediated by GLP. On the other hand, GIP reduces the incidence of nausea. More so when you combine GIP and GLP, the incidence rate and the event rate of nausea less compared to GLP when it is given in higher doses. So next is pancreas. It stimulates the pancreatic beta cells to secrete insulin in a glucose-dependent manner and suppresses the release of glucagon. So it is primarily insulinotropic and glucagonostatic and delays the stomach and gastric emptying. Next is GIP acts on the central nervous system. Pancreas stimulates insulin secretion. With reference to insulin secretion, 44% of the insulin that is secreted is primarily contributed by GIP, and GLP contributes 22%. Glucose amino acid contributes nearly 33%. And with reference to GIP, it is insulinotropic and glucagonotropic. Anorexia is primarily mediated by GLP, and GIP, it improves insulin sensitivity, especially in the adipose tissue. That is, adipose tissue have receptors, and GIP acts on the adipose tissue. It improves insulin sensitivity, it increases the blood flow, lipid storage, and very important thing is it also favors fatty acid oxidation. And if you look into the effect mediated by GLP on adipocyte and the effect mediated by GIP, GIP predominantly activates on the adipose tissue in contrast to GLP. So they combine GIP dual and GIP analog agonist. They act better in terms of weight reduction rather than putting the patient on high dose of GLP that initiate nausea, apart from that with reference to reduction in the fat mass. And GIP actions on the adipose tissue. GIP has been shown to increase adipose tissue blood flow, increases glucose uptake, and de novo lipogenesis from glucose. So we have the visceral adipocyte, we have the subcutaneous adipocyte. There the action differs. In terms of visceral adipocyte, it reduces the adipocyte expansion. At the same time, increases the white adipose tissue of the subcutaneous depot, and thereby it improves calcium storage, that is the fat storage in the subcutaneous tissue. So primarily it acts on the visceral and also on the subcutaneous tissue. So increasing the LPL activity, increasing the adiponectin and various lipogenesis activity, as well as the FFA uptake, as well as glucose uptake. Right. So tirzepatide, it's a single molecule. So we have the unimolecular monoagonism, liraglutide, dulaglutide, semaglutide. We have unimolecular dual agonism, combined GIP and GLP. Tirzepatide, it's a selective, long-acting, novel, newer, combined dual agonist, given once weekly, that is subcutaneously. So based on the native GLP sequence, if you look into the receptor affinity, similar to native in terms of GIP. With reference to GLP, 5% lower. So maybe the nausea is less because of the reduced affinity. Mean half-life approximately 5 days. So it can be given once weekly. Dose adjustment, no dose adjustment is recommended for patients with a renal or hepatic impairment. So this tirzepatide addresses some important biological adaptations of obesity. Combined GIP and GLP So acts on the brain, reduces the appetite and caloric intake by increasing the feeling of satiety and decreasing feeling of hunger. Reduces the intensity of cravings and preferences. That is very important. So the craving is very much reduced. So the intake will come down. So food intake, caloric intake will come down. At the same time, improves energy expenditure. So GAP receptor agonism adiposity. It regulates glucose appetite and modulates lipid intake and lipolysis by binding to human adipocytes and activating GAP receptor. So predominantly GAP mediated effect, wherein the GLP may not have that much impact on the adipocytes. So through the combined actions of GIP and GLP receptors, it lowers body weight, resulting in greater fat mass loss than lean mass loss. When you compare GLP-1 high dose with GIP and GLP, it produces substantial weight reduction, very important. Significantly more amount of weight reduction compared to GLP alone given in high dose. That is one. Second thing is the fat-free mass. Though it has been reported, the reduction in the fat-free mass less compared to the patients treated with GLP receptor given in high dose because of the protective effect. GLP, it stimulates the AMPK kinase pathway, thereby it improves the muscle protein synthesis as well as the muscle function. And very important thing is GIP, it prevents the deposition of fat, that is myocellular steatosis. Thereby it helps to preserve the fat-free mass. So tirzepatide for weight management was evaluated in a robust clinical trial program involving several thousands of patients. So my focus will be on SURMOUNT-1 and SURMOUNT-4. SURMOUNT-1, so several thousands participated. So both. So SURMOUNT-1, it was phase 3, randomized, double-blind, controlled trial study. SURMOUNT-4, SURMOUNT-1. This particular study investigated tirzepatide 5 mg, 10 mg, 15 mg versus placebo in adults with overweight or obesity with complications. So patient with BMI 27 or more with overweight or obesity related complications like dyslipidemia, hypertension, obstructive sleep apnea and established cardiovascular disease, or BMI more than 30 or more given tirzepatide, diabetes excluded. Very important. This particular study was conducted only in patients with obesity. This included initial screening period for 2 weeks, followed by the trial period, wherein the dosage was started with the 2.5 mg. And dose escalation was achieved. So doses, that is from 2.5 mg, 5 mg was given after 4 weeks. So it started with the low dose and escalated, that is uptitrated gradually, slowly with a low dose. That is the reason where majority of the patients, they completed the trial, and the side effects were nausea, vomiting, which were definitely transient, mild to moderate in severity, and that did not lead to any discontinuation. So it was a phase 3 multi-center randomized double-blind placebo-controlled trial, and the core primary events endpoints include the percentage change in weight from baseline at week 72. At the end of 72, patients without pre-diabetes, they were followed up for another safety period. And patients with pre-diabetes, they were followed. So patients with pre-diabetes were also included in the study. Nearly 96% of the patients, they reverted back to normal glycemia. In contrast to patients treated with placebo, 60% of the patients, they reverted to normal glycemia. And we have the secondary endpoints. Percentage of the patients achieving 5%, 10%, 15%, 20%, 25% weight reduction. Changes with reference to weight circumference. Changes in the systolic BP, diastolic BP, and very important thing is lipid profile. So powerful weight reduction seen as soon as 4 weeks and continued through 72 weeks with the tirzepatide. If you look at the percentage weight reduction, 16% average reduction in body weight with the tirzepatide 5 mg at 72 weeks. And very important thing is you can see the improvement was reported as early as 4 weeks, and it was sustained till the end of the trial, that is 72 weeks. So 22.5% average reduction in body weight with 15 mg at 72 weeks. So there was dose dependent reduction in body weight, significant, substantial and sustainable. And patients with obesity, they experience significant weight loss across all doses of tirzepatide. Overall change in body weight from baseline to at 7 weeks. So patient treated with 5 milligram, 10 milligram and 15 milligram. So 16.1 1 kg average reduction body weight with tirzepatide 5 milligram, 23.6 kg average reduction body weight with 15 milligram at 72 weeks. You can see the difference compared to placebo. Significant and clinically meaningful and statistically significant p-value for interaction. So majority of patients with obesity, they achieved greater than 10% weight loss. So normally, when you compare placebo, and the active comparator should result in 5% above the mean placebo adjusted weight loss. If a placebo resulted in 4% weight reduction, the active comparator should result in more than 9%. So the percentage of patients with, that is who achieved body weight reduction at 72 weeks. So you can see 5 milligram, 5% weight loss, 10% weight loss, 15% weight loss, and more than 20% weight loss with reference to various dosage compared to placebo. So 9 out of 10 patients with obesity achieved more than 5% weight loss with the tirzepatide 5 milligram. Even the lowest possible dose of 5 milligram, it achieved significant weight reduction compared to placebo. 3 out of 4 patients with obesity achieved greater than 10% weight loss with the tirzepatide 5 milligram. Next is more than 50% crossed 20% weight loss barrier with the tirzepatide. So percentage of patients who achieved body weight reduction at 72 weeks, that is more than 15% and more than 20%. You can see compared to placebo. So 8 out of 10 patients with obesity achieved greater than 15% weight loss. And 2 out of 3 patients with obesity achieved more than 20% weight loss with the tirzepatide 15 milligram. Next is patients with obesity on tirzepatide experience improvement in body composition. That is very important. Changes in body composition, they were evaluated in a sub-study in SURMOUNT-1 using DEXA. So treatment with the tirzepatide was accompanied by greater reduction in fat mass compared to lean body mass, leading to an improvement in body composition. So greater weight reduction, what could be the reason? That is mediated by GIP. Normally what happens, GLP receptor gets internalized. On the other hand, when you give GIP mitigates the internalization of GLP. Thereby GLP comes and it continues its intercellular signaling. That is very important. Next is the resultant nausea is very less, number 2. Third important thing is its impact, both GIP and GLP on the central nervous system is robust, so resulting in greater weight reduction. Next is this reduction in total fat mass was accompanied by reduction in the visceral fat. So predominantly it induces reduction or regression of the visceral fat in contrast to subcutaneous. So it prevents the expansion of visceral adipose tissue, at the same time increases the expansion of the subcutaneous adipose tissue. So most of the weight loss was attributable to a reduction in the fat tissue, including the visceral fat. So reduction in the waist circumference is very important. Not only it does reduce body weight, but also the parameters of metabolic health. One of the primary objective of treating the patient with obesity, not only to weight, reduction in the waist circumference, that is equally important. Mean reduction in waist circumference of baseline 70 weeks, that is 19.9 centimeter average reduction of waist circumference with the tirzepatide 15 milligram at 72 weeks. Very important thing, atherosclerotic cardiovascular risk factors, CKD risk factors, heart failure risk factors. In terms of reduction in systolic BP, diastolic BP, triglycerides 24.3% to 31 point. HDL cholesterol elevated. LDL cholesterol also brought down 5.3 to 8.6%. And those patients were already on the standard of care. So patients taking this tirzepatide experience improvement in cardiometabolic parameters at 72 weeks. So normally we think once the patient achieves weight, should be continued. Let us stop and see. And we have enough trials with reference to statin, with reference to sacubitril valsartan. So SURMOUNT-4. this is a very important study. Again, phase 3, withdrawal study. Initially, for 36 weeks, patients were treated with 2.5, gradually escalated to 5 milligram, 10 milligram, 15 milligram, followed for nearly 36 weeks. Right. At the end of the 36 weeks, then it became, initially it was open label. Subsequently, it became double-blind, randomized. One group received placebo, that is, they discontinued tirzepatide. Another group continued receiving tirzepatide, the same dose. So phase 3, multi-center, randomized, double-blind, placebo-controlled trial. If you look into the primary endpoint, that is maximum tolerated dose, percentage change in body weight from week 36 to week 88. So that is, they look into. That is the primary endpoint. So participants who stayed on tirzepatide after the lead-in period, that is initial lead-in period, they were continued. They were given the same tirzepatide for another 52 weeks. That is, after the lead-in period, continued to lose weight versus those who regained when stopping. So you can see patients at the end of 36 weeks randomized, that is on tirzepatide and on placebo. You can see on tirzepatide 26% reduction from week 0 to week 88. That means that is additional weight reduction that was the patient experience. So initial weight reduction 20.9. At the end of 88 weeks, additional weight reduction. And you can see patients in the placebo group, they regain weight by 14 kg. So the difference, more than 6.5, statistically significant. So very important, total weight reduction in participants from week 26% versus minus 9.5% in participants who stopped taking tirzepatide at week 36. So more than 7 of 10 patients, they achieved greater than 20% weight reduction on tirzepatide. So percentage of patients who achieved body weight. So 5%, 10%, 15%, 20%, 25%. So 5 out of 10 participants taking tirzepatide, maximum tolerated dose, demonstrated weight reduction of 25%. So that is very important, right? This particular lady, now she has come to our clinic. Should we start the patient on tirzepatide? If we start the patient on this tirzepatide, what will be the impact on weight reduction? What will be the impact on the metabolic health, right? So if Anjali takes tirzepatide in addition to a reduced calorie diet and increased physical activity, she could potentially attain weight loss as early as 4 weeks, achieve significant and sustained weight loss up to an average of 22.5%. She can experience improvement in her cardiometabolic profile. In all the trials, intense lifestyle intervention was motivated by dietitian as well as the healthcare professionals. And the patients participating in the trial were given 500 kilocalories deficit per day, and they were motivated to continue physical activity for 150 minutes, right? So adverse events, that is very important, right? So adverse reactions in the surmount clinical trial. Tirzepatide has a similar safety profile to other incretin-based therapies. And if you look into nausea, diarrhea, constipation, dyspepsia, the most common adverse reactions were gastrointestinal, and they were mostly mild to moderate. So transient, mild to moderate, reported during the dose escalation period. And gastrointestinal adverse reactions primarily occurred during dose escalation and decreased over time compared to placebo. So discontinuation due to adverse reaction, this is very important. Percentage of patients who discontinued treatment, that is discontinuation due to adverse reaction and discontinuation due to gastrointestinal adverse reaction. The most common adverse reactions were gastrointestinal and were mostly mild to moderate, and gastrointestinal adverse reactions primarily occurred during dose escalation and decreased over time. So in short, tirzepatide significantly reduced body weight by an average of 16% with 5 milligram and 22.5% with 15 milligram. So significant weight reduction. It has been compared with the currently available GLP-1 receptor analogs, wherein it has demonstrated substantial reduction, sustainable reduction, and higher magnitude of weight reduction can be achievable and sustainable for a longer period of time. So improvements demonstrated in key metabolic parameters like blood pressure, waist circumference, triglycerides, and HDL cholesterol. The most common adverse reactions were gastrointestinal in nature and were mostly mild to moderate. So treatment with the dual GIP and GLP receptor agonist tirzepatide elicited substantial reduction in body weight, improvement in metabolic health measures like reduction in the waist circumference, improvement in blood pressure and lipid profiles in individuals with obesity or overweight, 27 kg or more with one obesity or overweight related complications, or 30 or more in patients both with and without diabetes. And very important thing is it has resulted in higher efficacy compared to what has been previously documented with GLP-1 receptor analogs. So thank you very much. Before I conclude my talk, let me invite all our delegates to attend this Research Society for the Study of Diabetes in India that is going to be held in Kochi from November 6 to 9. And yet another exciting event is Tamil Nadu Chapter RSSD Annual Conference track that is going to be held in Coimbatore on August 9th and 10th. We have stalls here. Anybody interested to register, they can go and register. And the venue is Coimbatore. I request every one of you, please register and make this a memorable and a successful event. Thank you very much for the kind listening.
Thank you, Dr. Shanmugavel, for a wonderful presentation.
I can take up the question, sir. No problem at all.
Any questions from the audience?
I can share my experience with this particular molecule in the management of both obesity as well as in the management of patient with the type 2 diabetes. Yes.
Shanmugavel, a small clarification.
Yes, sir.
In India, type 2 diabetes patients, 1/3 are normal weight and lean. So can they...
that is our DCGI. They have given approval for the management of patients with type 2 diabetes and obesity.
Because the lean diabetics also, they have visceral obesity and intramuscular fat excess.
Of course, currently it's going on, sir, trial.
Can we combine with the first generation anti-obesity drugs like orlistat, topiramate with the phentermine?
And no, sir, in all the trials, they have stopped totally. And if the patients has received any of the weight lowering agents, they were virtually excluded from the study. So the inclusion criteria is they should not be on any other GLP-1 receptor analog or any weight lowering medications. They have tried this particular trial only in patients who are drug naive.
Thank you.
Dr. Shanmugavel, all these effects described by you for this drug is also you can have with dapagliflozin. Why should you go for such a costly drug?
Pardon, sir?
All these systolic hypertension, waist circumference, weight reduction, everything is also got by dapagliflozin also. Why should you go for costly this drug?
It's a very good question, no problem at all. When you prescribe these drugs, we are getting no doubt improvement for an initial period. There are certain categories of patients who might need this particular drug. Such patients should not be deprived of this currently available drug, which can improve the cardiometabolic health.
Thank you, sir. Thank you very much, sir.
Thank you so much.
Thank you so much, sir, for the excellent discussion. So it's been great pleasure to welcome our National APA President, Dr. Jyotimar Paul, sir, for the Dr. Muruganathan, sir, oration. So now I invite Dr. Palniappan, sir, to read about the citation.
Dr. A. Muruganathan has more than 40 years of teaching experience. He is the ex-emeritus professor, Tamil Nadu MGR University, international advisor to Royal College of Physicians, Glasgow, international member of Medical Education Board of RCP Glasgow, and advisory council member of National Board of Examination. He is a brilliant clinician, teacher, researcher, and administrator who has received highly prestigious awards such as B.C. Roy Awardee from the President of India 2005 and the Best Performing Doctor Award from Tamil Nadu Government 2014 for his impeccable service to humanity. The Association of Physicians of India, Tamil Nadu State Chapter, with great pleasure is pleased to honor the prestigious Dr. A. Muruganathan oration for the year of 2025 to Professor Dr. Jyotirmay Paul, MD, FICP, FACP, FRCP. Dr. Jyotirmay Paul did his MBBS in 1993 and MD 1999, and he was a medical officer at Labur Rural Hospital in 2002, RMO cum clinical tutor at IPGME and Research Center and Hospital in 2003. Currently, he is the Professor of Medicine since from 2014 to till date in the College of Medicine, Sahur Datta Medical College, Kolkata. He is the Teacher for Excellence and University Examiner for undergraduate and postgraduate students. Dr. Jyotirmay Paul is the MD final examiner paper setter in universities of Tripura, Meghalaya, Assam and Sikkim, and invited as an external examiner in Nepal Medical College. He conferred fellowship in geriatrics medicine from WHO in Madras Medical College, FACP in 2014, FACP Fellow of American College of Physicians in 2014, FRCP Fellow of Royal College of Physicians of Ireland 2016, FRCP Fellowship of Royal College of Physicians Glasgow 2017, FRCP Fellow of Royal College of London in 2023. Dr. Jyotirmay Paul is the research guide and co-guide and guide for 15 postgraduate students till now. He is the clinical trial investigator in phase 2, 3, 4 trials. He is the editor, associate editor, sectorial editor and editor-in-chief for ICP monograph, Clinical Methods in Respiratory Medicine, McMaster Textbook of Internal Medicine, Southeast Asian editions. He authored many chapters in postgraduate medicine, Medicine Update Assam, and APA Textbook of Medicine. Dr. Jyotirmay Paul holds many prestigious positions like member of Technical Research Group on ART NACO East Journal Governing Body member of API, Secretary of API West Bengal, Vice President of API, Joint Secretary of IMA Bengal, Chairman Scientific Committee API West Bengal, Convener East Zonal API, Vice President API West Bengal, Vice President American College of Physicians of India Chapter, State Coordinator NTB Program IMA Bengal, Member Council West Bengal University of Health Sciences. Dr. Jyotirmay Paul is the Vice Dean of Dean in Indian College of Physicians 2023, the Vice Dean of ICP 2022-2023, Dean of Indian College of Physicians 2023 to 2024. Currently, he is the National President of API 2024 to 25. The Association of Physicians of India, Tamil Nadu State Chapter, takes immense pleasure and honor to award the prestigious Dr. A. Muruganathan oration to Dr. Jyotirmay Paul at the annual conference of API Tamil Nadu State Chapter, TAPICON 2025 CMC Vellore. Thank you very much. is going to deliver the oration, Muruganathan oration on hypertension and stroke. Over to my dear friend, Dr.
Almost 1 a.m. and order curd rice. So, so this is not only API, I learned food also from Dr. Muruganathan. So the topic is hypertension management in the stroke. Hypertension and stroke, this is the two bread and butter for all the physicians. And stroke is one of the common major emergency that every intern is faced. When I worked in the rural hospital, I managed stroke. When I worked in the district hospital, there is a secondary care, I managed stroke. Now in medical college, again I am managing stroke. The modalities may differ from place to place, but a physician, whether in the rural area or in a district area or in the capital city, metro city, have to face the stroke. So stroke management, that is why is a bread and butter for every physician. Basically, we encounter two types of stroke. One is the hemorrhagic stroke, another ischemic stroke. Hemorrhagic stroke basically due to the rupture of the different vessels or rupture of the aneurysm or amyloid arteriopathy or due to the different causes like person is taking lot of anticoagulant, warfarin and others. And ischemic stroke, basically two basic pathophysiology. One is the atherosclerosis and occlusion of the arteries, another is the embolism, particularly from the heart and large arteries and occlusion of the artery. These are two major facets of the stroke. One hemorrhagic, one is ischemic stroke. Hypertension and stroke has a very close relation. Hypertension is the most commonest major risk factor for the stroke. And hypertension either causes atherosclerosis and show the occlusion of the arteries and leading to the infarction, or it affects the heart, lead to increased risk of embolism, or causes rupture of the artery. This is some of the basic pathophysiology by which hypertension is responsible for the most of the stroke cases that we encounter. When the stroke patient come to emergency, usually up to 75 to 80% patient, we get the higher BP. And this higher BP usually start declining either after 1 hour or after 1 day. So this high BP either may be due to pre-existing hypertension or consequence of the stroke. What are the consequences of the stroke? There is increased sympathetic tone, increased cortisol, increased cytokines, increased stress, increased baroreceptor dysfunction, or Cushing reflex when there is increased pressure within the brain. So either pre-existing hypertension or consequence of the stroke. For that reason, hypertension at presentation is very common. It can subside after 1 hour or after 1 day, or it can persist as it is. So you have to decide whether we will give the medication to control the hypertension, or you will wait because of the normalcy of the blood pressure that may happen after 1 or 2 days. Hemophilia study that very clearly established the direct relation between the stroke and hypertension. And systolic blood pressure usually considered a major predictor of risk compared to the diastolic blood pressure. And till now, there is no threshold has been established above which the risk of the stroke increases. So basically, hypertension is related to stroke, but cutoff value related to other factors also. That is why proper appropriate cutoff value till now not defined properly. So when you are dealing a patient of hypertension, few of the issue is there, because you have to treat the hypertension. But question is, when you will start the antihypertensive drug? Patient develop the stroke at the home. Most of the people may have their blood pressure machine. You have got that patient's blood pressure at home is 180 by 110 or something like this. Whether pre-hospital, when the patient is transferring from home to hospital in ambulance, whether immediately we start the antihypertensive drug, or after admission you recorded BP is high, you will start immediately, or after initial stabilization you will wait up to the normalcy of the blood pressure, that may be the reactionary to the stroke. So after stabilization or pre-hospital or at admission, we will start, whether we will start the antihypertensive drug, what are the evidences, and what should be the BP goal, and which drug will act best in this scenario, and what about the primary and secondary prevention. So what drug you will use for the prevention of the recurrent stroke, and what should be the treatment goal, and what type of drug you will use. So these are the questions that we will try to meet in next 15 minutes. So coming one by one, one is the ischemic stroke. So ischemic stroke, first issue I told, there is some study whether starting of the antihypertensive drug in the pre-hospital stage in ambulance can be helpful. So some study, there are a lot of study, 2 UK study. One is the PL first trial, one is the right trial. They use drugs in the pre-hospital. Their idea was, because if you try to give the thrombolytic, your blood pressure before giving the thrombolytic should be below 185 by 110. So pre-hospital stage, if you give the antihypertensive and can bring down the BP below 185, so we can quickly start the thrombolytic therapy. This was the hypothesis. But it is seen that pre-hospital initiation of antihypertensive, no benefiting functional outcome and mortality. Even the hospital started thrombolytic therapy earlier. So that is why the guideline, European guideline, is not advocating antihypertensive therapy to start it in ambulance. Next is the acute phase. All the ischemic stroke patients who are admitted, there is an acute phase. So acute phase hypertension, or raise of the BP is very common in a ischemic state when the person attend the emergency. But usually it is self-limiting. It is subside to some extent by 1 week. And this acute hypertensive response basically associated with the poor outcome of the stroke. But there are many trials to come to a conclusion what should be the optimum BP and whether we should treat rapidly this acute response of hypertension in a stroke patient. But till now it is not properly established. The concept was that high BP in a ischemic stroke is beneficial because it supplies the more blood to the penumbra region to prevent the further death of the neuronal tissue. But at the same time, high BP can convert, or there is a chance of more the hemorrhagic conversion of that infected zone. Again, if you reduce the BP acutely, that lowering of the BP acutely may increase size of the infection because the blood flow will further decrease. So higher BP versus acute reduction of the BP, which is beneficial in the trial. There are so many trials there, we will come later on. So what is the evidence and what is the guideline, what is the based on the more RCT where we have reached in 2025. In hemorrhagic stroke, high BP is detrimental because it can increase the rebleeding and increase the hematoma size. So we have to carefully assess when we start the antihypertensive drug and what should be our goal of BP and how rapidly we will reduce the blood pressure. Because of these are the important clinical scenario that can happen either due to the increased BP or acute lowering of the BP. So BP lowering in acute ischemic stroke, it is seen from the maximum trial that intensive BP lowering does not result in any significant outcome in terms of mortality or functional outcome. So one study is very important, the China antihypertensive trial in acute ischemic stroke. They recruited more than 4,000 patients with SBP between 140 to 220. And they categorized in the 2 groups. In one group, they have randomized with the drugs and there was a BP reduction attempted 10 to 25%, average was 13%. In another group, there was not randomization, that means antihypertensive was not given, and in that group, some reactionary decline of the BP was approximately 7%. But the result of the both group when compared statistically, it was a neutral. So question is when to start. So that means from the previous study that intensive BP lowering does not have any functional outcome. So question is when to start the antihypertensive therapy and what should be the goal. This differ from scenario to scenario. One is whether patient is a acute presentation or chronic presentation, whether it is a TIA or full-fledged infarct, whether patient have comorbidity or patient is without comorbidity, whether patient will subject to get the thrombolysis, your facility in the hospital is there, or patient will undergo thrombectomy, that facility is there in your hospital. Depending on this condition, you have to decide when to start the antihypertensive and what will be the goal of the blood pressure. So this is the 2019 guideline. If we summarize, there are 5 scenarios. If the patient develop from TIA and if you can exclude the large artery occlusion or stenosis, initial 15% reduction in BP is adequate and harmless. If the blood pressure is more than 220 by 110 and patient have certain comorbidities, as soon as possible, you have to start the antihypertensive drug. Challenge is when it is infarct and BP is less than 220 by 110. That is the challenge. Here, it is seen from the multiple trials that benefit of treatment is uncertain by 48 to 72 hours. But within the first 24 hours, if you reduce the blood pressure by 15%, that is quite reasonable. So challenge is in this category below 220 to 110, no very clear evidence is there how much and when to start. But in first 24 hours, 15% reduction is quite adequate. But you assess whether patient has comorbidity. If the patient has comorbidity, such as heart failure, angina, then start the drugs as soon as possible. Fourth condition is hospital have the facility of thrombolysis. In that condition, you have to reduce BP, SBP below 185 and diastole by 110 before giving the thrombolysis. And after thrombolysis, maintain the blood pressure below 180 by 105. And if the patient is candidate for endovascular treatment and facility available in your hospital, then BP to maintain before and after procedure below 185 by 110. So if you continue, what is your role within first 24 hours and after 72 hours. In first 24 hours, your role is if BP is more than 220, if we summarize from the previous guideline, if BP is more than 220 by 120, lowering of the BP by 15% from the baseline by 24 hours. This is advocated. And BP is below 220 by 120, initiation of the drug is safe, but not very effective in preventing death or dependency. But 15% reduction in first 24 hours is quite safe and reasonable. But if the patient has comorbidity, you have to lower the BP earliest by 24 hours from the baseline, at least by 15%. So this is the guidelines until now the evidence from the ischemic stroke. Now we are coming to the hemorrhagic stroke. Hemorrhagic stroke, it consists around 20 to 25% among the all strokes. And intracerebral hemorrhage is the commonest, around 20%, and subarachnoid is the 5%. There are other varieties also. So intracerebral hemorrhage causes significant mortality and morbidity. So acute phase treatment is very essential. In intracerebral hemorrhage, our primary goal to control the BP is because reducing the BP, we can reduce the size of the hematoma and also the perihematoma edema. For the subarachnoid hemorrhage, BP is needed to be controlled. To prevent the rebleeding and to maintain the cerebral perfusion. So in both ICH and subarachnoid hemorrhage, control of the BP is very essential. Otherwise, there will be either rebleeding, increased size of the hematoma, and increased edema that can further aggravate the clinical scenario of the patient. BP elevation is common in the hemorrhagic stroke because either mostly from the pre-existing hypertension or due to the Cushing reflex, that is due to the increased ICT, or due to the anxiety and pain out of fear and out of the clinical situation. Elevated BP, I told, is dangerous for the ICH patient because it can increase the hematoma size, it can cause the rebleeding, it can increase the perihematoma edema and mortality. So our duty is to reduce the blood pressure, to reduce the mortality and morbidity. But have to remember, if you very aggressively reduce the BP, that can lead to further cerebral ischemia and death of the neuronal tissue. So that is why very judicious application of drug and the optimum reduction of BP, and you have to have very clear idea what is the goal of the BP when you are treating ICH patient with the antihypertensive drugs. So if you go in summary, not going very details about the studies, there are 12 RCT, they have observed cerebral blood flow following the reduction of the BP. What is happening following the reduction of the BP? Whether if you give the antihypertensive drugs, cerebral blood flow is acutely decreasing, because if it is acutely decreased, that can further increase the ischemia also. Or there is no at all change of the cerebral blood flow giving the antihypertensive drug. What is happening? So they have recruited patient with the acute stroke within the 24 hours and whose the SBP was more than 150 millimeter mercury. So it was divided into two groups. One group BP achieved below 150, another group BP achieved was between 150 to 80. And perfusion CT scan was done to evaluate the cerebral blood flow around the hematoma. The observation was degree of BP reduction did not affect the cerebral blood flow. That means BP reduction was quite safe in both of the group. So INTERACT-2 trial, they evaluate the intensive lowering the BP in acute ICH. In this trial, around near about the 3,000 patient was recruited between the SBP between 150 to 220 within the 6 hours of onset of the acute stroke. They were randomized in the two groups. One group target BP was below 140, another group was target BP was below 180. And primary outcome that was estimated, that was the death or major disability. It is seen in this trial that intense treatment group have a better functional outcome, and reduction of BP does not cause any major adverse effect. So that means in INTERACT trial, by the INTERACT trial, the BP control below 140, around 140, has a better functional outcome than the BP whose BP was around 180. So based on this trial, the ACC AHA guideline 2019, they have published that in ICH patient, BP between 150 to 200 without contraindication of lowering BP. That means at presentation, if the BP is between 150 to 220 and there is no contraindication of using the antihypertensive drug, lowering of the BP up to 140 millimeter mercury may be safe and has a better functional outcome. So this is a major difference of antihypertensive drug application and goal between the ischemic stroke and hemorrhagic stroke. This trial was done after publishing of the AHA guideline 2019. They also taken the patient with ICH and hypertension, and they divided into two groups. One group BP was achieved 110 to 139, another group from 140 to 180. And antihypertensive drug was started aggressively within the 4 to 5 hours of onset. And this two group was evaluated for the next 3 months for the death and major neuro disability that was estimated. It is seen that intense group, those BP was reduced to 110, 120, or intense BP control group has a more end organ damage, particularly the renal damage. So conclusion, if we compare the all trials, including the ATTACH-2 trial that published after the release of the guideline, that in two trial, BP reduction for last trial, ATTACH-2 trial, BP reduction was more rapid and intense than the previous trial. And subgroup analysis, it is also shown from the interactive trial. Those patients whose SBP came below 130, they have a worse prognosis. So that is what conclusion from the both trial was, SBP target of 140 will be better than the target of 130 during the admission period. So final guideline that came from the intercerebral hemorrhage, the guideline on 2015 recommendation was when the SB between 150 to 120 millimeter, acute BP loading may be effective in relation to the functional status, number one. And if the SBP is more than 220, it is reasonable to lower BP more aggressively by continuous infusion. And 2007 guideline was, that is the based on the attached to trial, BP loading to 140, below 140 may not be beneficial but rather be harmful. That means intense BP loading up to 110, 120, that may be harm to the other organ. So that is why considering the two trial, so maintain BP between the, for an ICH patient between 140 to 160 is quite adequate. Next is coming to the subarachnoid hemorrhage. In subarachnoid hemorrhage, rebleeding is a challenge. So BP control must to stop the rebleeding. And AHA guideline is recommend that BP of SBP below 160 to balance between the rebleeding and ischemia. And that is why in subarachnoid hemorrhage, you have to maintain mean arterial pressure around 110 millimeter mercury. Last two issues, one is the BP variability, one is the prevention. BP variability stroke, BP variability is a very strong predictor of the stroke and related to the CV effect, particularly the early morning surge and late absence of the late midnight dipping. This is very important for the BP variability, and that is why nowadays ambulatory BP monitoring is becoming popular to assess the early morning surge and loss of midnight dipping, because these two are very strongly predict and associated with the different CV cerebrovascular accident. And there are many drugs, diuretic, calcium channel blocker, they are more effective in preventing the BP variability than the beta blocker, contrary to the popular belief. In ICH also, BP variability related to the worst outcome because it is related to the more oncotic and hydrostatic pressure around the hematoma, and that also variability leads to more autonomic dysfunction that lead to more pro-inflammatory state and more vasogenic edema. That is why BP variability during the admission and before occurrence of the stroke, in both situations, the physician have very clear knowledge of the BP variability because variability related to the more worst outcome. Finally coming is the prevention of the stroke, because prevention is always better than cure. The all RCT has a clear evidence that control of the BP is related to prevent the stroke. This is very clear. If you reduce the SBP and DBP, 11 to 12 for SBP and 3 to 4 for diastolic BP, at least there will be 36% reduction of the stroke incidence. So guideline for the primary prevention is AHA guideline, BP lowering with the diet and lifestyle measures and should be lowered below 140 to 90. But 2000 guideline, it has further reduced to 130-80. So current guideline for the prevention of the stroke, primary prevention, target should be below 130-80 along with the diet and other lifestyle control measures. Secondary stroke prevention, there are multiple studies, few of the study I have mentioned. Was the indapamide versus placebo. It is seen that indapamide group has a better result for prevention of the recurrent stroke in future. Progress study, they have used perindropil, and after 4 years there is a significant reduction in perindropil group for the recurrent stroke. And all the meta-analysis have a conclusion that if the SBP can be done below control 120 millimeter mercury by the drug, it is better to prevent the recurrent stroke. If we compare the between drug, which is the better for the prevention of the stroke, in the all-heart trial, it is seen that amlodipine chlorthalidone has a significant difference found in terms of stroke prevention. And meta-analysis of 58, another RCTs, it is shown that diuretics are superior to RAS blocker in prevention of the recurrent stroke. So small vessel disease lastly, because lacunar infarct is very common And SPS 3 tal is shown that two group was there. One group is the below 130, one group 130 to 139. In two group, the below 130 millimeter, they have demonstrated the better outcome. So in patient with lacunar infarct, recommendation is below to come bring down the blood pressure below 130 millimeter mercury. Recurrent stroke prevention, 14 guidelines was that SBB should be below 140 and diastolic 90. For the lacunar stroke, it should be lowered down to 130 to 80. But the 2007 guideline, they have advocated for the all stroke. Whether stroke or TIA, BP lowering should be below 130-80 to prevent the recurrent stroke. And restart medicine when the patient is stabilized, and any drug of the major four classes can be advocated, but definitely clothalidone and calcium channel blocker has an age as per the trials for the better outcome and choice, but have to depend on the comorbidity. So this is in nutshell about the stroke management and hypertension management and stroke. Till now, not very clear guideline when to start, how much intense, what should be the goal. But based on the recent data, what I have presented, there is a evidence that how we can best manage or you can prevent the mortality and improve the and also the morbidity, that is the functional outcome you can modify with controlling the blood pressure during the acute phase and after discharge. You have to prevent the recurrent stroke. So before ending, a few issues I am taking the opportunity. One issue was the JAPI. JAPI, I know many of you not getting because some issue has happened due to the address issue. So we are hopeful from July again we will start getting the JAPI. And two more added feature we have done in the API website. One is this is the new API website. I request all of you to go to the website. There is on the home page, there is one is the apply now. Now the membership application can be done online with the payment portal is there. So you go to the apply now, you will get two links. One is the fellowship application, one is the membership application. In membership application, you fill up your data and give the payment online. Your data will be received by the office to evaluate whether your membership is okay or not. If you are not eligible for the membership, your money will be refunded. And fellowship, it will take another 1 month to become functional, including the payment portal. There is a two limb, one for the fellowship for the Indian national, one fellowship for the international people. This time, first time, we are introducing our fellowship like FRCP or FSCP to the international people. And there is another link, the global forum. We have a liaison activity with the multiple international organizations, including the countries, and you will get the all information, including the conference, what is happening in our partner country to the global forum link. And finally, now there is 24,000 members. Many of you, I know they have changed their address, but office record still having the older record. That is becoming a challenge. Lot of JAPI and ballot, everything, letters are returning back to the office. So what we have done, in the website, you click here, the home page, there is a button called contact. If you lose the contact, this is contact, you will get the member directory. You contact button, click, you will get a 3 link. One is the member directory. You click here. So this page will open and you yourself fill up the form. Your name, email ID, phone number, your address, your membership number, everything you fill up. Along with your medical registration certificate. You have to give any government attachment, Aadhaar card, PAN card, your passport, your medical registration number, driving license, anything you have to put as an attachment and submit. This will be received in our office. Immediately we will get a mail that the data has been verified by the office, and now you do your own user ID and password. So your dashboard will be created. So if we can complete this 24,000 people's data by next 6 months or 1 year, so your own dashboard you can create. So all our information now onward will go to your dashboard. So this will be very easy because nowadays postal service is irregular. Many of you are not getting our different mails, postals. JAPI will go by post, that is no issue, but other document, other information you will get in your dashboard. Along with the postal service, definitely will continue. So this is, I request everybody to go to the website and to click the contact and go to the directory, members directory, and you fill up the form and submit. So it will be easier for our office to send all information. I know all of you have grievance that you are not getting all the information regularly. That is why in the era of technology, we have adopted a system. I hope this by 1 year, we have to complete, and the central committee members, state secretaries, I request, at least all members not here, please percolate the message to every member of state of Tamil Nadu. Thank you.
Thank you very much, sir, for your wonderful presentation about hypertension control in hemorrhagic strokes. Thank you, sir.
Since this is oration, no questions. Thank you very much, President, sir.
I request Dr. Shanmugavel sir on stage. I request the chairpersons and speakers to stay on the stage. Now I invite the chairperson to present a memento to Dr. Shanmugavel as a token of our appreciation for his insightful talk. We request the chairpersons to kindly honor Dr. Jyotirmal Pal sir with a memento in acknowledgement of his excellent session. Now I request Dr. Jyotirmal Pal sir to give memento to the chairpersons. That brings this session to an end. We kindly ask everyone to remain with us as we proceed to the next session. Session 5, Yielding Mixed Crops. It is a privilege to welcome Dr. Balaji Nathan from Madurai, Dr. A.S. Mogan from Tirunelveli as chairpersons for the forthcoming session. I invite Dr. Balakrishnan from Tiruvallur on stage to chair the session.
I request Dr. Bharani ma'am to chair this session. request Dr. M. Anida to speak on Plex, a lifeline in rodenticide poisoning. Over to you, ma'am.
So good afternoon to one and all who are gathered here. It's been great pleasure to present over the TAPICON 2025 as a scientific convener. So today my topic is a Plex, a lifeline in rodenticide poisoning, a clinical perspective. This is the introduction. So as you all know that the rodenticide poisoning is a public health challenge in India. It's with the high morbidity and then mortality. A targeted therapy needed in very severe cases. So here the definition, the rodenticide ingestion, predominantly the yellow phosphorus and zinc phosphide. The prevalence in Tamil Nadu, the leading cause of the hepatotoxicity, more than 75 times when compared to the paracetamol poisoning. And mortality is 35% of the cases of poor outcome as a death and discharge moribund. So these are all the available brands of the rat killers available in Tamil Nadu. So the Ratol and all these products. So then these are the common rodenticide poisoning contents, the anticoagulants, predominantly the warfarin and zinc and aluminum phosphide, thallium and the superwarfarins. The toxic agents, these are all the agents which is the leading cause of the severe hepatotoxicity. The yellow phosphorus is a highly hepatotoxic, mainly it lacks the specific antidote, and zinc phosphide, it also causes the severe liver injury. The mechanism is the hepatocellular necrosis leading to the acute liver failure. The behind the pathophysiology is the anticoagulants, mainly that inhibit the vitamin K recycling, that is main reason for the bleeding diathesis in the rodenticide poisoning. And zinc phosphide is a phosphine, it releases the phosphine gas that causes the mitochondrial dysfunction. And the superwarfarins is a lipophilic and long-acting that accumulates in the liver and fat that causes the prolonged effects. So as you all encounter in our medical ward, so usually the patient may present it with the rat killer poisoning. The first 2 or 3 days the patient will be absolutely normal, but we need to observe till the 5th and 6th day of the admission, because that period only the patient may go for the acute fulminant hepatic failure. We should not discharge before 5th day of the admission. So these are all the pathophysiology. It causes the severe hepatic necrosis and fat accumulation, and also in case of the lungs there will be a pulmonary hemorrhage and all these things. So when compared to the study, out of 32 cases, these are all the list of the pathophysiology underlying the organ damage. Mainly in the liver there is steatosis and hepatic necrosis. In the kidney also the tubular necrosis, and heart atherosclerosis, in lungs alveolar hemorrhage, spleen splenic hemorrhage. So when we see these slides, we need to observe that it is the multi-organ damage. In each and every organ there will be a necrosis and then the hemorrhage. These are all the clinical causes. It's very important. So in the initial phase, in the first 0 to 24 hours of the ingestion, most of the patient may present with the GA symptoms like mild nausea and vomiting. And latent phase, 24 to 72 hours, there will be a symptom-free interval. And toxic phase is 72 hours. There will be an acute liver failure, encephalopathy, elevated INR, and possible renal and then cardiovascular compromise. The diagnostic workup, mainly the PT-INR and then coagulation profile, and then bilirubin, the serial liver function test we need to see, and then the CT brain and then urine toxicology. The conventional management, initially we need to give a supportive care, then vitamin K and N-acetylcysteine infusion, and then the FFP cryoprecipitate, if needed dialysis, all these things. These are all the management steps. In case of the primary care, the early management is the immediate decontamination. Whatever the poisoning, we need to give a decontamination, the gastric lavage plus activated charcoal, and supportive care, IV fluids and antiemetics, early referral to the higher centers whenever the patient showing the raising in the INR and GA bleeding, altered consciousness. Secondary care monitoring is we need to admit at the district and taluk hospitals, regular periodic checkups of the liver function test, INR renal panel, mental status, all these things. The tertiary care, we always need to observe the INR. The cutoff point is more than 4. And also the encephalopathy, altered sensorium. We need to initiate the Plex. As you all aware that the word Plex is the plasma exchange. They initiate the low volume plasma exchange for the acute fulminant hepatic failure. we need to avoid the sedatives. So we must know, instead of knowing the indication what should do, we must know what we should not do. So, okay, we need to avoid the sedatives in the encephalopathy because that may again worsen the liver injury and the liver transplantation when feasible. The role of the PLUX, the importance is mainly it removes the circulating toxins, and also it replaces the coagulation factors because of the liver injury. It's indicated, PLUX is indicated in case of the severe anticoagulant toxicity and thallium poisoning, refractory bleeding, and prolonged INR. So these are all again indications, like INR is more than 4, severe worsening of the INR, and then the depressed consciousness. Contraindication is hemodynamic instability, and then active sepsis case we should not do the PLUX. The mechanism is toxin and metabolite removal and replacement of the plasma protein that breaks the intrahepatic circulation, reduces the toxin level. So I'll just brief a short steps how we need to do the PLUX therapy, because most of the centers won't have the plasma exchange therapy. We need to prepare the patients, and when we need to see the indication and get concerned, do the baseline investigation, get a venous assess, either peripheral in case of the short-term PLUX therapy and central in case of the repeated cycles. If the patient needed 5 cycles, we need to go for the central line. So we go for the dual lumen central venous catheter, mainly the jugular or femoral, and check the patency and sterility, and we need to connect with the plasmapheresis mesh, and if needed, we need to give a replacement like albumin and set up the replacement fluid, 5% albumin, FFP, depending upon the indication. And initiate the plasma exchange. The blood is drawn, sent to the apheresis mesh. Plasma is separated by the centrifugation and infiltration. Cellular components is returned to the patient along with the replacement fluid. So we need to monitor the vitals during the procedure and post-procedure. We need to observe any allergic reactions, bleeding, diathesis, and complications. So these are all things. So the evidence and then outcome, in 2019 study, among 451 patients with the yellow phosphorus hepatotoxicity, 54 received the PLUX therapy. They showed a good outcome, and 99% lacked the transplant assesses. Non-transplant management with the PLUX showed the 60 to 75% of the transplant-free survival. These are all in our government hospital, Vellore Medical College and Hospital. The few case scenarios. The first is the 25-year-old male, yellow phosphorus ingestion. The INR is 10 and hematuria. They failed with the vitamin K and FFP. PLUX cycles after given show the clinical and then biochemical recovery. The second case is a 17-year-old boy with the history of ingestion of yellow phosphorus, presented on day 5 of conception with acute fulminant hepatic failure. The patient is expired in spite of the 5 cycles of the PLUX. If you observe closely, the first case, they presented immediately, they started the PLUX therapy, recovered well. But the second patient, they presented on the day 5 of conception, even after doing the PLUX therapy, may not be useful, the patient may expire. So whenever we are sitting in a peripheral centers or any PHC, we need to know the knowledge about the rodenticide poisoning. We need to observe till day 5 of ingestion. So most of the time, day 1, day 3, the patient is normal, will discharge. The patient may come in day 5, but there is no use even after initiating the PLUX therapy. The last case is 28-year-old female with the history of the zinc phosphate, yellow phosphorus. They also presented 1 week after conception, presented with the gastritis and liver failure. Even after immediate initiation of the PLUX therapy, could not able to save the patient. These are all the advantages of the PLUX. Rapid toxin removal minimizes the bleeding and shorten the hospital stay, may prevent the organ dysfunction. There is no specific antidote. The PLUX, mainly the low volume, can significantly improve the transplant-free survival because most of the patient cannot able to assess the liver transplantation. So this is the boon. The PLUX therapy is a boon to the rodenticide poisoning. The public health action, we need to sensitize the government setup also to ban the rat killer paste, powder cake availability. So that way we can prevent. Thank you so much.
So thank you, madam, for your excellent presentation of rat killer poison, especially in resistant cases in plasma exchange therapy. So today morning I talk about, I have given a broad spectrum aspect of the plasma therapy, but you have given a detailed scenario about the plasma therapy in rat killer poisoning. So 1 or 2 questions from the audience, as we are short of time.
So one point in government Vellore Medical College and Hospital, over last 1 year, 2024, more than 240 patients admitted, out of which the patient 235 got discharged and recovered. 5 patients only died. So we need to observe that also. The cake and paste and powder, what is the component? The paste is worsening when compared to the powder and cake.
National Health Mission of Tamil Nadu conducted the large multicentric trial, including Vellore Medical College, and there is a very successful workup of all the cases, and they are reducing the death rate in this particular lethal poison called ratol poison, yellow phosphorus. And what about the use of N-acetylcysteine, madam?
Yes, sir. That also is helpful, sir, for bridging therapy. So before initiating or deciding about the indication of the plasmapheresis, we can start an N-acetylcysteine. That helps to detoxify the toxic agents.
But the patient will appear, get admitted in so many days later after consumption of poison, because it is totally asymptomatic for the past, initial 3 or 4 days.
Yes.
Thank you, madam. Yes.
Anything can be done to ban these products, sir, since government has taken some initiative?
Yeah, government of Tamil Nadu issued a GO on this, rightly to say 9 months back. But after the GO, there is a number of cases are increasing in so many centers. After banning, not only ratol, but also the other OPC poisoning, we got a GO issued by the government of Tamil Nadu, and insisting the district collectors to go and have a ride along with the food safety and drug controller. But there is an increased number of cases till now. Very specially mentioned is the Delta region, like Tanjavur, Nahapatnam, Kadalur, up to Kadalur. Vellore is also an important center to note.
But if you ban the rat killer, the rat population will rise.
Leptospirosis.
That will cause more economic problem.
Yes, sir.
Thank you.
Thank you,
Thank you, sir.
We will go on to the next topic.
Thank you, ma'am. It is our pleasure to invite Dr. Narasingan sir from Chennai to deliver the following talk on lipids.
It's not going to be a lecture. At the outset, I would like to thank all the organizers of TAPICON for giving me this excellent opportunity to be here this afternoon. But it's not going to be a regular lecture. What I have decided to raise some questions and then try to find out some answers from you. If you are not coming out within 30 seconds, probably I will give the answers to you. The first question that I am raising is that when will you send your patients for lipid profile? When will you send the patient for lipid profile testing? At what age? From the age of 20. I think the Lipid Association of India has come to a consensus statement that it should be around 18 years of age or at the time when the person enters into the college. That's number one. If somebody has a family history of premature coronary artery disease, death in the family, or a familial hypertriglyceridemia or familial hypercholesterolemia, I think it is mandatory to submit such patients. Probably you should try to advise the lipid profile screening at the age of 2 years, So do you prefer fasting or non-fasting lipid profile? What will you prefer? Non-fasting, okay. Non-fasting versus fasting concentration. The lipid profile is normally taken in the fasting stage, which we had been practicing traditionally. The advantages of non-fasting lipid profile is that the sample process is simplified to patients, simplified for clinicians, simplified for clinical labs and hospitals. Usually, it is successfully seen in those population cohort studies also. In randomized control trials which had used the statins, they have done only the non-fasting samples. Increases the compliance to the lipid lowering therapy. In fact, if you analyze the data that is available with us, more than 1.5 lakh patients were observed fasting and non-fasting. They have seen that triglyceride levels go only about 26 milligrams over and above the normal values which are seen in the fasting state. I think it is mandatory to submit your patients only for non-fasting. This slight increase in the triglyceride, postprandial hypertriglyceridemia may not be really significant for us to proceed further. Non-fasting lipid and the lipoproteins are actually predict the cardiovascular risk much more. Most people eat regularly. We know that we don't keep our stomach empty all the time. We know that we keep only about 3 to 4 hours of fasting. That's not correct for us to get submitted for a fasting lipid profile. The recent guidelines also shifted the recommendation only for non-fasting. It is convenience and supported by several studies. Initially, non-fasting lipid profile, testing becomes very simple. For severe risk assessment, yes. Somebody is admitted in ICU with ACS, you need to probably submit the patient for a non-fasting lipid profile. In children, becomes easy and preferred by the patient. If a patient doesn't want to come on the next day, do it. Diabetic patients, as and when they walk in also, you can draw the samples for lipid profile in the elderly and in the patient with a stable therapy. The fasting sample may be required. Fasting sample may be required when the non-fasting triglycerides are more than 400. The known hypertriglyceridemic patients are followed in the clinic, or patients who have developed pancreatitis are followed in the clinic. You need to submit the patient for a fasting lipid profile. In fact, if you want to see some drugs which will have an impact on increasing the triglyceride level, these are the drugs like steroids, estrogens, tamoxifen, retinoic acid for acne, and L-asparagine. If you are planning to give this sort of treatment to a patient, I think it is mandatory to submit them for a fasting lipid profile. Do you calculate LDL cholesterol using Friedewald formula? How many of you are doing it? Nobody is raising the hand. Friedewald formula. Do you still prefer to use Friedewald formula? In fact, that formula was introduced way back 1972. A simple example I will tell you. Total cholesterol, if it is 200, and if the HDL cholesterol is 40, total cholesterol minus HDL cholesterol comes to non-HDL cholesterol is about 160 milligrams. Then the triglyceride divided by 5. You take 150 as a triglyceride value divided by 5, it comes to about 30. 160 minus 30 is the value for the LDL cholesterol. That is the Friedewald formula, which I simplified it, giving some examples so that you can arrive at the simple calculation which gives you an idea about the LDL cholesterol, which we had been practicing it in the past. And it has been, as a traditional practice, we have been doing it also by using the Friedewald formula, but it's no longer valid because cannot be considered to be useful in those patients in whom you have a triglyceride levels of more than 400 milligrams. Of course, we need to accept the Friedewald formula as a quick calculation, inexpensive alternative used for the clinical purpose, served as a global standard for lipid analysis in the past 4 decades. The next question is, do you advise direct LDL cholesterol measurement? I think only 1 or 2 persons rose the hand in the previous question. I think many of you now agree that it is for the direct LDL cholesterol measurement. In fact, the CDC had not approved the direct LDL cholesterol measurement, though they directly tell you that you should submit your patient for total cholesterol, triglyceride, HDL direct measurement, whereas they did not recommend the direct LDL cholesterol measurement because of the non-availability of a good standardization. But the National Cholesterol Education Program has come out with the recommendation that the laboratory reagents should be approved by this organization for you to go ahead in submitting your patients for a direct LDL cholesterol measurement. If you ask me the correct method of doing it, which we don't practice it, analytical ultracertification, that is a beta quantification, it is a gold standard technique, it is very, very slow process, costly, really, it is very, very costly and used only for research purpose. What are the parameters that you ask normally in lipid profile? What are the parameters? You ask for your total cholesterol, you ask for triglycerides, HDL cholesterol, direct LDL cholesterol. Hereafter, I think most of you probably will now come to understand that we need to submit our patient only for direct LDL cholesterol measurement because that is the correct value which you can obtain. Non-HDL cholesterol, total cholesterol minus HDL cholesterol, you get non-HDL. This has got a lot of significance now in the recent past. What is remnant cholesterol? Total cholesterol minus HDL cholesterol, it is non-HDL cholesterol minus LDL cholesterol. That gives you a small value, that is about 20 to 30 milligram, that comes as remnant cholesterol. There is an extended lipid profile. Nowadays, we ask our patients to go for one ApoB estimation, most important. Number 2 is ApoA estimation. If you are very keen in submitting your patient for an ApoB, ApoA ratio, that can be done. Lipoprotein little a, I think you should not consider that is little. It is not at all little anymore. It is a one that should be considered as most important, and it should find a place in the requisition that you should ask your patients to go for LPA estimation all through. What is non-HDL cholesterol and what is the significance? Non-HDL cholesterol. I think way back 2001, the NCP ATP theory guidelines started telling, after controlling the LDL, if a triglyceride is more than 200 milligrams, you should ask for a non-HDL cholesterol. It is nothing but a simple calculation. Total cholesterol minus HDL cholesterol, you get a value, and that value has got a lot of significance in predicting the cardiovascular risk. So all atherogenic lipoproteins come under the label of non-HDL cholesterol. If you remove the HDL cholesterol, which is anti-atherogenic, from the total cholesterol, whatever is remaining, that is considered under one category, and that is called non-HDL cholesterol, which includes LDL, VLDL, IDL, lipoprotein little a, chylomicron remnants, and VLDL remnants. Everything together is considered as the non-HDL cholesterol. If you look at the data, those patients who received statin therapy, you can just see the bars. Whatever the level that you are reaching as far as the LDL cholesterol is concerned, the levels that are reached by the non-HDL cholesterol is still have the higher level. The hazard ratio for getting the subsequent cardiovascular events is much more in those patients in whom you are not able to control the non-HDL cholesterol, thereby showing there is a residual lipid related risk. So this is very important in obese people, diabetic people, metabolic syndrome, and those people who are already on statin therapy, very accurate. And in fact, the Lipid Association of India has given a special category, the co-primary target. It is not a primary target, it is a co-primary target. Statins are the first line agent. If you want, you can use ezetimibe to control it. If you want, you can use icosapent ester to control the non-HDL cholesterol. What is ApoB? What is this risk in atherogenesis? There are two forms. One is ApoB100, which has been seen in all the things, LDL, VLDL, IDL, LPA, and all those things will contain ApoB100, whereas the ApoB48 will be seen only in chylomicron and chylomicron remnants. And then 90% of the atherogenic particles contain the ApoB. That is most important, and we need to realize that it has got a lot of significance. If you measure the LDL cholesterol, the cholesterol that is contained not only in LDL, but also the cholesterol that is contained in LPA also comes as a general value of LDL cholesterol. That has to be kept in mind when you're talking about the LPA. And then the ApoB is responsible for atherogenesis much more than your LDL. So please remember that atherogenic dyslipidemia should be having a category called ApoB in addition to the high triglyceride, low HDL, and then the small dense LDL cholesterol. Apart from the three, you should also consider ApoB as one of the parameters. In fact, the LDL cholesterol, the cholesterol that is contained in not only in LDL but also in LPA. What is non-HDL? It is the cholesterol content of all atherogenic lipoprotein particles, whereas ApoB concentration is the number of all atherogenic particles. What is LPA? What is LPA? Can anybody tell? Who are the patients suitable for LPA estimation? LPA is a small LDL particle which has got ApoB. It is actually bound with ApoA, which is coming in the form of crinkles. These crinkles have got almost a similarity to the plasminogen, thereby increasing the tendency for procoagulant, pro-inflammatory, and pro-atherogenic effects. Very, very atherogenic. If you have elevated levels of LPA more than 50 milligrams, significant. Studies have shown that anything that is going beyond 100 milligrams of LDL cholesterol, more than 90th percentile in population-based studies clearly indicated that people are at a risk of developing one myocardial infarction, stroke events, peripheral artery disease, heart failure, and then the ischemic stroke. In addition, people also die due to uncontrolled elevated levels of LPA. So when will you submit your patient? Anything above, anybody who is above the age of 18 years, please get them submitted for LPA. Premature coronary artery disease, yes, LPA. Premature death in the family, yes. Hereditary hypercholesterolemia, yes. And those people in whom you are getting recurrent attacks of stroke, in fact, I had a patient who suffered not only from myocardial infarction but also stroke, in whom I did not do a LPA in the beginning. Subsequently, when I did the LPA, it was 180 milligrams. So that shows we need to be very careful in analyzing the data. What do you know about remnant cholesterol? The remnant cholesterol studies have shown that it is higher in those people in whom you have uncontrolled hypertriglyceridemia. Uncontrolled hypertriglyceridemia, it is very high. It's not only the LDL that is important for atherogenesis, but also the remnant cholesterol. The remnant cholesterol increases the free fatty acid and it creates an inflammation that probably is responsible for subendothelial entry of the remnant particles to create atherosclerotic cardiovascular disease. Look at chylomicron, the larger particle, more of triglyceride. It will not enter into the subendothelial surface. Atherogenic dyslipidemia, is it important for only diabetic people? No. It's also very important for those people who are seeking advice for metabolic syndrome. I think this favorite slide would have been seen by you, all of you, for many, many times. I don't want to dwell here. How the triglycerides are high, how ApoB is high, how small dense LDL is high, how HDL is low, how things are happening in the pathogenesis, which I don't want to probably elaborate it. So the net result is that high triglyceride, low HDL, increased proportion of small dense LDL cholesterol, and ApoB are the 4 components, not the 3, 4 components of atherogenic dyslipidemia, which you see not only in people with metabolic syndrome, but also in diabetes. Non-fasting triglyceride is more, how are you going to manage obesity problems? I don't want to dwell too much on these issues because many of you know about triglyceride and its management. If you raise questions, I will answer that. What are the relations between HDL and ASCVD? I think HDL is one of the important ASCVD risk factor. But increasing the HDL by any means, including pharmacological means, did not show any sort of cardiovascular benefit at this stage. Then do you normally calculate ASCVD risk? I was not doing it in the last, I think, 10 years back, I was not doing it. But now I am doing it because we know how to do it. The European Society has come out with a score system which we don't practice. ACC, AHA came out with the calculator, we don't do that. But the European Society of Cardiology tells you that people who are having a very high risk should keep the levels less than 55 milligrams, over and above 50% reduction in the LDL cholesterol. Very extreme group, 40 milligrams. This is the algorithm which was published by Lipid Association of India. If LDL is between 100 to 129, low risk. Between 130 to 159, moderate risk. High risk, 160 to 189. Very high risk, more than 190. Suppose the patient has already developed ASCVD, he comes under the extreme risk group. Group A, Group B. Group A with an increasing high risk feature added, or a diabetic person, or a homogeneous, or homozygous familial hypercholesterolemia. If those patients require reduction of LDL cholesterol less than 50 milligram, optional is 30. Whereas the patient in whom you have polyvascular disease, diabetic person with the multiple risk factors, ASCVD, you need to keep the levels less than 30 milligram. So that is again another advice. So this is the target values of LDL cholesterol. Number 1, very high risk group, 50 milligrams and less than that. Extreme risk, less than 50. Optional, 30. Extreme risk group category B, less than 30. Beyond that, it is not recommended, but we have just suggested from Lipid Association of India. How far that is going to be taken up by our people, I don't know. Lifestyle modification, I think all of you know about it. Look at the ICMR study from Hyderabad. It has come out with a good coverage of lifestyle modification for various diseases. One can go through that. I'm not going to go through that. Now look at the ACS management. In ACS management, what is new now, which I will tell you, this is the most important information which we had obtained. 2025, 10 days back. It was published only 10 days back. In case somebody gets admitted in ICU with an ACS problem, send the lipid profile, start the patient on drugs. If the patient has got a statin naive, start a high dose statin and then try to give him high dose statin plus ezetimibe. So, in case the patient does not show improvement at the end of 2 weeks or 4 weeks, probably you should add PCSK9 inhibitor like ebelacumab or aliricumab or inclisiran. So the types of patients, they have divided into statin naive patient, statin who received, they received combination drugs, people have become intolerant to statin. How do you manage? Based on the studies like Improve It, Racing study, Lodestar study, people have categorized how to go about doing it. Don't go in a sequential way as we had been doing it for treatment of heart failure. One after the other, one after the other. No. Move away from high dose statin, come to a learning that we should treat our patients with a combination drugs. Combination of lipid lowering drugs are the method by which one can advocate now for all our patients. How you are going to take it forward, how you are going to implement it in clinical practice, is going to be difficult. But please understand, if you don't give them an opportunity to use all lipid lowering drugs in combination, following acute myocardial infarction, you are losing the patient because he is at a high cardiovascular risk. So patients with acute coronary syndrome need to receive combination drugs. Wait for the high dose statin plus ezetimibe only for about 4 weeks. If they don't show a response, go for PCSK9 inhibitor as early as possible. In case they don't respond to that, or if they're not willing to buy PCSK9 inhibitor because of the cost, probably you can switch over to bempedoic acid. So that's how the flow of drugs have come into play to manage the patients with acute coronary syndrome. I think the ASCVD risk, after all this treatment, ladies and gentlemen, please remember that we have a lipid-associated risk. One is a cholesterol problem, 2, triglyceride problem, 3, LPA problem. Apart from that, you have pro-residual inflammatory risk, residual thrombotic risk, residual diabetes risk, and residual metabolic risk. I think all of us should come to know that these are all the residual risks which need to be tackled over and above the lipid lowering in managing patients so that they will have a comfortable life. Thank you very much, ladies and gentlemen, for patient listening.
So thank you, sir, for clearing all doubts about estimation of lipids and treatment in lipid in various conditions. So thank you, sir. Any doubt? We are short of time.
So what is the normal value for children? Is there any standard, Indian standard, normal value of lipids in children, particularly triglyceride?
Only triglyceride?
Yes, sir.
Triglyceride value. You want the...
In children.
In children. So it's very difficult. It has to be seen only as a percentile. What we recommend for our adult patients is that 150 and above is considered as abnormal. To keep it less than 100 milligrams of triglyceride, it is optional. But it's more than 150 is now recommended by Lipid Association of India as abnormal for adult population. ACC-AHA tells you that 175 and above is considered as abnormal for triglyceride. For children, that goes with the percentile, depending on the obesity or the carbohydrate intake, familial hypercholesterolemia, or familial combined hyperlipidemia, or familial hypertriglyceridemia. You need to rule out all those possibilities. Only then you can think about an increase in the triglyceride may be related to lifestyle factors.
So thank you, sir. So we'll go to the next topic.
Thank you.
Thank you, sir. It gives us great pleasure to invite Dr. Puneet Saxena from Jaipur to deliver Dr. Shivakumar guest lecture, Remission of Diabetes, Clinical Evidence and Strategies. I request Dr. Bharani ma'am to read the citation.
Association of Physicians of India, Tamil Nadu State Chapter is very much delighted to give this guest lecture oration to Dr. S. Shivakumar, guest lecture to Dr. Puneet Saxena. Dr. S. Shivakumar guest lecture is instituted in honor of Dr. S. Shivakumar, who is a renowned physician in Chennai for about 40 years. He was formerly Professor of Internal Medicine at Stanley Medical College. He had also served as a senior faculty in medicine in nephrology in Madras Medical College and Kilpatrick Medical College. He has contributed original research work in leptospirosis and malaria and is an international advisory board member in several textbooks in medicine. He is a regular faculty in several international academic forums, including the Association of Physicians of India, and published several papers in international journals. The Association of Physicians of India Tamil Nadu chapter, with great pleasure, is pleased to honor the prestigious Dr. S. Shivkumar guest lecture for the year 2025 to Dr. Purik Saxena, MD, FICP, FACP, FIACM, FRSSIDA, FRCP, FTA, FISC, FINAC, FIPA, FGSC, and FICCMD. Dr. Puneet Saxena is a senior professor and unit head at SMS Medical College, Jaipur, faculty in certificate course in evidence-based diabetes management and Public Health Foundation of India. He is a national vice president of APA, national vice president, chairman, Geriatric Society of India, national governing body member, Indian Society of Hypertension, national governing body member, Indian Association of Clinical Medicine, national governing body member, Clinical Cardiodiabetes Society of India, secretary, Indian Podiatry Association, expert member, Central Drug Standard Control Organization, Government of India, treasurer, National APICON 2010 Jaipur, treasurer, National RSSDA Con 2019 Jaipur, organizing secretary, National EPICON 2022 Jaipur, organizing secretary, National BPCON 2024 Jaipur. Dr. Puneet Saxena is a fellow of Indian College of Physicians, fellow Diabetes in India, fellow Research Society for the Study of Diabetes in India, fellow Geriatric Society of India, fellow Indian Association of Clinical Medicine, fellow Royal College of Physicians, Edinburgh, fellow Indian Society of Hypertension, fellow American College of Physicians, fellow Indian Podiatric Association, fellow of Indian College of Cardiology and Metabolic Diseases, fellow of Indian Society of Cardiology. Dr. Puneet Saxena is a life member of APA, ICP, RSSDA, Indian School of Medicine, Indian Society of Hypertension, Indian Thyroid Society, Indian Hematology Association, National College of Chest Physicians, Geriatric Society of India, Indian Society of Nephrology, IMA, HIV Society of India, Indian Society of Critical Care Medicine, Indian Academy of Clinical Medicine, Clinical Cardiodiabetes Society of India. He is a member of American Diabetes Association, American Association of Clinical Endocrinologists. He is also graduate teacher and examiner, written many chapters in medicine, update from 2010 to 2023, RSSDA Diabetes Update 2019-20, and monograph on obesity. He published more than 20 publications in Index Journal and invited faculty in many national and international conferences. He received many awards. Few are Distinguished Member Award, Diabetes Awareness Award, Scroll of Honor, Senior Physician Award, Excellence Award in Medicine, and Vivekananda Gaurav Samant and Rajasthan Yuvachatra Samantan. The Association of Physicians of India Tamil Nadu chapter takes immense pleasure and honor and award the prestigious Dr. Shivakumar guest lecture to Dr. Puneet Saxena at the 21st Annual Conference of AP Tamil Nadu State Chapter, TAPICON 2025.
So, good afternoon, everybody, and it's a pleasure to be at Tamil Nadu for TAPICON 25. Thanks to my friend Dr. Palaniappan, Dr. S. Chandrasekhar, and the entire team of organizing team. And it's very nice to be amongst the API family. I've been associated with right from the beginning, and just now we had the president also, and I saw Dr. Muruganathan around also. And my close friend, Dr. Anupam Prakash, is also here, Dr. Nursing, and so on. So Thanks for the honor, and I'm humbled, and I've been asked to speak on remission strategies in diabetes, evidence and implementation. So this topic seems to be monotonous and boring, but it is of clinical importance because I think down the line, some years down the line, you will have patients, eligible patients, who will be categorized in the guidelines also, where you will be separating patients for remission. And if that happens, then probably, and it has to happen because looking to the numbers, just see this data, right? So this is the latest data of IDF in 25, and we still hold the rank number 2, and we are going to be there in 2050 also. And not only that, but undiagnosed diabetes also. So we need to do something rather than taking only the care of the patient, right, in the form of treatment and preventing and treating complications. We need to reverse the situation, and that's why the need of this. And we all have seen this graph, how the natural history of type 2 diabetes moves. And once diagnosed, it has been identified as an incurable chronic disease, which is not the case as on today. Why? Because weight gain and obesity is the main driver of type 2 diabetes. You can see over here, you have to see the reference BMI of 22, and as you move upwards and the BMI crosses 35, almost 70–80% people will have some form of glucose intolerance or maybe frank diabetes. So that is the situation. So it is the main driver. And why? Because there is a twin hypothesis, because of deposition of fat, visceral fat in liver and pancreas is hampering with the lipid metabolism and the glucose metabolism. And that is why there is dysfunction at those two levels, leading to the insulin resistance, the decreased insulin response to the meals, and this is how the natural history of diabetes will progress from normal to pre-diabetes, diabetes, and finally complications if you move from left to right. But then we have to make our patients move from right to left, and there is lying the best fruit of remission, and it is possible, it is not impossible. And that is why we have these two terms, reversal and remission. Reversal is a process and remission is a state. So reversal in a nutshell will mean reversing the underlying metabolic abnormalities leading to achievement of euglycemia without continued of any glucose-lowering medication. And remission is the state where you can achieve that. HbA1c of less than 6.5 and ideally less than 5.7, that occurs either spontaneously or following an intervention, and that persists for at least 3 months in the absence of use of glucose-lowering pharmacotherapy. So how you can do that? There are stages of remission. If you talk about type 2 diabetes, leave aside those who are on insulin, but somebody who's on OHA, just see that if somebody, look this slide from bottom upwards, from stage 6, where a person is on at least 3 anti-diabetic medications, you want them to be on reduced medication in form of 2, finally 1, and without medication for some period of time, and ultimately forever. And if you can achieve stage 0, where you can maintain the patient without medication for more than a year, that is the ultimate goal. And that's why these terms have been coined, and they came as ADA statement, where there was a partial remission if you can maintain somebody with to hyperglycemia below diagnostic threshold for at least a year, and complete remission is a complete normal glycemia, where HbA1c is less than 5.7 for more than 1 year duration without any pharmacotherapy, and prolonged remission is if it happens for more than 5 years duration. Earlier in the day, Dr. Shanmuguli was speaking on Mounjaro. So that was one of the strategies, right? So for long-term strategy, and coming to that, what are the 3 pillars for diabetes remission? So diet, exercise, and weight loss. Looks quite simple and can be achieved without spending also. It is just the motivation which is required at the level of both physicians and the patients, and the inertia has to go. We have to take this seriously instead of writing prescriptions and writing medications. If you just put stress on all these things, diet, low calorie, nutrient dense and protein rich diet, low carb diet, ketogenic, there are various mechanisms, but the main thing is low carbohydrate diet. If it is less than 10% of the carbohydrate in a day, it is very low calorie, low carbohydrate diet, and if it is 10 to 25, it is low, 25 to 50 is moderate carbohydrate, and if it is more than that. And Indian diet, up till now, we have been saying that the carbohydrate content should be around 55%, 60%. But if somebody is having diabetes, type 2 diabetes, obesity, or any of the metabolic problem, you have to switch from there to moderate, low carbohydrate and very low carbohydrate diet. And this is the systematic review and meta-analysis of 23 trials which have shown that in low-calorie diet for 6 months, only 6 months, may experience remission of diabetes without any adverse consequence. And it fares better than the low-calorie and low-fat diet, and show that 32% higher diabetes remission as compared to low-fat diet. So such is the importance of just cutting down, and this is the evidence of very low-calorie diet. It has been compared with intensive lifestyle with medications, and low-carbohydrate diet has fared better in these trials. So you don't spend anything, you just need to tell and teach your patient and ask him to follow out. This is difficult, but then coming to the second pillar is exercise, structured exercise program for at least 6 to 12 months. If it is combined with dietary intervention, it is important to combine it with dietary intervention, otherwise it is of no use. So 150 to 300 has been the conventional recommendation, but can be individualized, but it can lower down HbA1c by almost 0.5 to 0.7% on an average, and if it leads to weight loss of more than 10%, if it is combined with diet, then 50% of the people will become normoglycemic or euglycemic, and the sedentary times of more than 8 hours per day has to be broken. It cannot be like that somebody is going to gym for 2 hours and then sleeping for almost 14 hours in a day and not working will not work. You have to have good basal metabolic rate, and you have to break the sitting times, and you can just see the importance of 24-hour physical behavior. It requires not only exercise, but stepping, breaking sitting, sweating, strengthening, sleep is important, and chronotype. Being a normal chronotype is equally important. And it will have favorable effect on all the parameters shown over here, whether it's glucose, it's blood pressure, whether it's A1C, whether it is lipids, whether it is physical functioning, or whether it is depression, or ultimately the quality of life. So that is the importance of, and third thing is the weight loss, where the pharmacotherapeutics also have a place. So you have bariatric medical procedures which were touted as the metabolic surgery or diabetes remission surgeries, which is exactly not correct, but yes, it yields that result. And then dietary restriction, and then physical activity. So these are the various bariatric medical procedures which we have: the sleeve gastrectomy, the RNY bypass, the banding, and finally the biliopancreatic diversion. And just see the results. The sleeve gastrectomy will lead to 22% weight loss and almost, on an average, 50% diabetes remission, whereas RNY, which is more potent, weight loss of 30% and almost 80% of diabetes remission, and the BPD, the biliopancreatic diversion, will lead to almost 100% of reversal in obese patients where the BMI is more than 30. So that is the power, and it is backed by randomized trials. This is the list of trials which have shown that all these kind of bariatric surgeries, they have fared better than the intensive lifestyle management plus the best of the medications as per the protocol. So coming to dietary restriction, final word, you have to restrict the calorie, you have to restrict the carbohydrate, you have to reduce the fat percentage, and that is you have to modify. And just see here the role of diet in weight loss. If you can achieve more than 15 kgs of weight loss by diet, 86% of remission in obese people. Somebody is weighing 100 kgs, if he drops down to 85 kgs, just imagine what he can achieve in long term. And these were the landmark trials. The direct study, which was a British study, although a very small study, which first time showed that you can achieve the remission by diet and exercise alone. And these were the results, and they were maintained for 2 years in this study. It's not that you have achieved it temporarily, and more than 10 kg body weight loss can lead to 65% remission. That was the evidence which came for the first time, and those who were treated early were having the best results. And this was, again, the twin hypothesis has been placed again here. You reduce the visceral fat, you want liver and pancreas to function much better way, and that is also one of the mechanisms. Not only the remission, but the complications of diabetes in the look ahead study, if you advise for lifestyle interventions, have shown to be effective in achieving remission and reduction of the complications. So prevalence of remission, duration of remission, And finally, those who achieved diabetes remission through weight loss trials had 40% fewer heart problems and 33% less kidney disease. So you can avoid that CKM syndrome, which is being talked about nowadays because of this. Now coming to the pharmacotherapy, I'm going to skip this. Yeah. So coming to the medications. So this is the summary of strategies for type 2 diabetes remission. Short-term intensive insulin. Then you have SGLT2, then GLP-1 receptor analogs, which have found the place nowadays in the hierarchy of the treatment as per ADA for atherosclerotic cardiovascular disease and heart failure. But soon you will have these drugs recommended for diabetes remission, and with that day it's not far away when you will have a separate category or a drop down where you will choose patients for remission and will have a list of drugs for achieving that. And then you have bariatric surgery, and you have metformin-based combinations which are weight neutral. They can also help. Something about the short-term intensive insulin therapy. So there have been trials, especially in the early stage of type 2 diabetes. If you use continuous subcutaneous insulin, even for a short period of time, as shown in this study for 2 weeks, it yields results by giving rest to the pancreatic beta cells and other mechanisms where you can have long-term impact on euglycemia or maybe reduced requirement of medication for controlling blood glucose. So there have been many trials on these drugs for the SGLT, and I cannot mention here because it's beyond my scope, but just combination of one of the SGLT2 with oral semaglutide shown over here can lead to 55% near normalization rate of glycated hemoglobin. So 55%, these two drugs can, and SURPASS and SURPOUND was being talked in the afternoon. So we saw the results, both these trials, and it has been shown that weight loss achieved in both these studies to the tune of 20 to 25% can lead to significant remission of diabetes. And that is happening in practice. I personally have now almost 80 patients on Mounjaro, and I've been analyzed, and almost 50% of them are diabetics, and almost 70% of them are touching normal glucose levels, and they are now without any other anti-diabetic medications. So that is the kind of response which is coming. But this is not easy. There are challenges for diabetes remission. So direct trial, you can see only 20% people stuck to the dietary instructions which were given in the trial. Same thing happened in the diabetes prevention program. Out of 1,58,000, only 3,200 could complete the tenure of the trial because of the restrictions which were laid on. So that was the problem. Then the other problem is that if you withdraw the anti-hyperglycemic medications and anti-hypertension, there is a chance, rare chance of rebound. And you have to follow the patient. You never know when they will become overt again and can have complications. So that is the problem. So summary of interventions, if you see here, the diet, surgery, lifestyle, and pharmacological, they have benefit on microvascular, cardiovascular, cancer, and quality of life. But the problem is that not all of them have enough data to support what you call as evidence-based medicine, especially for the very low carbohydrate diet. For surgery, you have data. For pharmacological agents, you have data. But for lifestyle and diet, you don't have enough data because you don't have any randomized trials, enough randomized trials long-term which can suggest that. So finally, coming to the last part, the consensus report is like that remission is the best word which has to be achieved. The process is reversal. Cure is not to be used because you cannot cure that disease, and the HbA1c has to be kept below 6.5 if you want remission, and ideal would be to have it less than 5.7 for at least a year, and for long-term remission it has to be for more than 5 years without any medication. So the international guidelines especially recommend early type 2 diabetics who are willing to undertake this intervention and achieve more than 10% weight loss are more likely to achieve type 2 diabetes remission, and type 2 diabetes should not no longer be seen as an irreversible natural course accompanied by progressive beta cell failure, and remission can be achieved by any of the modalities, whether it is surgery or intensive therapeutic measures or lifestyle modification, and it can be sustained also. It has to be achieved through a personalized approach, and there is a paradigm shift in our understanding of type 2 diabetes mellitus, and it may be necessary, rather it is necessary to change the concept of type 2 diabetes as an urgent condition. The moment you see a type 2 diabetes, one should evaluate whether he can be reversed or he can be put into a state of remission, and based on that, they require rapid intervention rather than snubbing it off as a chronic progressive disease and just writing a prescription of management. So while remission may not be possible or appropriate for everyone living with type 2 diabetes, it offers hope for many. And I hope after listening that again and again at different platforms, we would be practicing this rather than only listening it. Thank you very much.
So thank you, sir, for delivering the prestigious Dr. Shivakumar guest lecture. Thank you, sir.
Thank you very much.
Thank you, sir. Let us now invite Dr. Chandrasekhar from Chennai to share his valuable insights on pulmonary embolism and edema.
Okay, Thambi. 18 minutes. Shall I begin, sir? With your due respects to the chairpersons and dear organizers, thanks for the opportunity. It's a wonderful gathering, even in the lunchtime. So I'm going to talk about the pulmonary embolism. So this is a very common condition. Many times we see patients with chest pain, breathlessness, syncope and pre-syncope in the emergency department. But many times we fail to make a clinical suspicion of a condition called pulmonary embolism. So this is the most common vascular event next to myocardial infarction and stroke, and it is the second commonest cause for the unexpected sudden death. So many times the patient will be brought dead to our ED. So this is one of the common condition, and of course it increases with the age. And the problem is 1/3 of the patients who die of pulmonary embolism, they do so within the first hour of the presentations. So we all know the conventional risk factors, like we know the pointer. So this is the high risk patients, like you can see the high risk patients in addition to any surgical or orthopedic conditions or surgical conditions. There are many medical conditions, remember that, like hospitalization for the heart failure, atrial fibrillation, diabetes, hypertension, obesity. It's a cardiovascular continuum, so where the patient gets both arterial and venous thrombosis. If you could see a lot of the things which are depicted in the red color, where the medical condition that can cause the pulmonary embolism. So what about the pathogenesis? Why we should worry about that? Like whenever a patient gets a pulmonary arterial thrombosis, there is an impedance to the pulmonary vascular flow, and there is a vascular resistance goes up. As a result, like your right ventricle goes on to dilatation, stretching, and resulting in the neurohormonal activation, and it causes some kind of stress to the myocardium of the right ventricle. We all know that, like, the right coronary artery, which supplies the right ventricle, is bit different from the left coronary artery, where it receives the blood supply during the diastole, whereas the right coronary artery receives the blood supply both during systole and diastole. So it suffers both during the systole and diastole, and as a result of which, like, it started deteriorating, started failing. So once it started failing, the stroke output that comes from the right ventricle goes down. Eventually, the left ventricular stroke output also goes down, and the patient begins to develop a hemodynamic instability in the form of hypotension, syncope, cardiovascular collapse, and so on. How do we differentiate? The massive pulmonary embolism. If somebody is presenting to you with a blood pressure of 90 millimeter and less than that, and or if they have a drop in blood pressure of systolic blood pressure of more than 40, recurring inotropes or some kind of circulatory support, we call that as a massive pulmonary embolism. Submassive pulmonary embolism is without a hypotension, but the patient would do exhibit some signs of right ventricular strain, dilatation, stress, or the biochemical markers like TROP or BNP would be elevated. A patient is having only risk factor, but no dilatation, no marker elevation, they comes under the low risk. What are all the clinical presentation? Any patients, I repeat, any patients who present to you in the emergency department with chest pain, dyspnea, presyncope or syncope with no obvious cause, please look into the evidence for pulmonary embolism. So it can present with hemoptysis, fever, unilateral leg swelling. For DVT is another thing which we should look for. But again, please remember that this is the very common presentation. The patient present to you with persistent hypotension, present to you with right ventricular failure, present to you with broad death, cardiac arrest. So that is the evidence for massive pulmonary embolism. How do we diagnose? ECG is, of course, the very easy tool by which we can suspect and sometimes make a clinical diagnosis of the pulmonary embolism. Obviously, they may have tachycardia, right atrial, right ventricular strain, and S1Q3T3, which is called a McGinn-White, which is present in 10 to 30% of the individual, not in all. The right bundle branch block, and sometimes the atrial arrhythmias also. So these are all some of the ECGs which you could see, which you could appreciate the S1Q3T3 and T-wave inversion in V1 to V4. And this is another patient where the sinus tachycardia with T-wave inversion in V1 to V4 suggestive of pulmonary embolism. Again, another patient with T-wave inversion with RBB and in the precordial leads V1 to V3. The next common investigation which we can order is the chest X-ray. Remember that like chest X-ray can be normal in patients with pulmonary embolism. A patient with a normal, near normal chest X-ray with evidence of hypoxemia, suspect pulmonary embolism. Of course, we should look for some classical signs like Westermarck, Pala, and Hampton sum. These are all some of the chest X-ray evidence of you can see the Pala sign and the Hampton sum. And the third investigation which we can do to make a clinical suspicion is the D-dimer. It has got a excellent negative predictive value. If somebody is having a normal D-dimer, you can virtually rule out the possibility of pulmonary embolism. But please remember that the D-dimer physiologically increases with the age. Anyone after the 50 years, if you want to calculate the D-dimer, the formula is very simple, age into 10. So that is the value and above which you should suspect a patient to have some evidence to say that pulmonary embolism. Echocardiography is another common bedside tool which we can do. Of course, what you should look for the right ventricular strain, dilatation. Of course, you should look for some of the signs like 60-60 or McConnell signs also. If somebody is having a right ventricular strain, dilatation, so these are all the patients who are at risk of developing more mortality. So you should intervene immediately. That is the one. And they should present to us with hemodynamic instability. So these are all some of the echocardiographic features. The venous Doppler, 30 to 40% of the patients with pulmonary embolism, they may have a DVT, not all. So you should look for it. So where do we look for? 4 points, 2 in the groin and 2 in the popliteal region. And incomplete compressibility can give us some idea that the patient is having a DVT. This is another investigation of choice, CT pulmonary angio, where we can visualize the pulmonary artery up to the segmental levels. Of course, in addition to that, it has got other advantage also. You can also see the right ventricular dysfunction. If the patient is having other causes for condition causing hypoxemia, like pleural effusion, ARDS, or some pneumonia, all these things can be visualized. This is becoming obsolete, lung scintigraphy, where the patient can have some ventilation perfusion defect. This is the picture showing the impaired perfusion in VP-shunt. And this is the gold standard, pulmonary angiography, which can detect as small as 1 to 2 millimeter of occlusion, and you can see the filling defect or amputation of the pulmonary artery branch. The other investigations like MRI pulmonary angiogram is gaining more important particularly after the pipette 3 study, and you should look for the biomarkers like troponin and BNP levels and ABG. So these are all some other tests which you can do. There are many scorings are there. Don't worry about that. All these scorings are downloadable from internet. This is based on the risk factor like immobilization, malignancy, previous history of VTE kind of thing, and the patient characteristics, age, blood pressure, the tachycardia, the hypoxemia, presence of hemoptysis. So these are all some of the patient characteristics that can help one to suspect that the patient is at risk of developing pulmonary embolism or not. What is the treatment? So the treatment is to restore the hemodynamic and respiratory support. And once you suspect that patient is having a pulmonary embolism, always assess for contraindication and complication. So you should look for the contraindications for thrombolysis and anticoagulation. Since the patient is in hypotension, our junior doctors may be in a hurry to push lot of fluid into it. We should remember that less is more, and we should give only a minimal fluid challenge. Small allocates of 100 to 200 ml of normal saline is sufficient. If the patient is found to be hypotensive, norepinephrine is the treatment of choice. You can start with 0.1 to 0.5 or 0.3 mics per kilogram body weight per minute. If the patient is still not responding, we can go ahead with vasopressin. Maybe if still the patient is not responding, we can go for other inotropes or some other measures which I will deal you shortly. Oxygen is the one thing to correct hypoxemia, but please remember the hypoxemia is not the problem. The hemodynamic instability in patients with pulmonary embolism is the significant contributor to the worst mortality. Please remember that. Sometimes the patient is having low GCS, we may have to do a intubation. Please remember that during intubation, the patient may crash. The hypotension may get worse and patient may collapse and end up with, a patient dying in front of you. So you need to be very careful. Try to avoid NIV. Choose your patient. Try to avoid ventilation also. There are some inotropes which are gaining some interest in the recent past, levosimendan, because of its vasodilatory effect in addition to the inotropic actions. So some of the drugs like prostacyclin and nitrous oxide are the rescue therapy. The important message is you need to identify the patients who are all the patients who can receive the thrombolytics. If you have a patient with a cardiac arrest, if you have a patient with a hypotension which is not responding, if you have evidence of CT evidence of a filling defect, if you have a echocardiographic evidence, these are all the patients who are at risk of, the indications for a thrombolytic therapy. So the thing is, there are many agents are available, alteplase, tenecteplase based on the weight or streptokinase. But the thing is, this thrombolysis you can give up to 48 hours of symptom onset. So we have a golden period for stroke and MI. For pulmonary embolism, it is extended up to 48 hours, please remember. And after the thrombolysis, they need to be on anticoagulation with ultra-fractioned heparin. So the second option is, if you don't have the facility for immediate thrombolysis, better anticoagulate them with heparin immediately. If you are in a limited source setup, then start the heparin at the dosage of 80 units per kilogram IV bolus, followed by 18 units per kilogram per hour. Low molecular weight, it has got some specific indication in pregnancy, obesity, patients with recurrent pulmonary thromboembolism or VTE or extreme obesity. Remember that you need to go with weight-based therapy of low molecular weight heparin. So if you are going to start the patient on enoxaparin, it's 1 milligram per kilogram body weight, not 40 milligram, usual thing. NOAC, all the patients who are put on the anticoagulants with heparin, it should be continued with NOAC. So we have got DABI, we have got 10A inhibitors like rivaroxaban and apixaban. It depends on the individual's experience, like they can be on these NOAC. It should be continued for 3 to 6 months, please remember. There are some other the therapeutic modalities also available, like they are the CD, catheter directed thrombolytic therapy. So where they have, so where they can do thrombus fragmentation or lysis of the thrombus or suction of the thrombus as well. So venous filters is again has got a very few indications. Patients who are at risk of developing a bleeding disorder, contraindicated to anticoagulant or thrombolysis, and patients in the perioperative period, pregnancy, where we can have this venous filter. Please remember that like none of the trials have shown any survival benefit with the IVC filter, because it doesn't prevent any recurrence of the DVT, or sometimes it can allow the embolus to pass through also. So please remember, once the patient is placed on IVC filter, it should be removed as per US FDA guidelines. It should be removed in 25 to 54 days. So I'll show you some of the case studies. She's diabetes hypertension who was showing S1Q3, presented to us with hypotension and echocardiographic evidence of right ventricular involvement failure. She was thrombolized and she became better. So this is another elderly gentleman with COPD and had breathlessness. Again, the ECG showed echocardiographic evidence of pulmonary embolism with the markers being elevated. He was not willing for the thrombolytics. He was put on anticoagulants. The third case is hypertension, diabetes, CKD, admitted with the stroke and discharged. So after that, the patient developed sudden breathing difficulty, and the patient cannot be an ideal candidate for thrombolysis because of the recent CVA which the patient had. So finally consulted with the patient, and we used a device therapy, and this is the angiogram showing the filling defect on the right side, and catheter directed thrombolysis was done, and you can see the bits of the thrombosis, and now you can see the restoration of the pulmonary circulation. So in summary, it needs a strong suspicion. The patients with pulmonary embolism can be asymptomatic. The acute pulmonary embolism is devastating and required prolonged resuscitation. D-dimer is a very good test in limited resource setup, and CT pulmonary angiography is the diagnostic tool. Thrombolysis, oral NOACs are the mainstay. There is always, it's an enigma, I said. There are always lot of questions remains with pulmonary embolism. Even with the thrombolytics, can we have a failure? Yes, the literature says that 15 to 27% of the patients who receive thrombolysis can have a failure. What about the patient present to you with cardiac arrest? The patient present to you with cardiac arrest, so we need to, if the patient is having the risk factor, and if you strongly suspect that the patient could be suffering from could have had a pulmonary embolism that has led to the cardiac arrest, then you can take a shared decision making with the patient's attender, and even you can thrombolyze with off dose. That is the safest dose of alteplase is 50 milligram. What about in perioperative patients? Perioperative patients, in the first 2 weeks, we cannot thrombolyze, only anticoagulant. How to identify the patients with thromboembolic pulmonary hypertension? When somebody is having CT or echocardiographic evidence with the perfusion defect and pulmonary artery pressure is more than 20 millimeter of mercury, you suspect that the patient could be having a pulmonary hypertension related to the thromboembolism. Do we need thrombophilic workup for all? No. Only in patients with recurrent thrombosis or patient with Z history, you should go for thrombophilic workup. So it's unnecessarily you need to order for protein C, protein S, protein Z, or antithrombin 3 factor deficiency. All these things are unnecessary. Can you get a DVT while the patient is on NOAC? Yes, 40% of the patients still can develop a DVT despite NOAC. Can a upper limb DVT can cause pulmonary embolism? Yes. 6% of the patients, because in the ICU, the patient is put on various devices and lines. So that can lead on to, again, pulmonary embolism, 6%. The literature says 6%, but it does not require any kind of removal of the gadgets. Okay, you can just continue with the anticoagulation. Can a patient with the DVT can walk? This is a very common question among the primary care physician or with the patient. Once you start the patient on anticoagulant, after 12 hours, the patient can walk. Do all patients, immobilized patients, require prophylaxis? You are the better judge. You decide. Depends on the patient's risk factor and assessment. The role of graded compression stockings and intermittent pneumatic compression, it's again not a rewarding experience. Like it's better to put the patient to assess the risk of using the scoring. So these things are relatively kind of thing that may attract more attention to the patient, but it's not a rewarding experience for the medical profession to prevent a pulmonary embolism. So with this, I thank you all for the patient listening. Thank you. Thank you for the opportunity.
So thank you, sir, for your extensive lecture on pulmonary thromboembolism. Some 15 years or 20 years back, any controversial or undiagnosed deaths, they will put as cause pulmonary embolism, or in OG cases, that is amniotic fluid embolism. Nowadays, there are so many investigations are there to diagnose the pulmonary thromboembolism, and treatment also available. So thank you, sir.
Yes, sir. So there are some instructions. The long haul flights, the prolonged immobilization, whether they are traveling in a flight or in a car, more than 4 hours, if they have a risk factor, they need to be assessed, sir. Puneet.
It has got a very unique action. It doesn't act on the pulmonary circulation at all. It only acts on the systemic circulation. So the pressure comes up. So the vasculature of the pulmonary arteries, they have a less afterload. It's a very good drug. In my experience, I used the Fondaparinux 7.5, obese patients above 60 years. Quite safe and economical. I think me and Sharma always say, patient comes with unusual tachycardia, dyspnea, tachycardia. Clinically, we can suspect the patient has got a pulmonary embolism. Very nicely alluded lecture, Chandru. Well done.
Sir, I have one question. A patient a 26-year-old comes with pulmonary thromboembolism with no risk factors, and we did an APLA profile, only single was positive, only cardiolipin was positive. So how long should we continue? Should we repeat the APLA profile after 12 weeks?
APLA is positive.
Only one, sir, 1 out of 3.
So the patient has already developed a event.
Yes, sir.
A patient already developed a venous thromboembolism with a risk factor. The patient needs to be on oral anticoagulants for lifelong.
Even if it is a single...
Yes, madam. Okay. Like being a female, like you need to be very careful during the pregnancy. So you need to switch over to BARF, okay, or a parent, depends.
Thank you, sir.
Yeah.
So we'll close the session.
Yeah, thank you, sir.
I request the speakers to come onto the stage. May I now invite the chairperson to present a token of appreciation to Dr. Anita for her enlightening presentation. We request the chairpersons to kindly felicitate Dr. S.N. Narasingan with a memento in recognition of excellent session. To convey our heartfelt thanks, we now invite Dr. Puneet to present memento to Dr. S. Chandrasekhar.
Sir, group photo, sir. Sir.
I request Dr. Puneet to give mementos to the chairpersons. We request Dr. Puneet to present the mementos to the chairpersons. With that, we conclude this session. Announcement: we would like to inform you that the day three of the conference of TAPICON 2025
It's a great honor to honor one of my best friend and an advisor to Vellore District APA branch on behalf of our organizing secretary. Please come, sir. Incognito, Dr. Chandrasekhar has helped to prepare this scientific agenda. I am very happy to honor Vellore District branch of APA feels proud to honor Chandrasekhar ji. Anita? One. Thank you, sir. Thank you.
I repeat, announcement: we would like to inform you that the day 3 of the TAPICON 2025 will take place in GRT Hall, Vellore. We are honored to welcome Dr. Bala Vignesh and Dr. Kumaresan as the distinguished chairperson for the upcoming session. May I now invite the speaker, Dr. Anupam Prakash, for his insightful and engaging presentation. I now request the speaker, Dr. Anupam Prakash. We are honored to welcome Dr. Kaveri Kannan as his chairperson. We are delighted to welcome Dr. Muruganathan, who will be leading us into the topic. We are delighted to welcome Dr. Muruganathan, who will be leading into the topic blood pressure variability.
Good afternoon, everyone. At the outset, I must congratulate the organizing committee and the scientific committee for their excellent arrangements. I am also privileged to have my good brother, dynamic president, in the audience. But the most difficult thing to talk, especially after food. I know many people just had food in the relaxation mood. Don't worry, sit back and relax, as Indigo people says. But nowadays, if you say Indigo people relax, so many airlines now, they find it very difficult. Nobody now relaxes. So I told Nandini to do a program or project, check the blood pressure during the takeoff and then landing, so that you will know what's the blood pressure variability in the passengers. So that's how I connect the BP variability here. I will not take much time. I'll go to the subject again. This is my plan. First, introduction. Blood pressure variability has emerged as a pivotal and independent determinant of cardiovascular health with significant implications for mortality, morbidity, and treatment strategies. Traditionally, normally what we talk is hypertension management, controlling average blood pressure. But now the growing evidence says, and the many trials, many studies, technological advancement suggests that fluctuations of BP over different time frames may be equally, if not more, important in predicting cardiovascular events. We see commonly like this. See, Nandamar in Erodi is a good practitioner. With good BP control, everything is good. Suddenly they develop CVA. Last time Tuticorin Selvaraj also was mentioned about this project, this patient. With long-standing high BP, they don't develop any vascular event. Chronic hypertension, no problem. But somebody who's got BP control suddenly develop cerebrovascular accident. This is the new entity called BP variability. And what is it? It is rather than representing a background noise or a phenomena occurring at random, these variations are known to be the result of complex interactions between extrinsic environmental and behavioral factors and intrinsic cardiovascular regulatory mechanism, maybe neural, central, neural reflex, and humoral influence that are not yet completely understood. You can see, for example, same like Udas. Whenever he chaired a session, his BP is different. When he gives a lecture, the BP is different. When he goes to sleep, the BP varies. So in individual in a day, the BP goes up and down. Same way, within the individual, also one patient to another, there is a difference. You can see the first patient has got lower BP variability, the other person has got higher BP variability. Now, the BP variability classified into short term and long term. Short term is again divided into very short, beat to beat, and short within 24 hours period, minute to minute, hour to hour, and day to night. In long term BP variability, it is day to day or visit to visit or seasonal. And then very short term BP, I already told you. Then how do you diagnose very short term BP? It is measured using a continuous finger photoplethysmography or intra-arterial catheters. What are the physiological correlations? Reflex autonomic tone, cardiac output variability. Clinical significance, it is primarily used in research settings. Now, short-term BP, how do you measure? Ambulatory monitoring, and then diurnal patterns, circadian rhythm. I'll come to the circadian rhythm, what is circadian rhythm, and sleep, how sleep can influence the BP variability. The medium-term BP variability, mainly it is done by home BP monitoring. It also affects by lifestyle modification, medication effects. Whenever somebody takes medicine, the BP may go up, and especially long-acting, the BP is maintained. So like this, and also patient engagement. See, it also patients' involvement in their own care, increasing awareness of factors that influence blood pressure and potentially improving treatment adherence. Then coming to the long-term BP, that of course office BP measurement is the key, and you can see the disease progression and research value. So nowadays we talk only about office BP. We don't even talk about home BP and APBM. Only for the last 10 years I had been shouting and talking about the importance of home blood pressure monitoring. Then how do you assessment the BP? Quantification. These are the terms I think you should know. Standardized deviation, that is, standard deviation is the basic statistical measurement of dispersion around the mean blood pressure. And then average real variability, we call it ARV, calculated as the average absolute difference between consequent BP readings and superior to SD. And coefficient of variation, CV. And then this is another important thing, variability independent of mean. Now we call it as a smoothness index that used to be assessed the amplitude and distribution over the time in the treatment of BP. Then nowadays there is advanced BP qualification method. I think Anupam Prakash is doing this also in his institution. This is called weighted 24-hour SD, and then residual BP variability. And the recommended approaches, if you see, Sikitol advocates the use of ARV and VIM in both research and clinical setup. It's not come to the practice, but they advise this because this is very important diagnosing point. Then coming to situational of BP variability. Then all of you know white coat hypertension, mask hypertension, circadian variations, and then labile hypertension. Now coming to circadian variability. The APBM is the gold standard to find out the circadian variability. Beat to beat variability, day to night variability comes under dippers, non-dippers, reverse dippers, and excessive dippers. Night to day variability leads to morning surge. So what is nocturnal dipping? The correct time period for sleep and awakening should be considered. Poor reproducibility of the classification of hypertensives into dippers and non-dippers based on APBM. What is the mechanism of nocturnal dipping? Persistence of sympathetic drive, reduced sensibility of baroreceptors at night, volume overload in specific conditions, autonomic dysfunction, sleep apnea, diabetes, and aging. So these are the pathogenesis of nocturnal dipping. This non-dipping status is associated with cardiovascular risk, and nocturnal BP is independently predicts outcome. See, that's how the role of home blood pressure monitoring and APBM comes. When somebody comes to you, you check the blood pressure only in the office or the clinic. You don't know what is the blood pressure in the night. The nocturnal hypertension is the notorious, more than 30 to 40% of the patients who has got cardiovascular problem or stroke. If you find if you take a ABVM, they will show nocturnal hypertension. Then morning surge, again, the nighttime BP is normal, but early morning surge is there. You can see somebody sleeps well in the morning in their bed night, and when they get up, they develop CVA or heart attack. That is due to morning surge. There is no consensus definition of morning surge, but usually assessed by using APBM. Exaggerated surge is associated with target organ damage. Then this is the 3 patient A, patient B, patient C. You can see morning surge, how it triggers, and what are the risk factors in the morning surge. I already told you. Then what causes this BP variability? You can see the very short-term BP can be caused by increased central sympathetic drive, decreased arterial or cardiopulmonary reflex, humoral neurological behaviors, and then arterial complaints, then inappropriate dosing of titration of drugs, and decreased adherence of the drugs, and seasonal changes. These are the causes for very short-term, and long-term, mid-term BP variability. And this is a big tabular column algorithm. It gives everything. What is the definition? How do you diagnose? What are the indices you use? I already told you SDCV. And proposed mechanisms, I already told you. So if you know this particular tabular column, you will understand the whole BP variability. Now coming to is it relevant? See, we talk about BP variability. Is it relevant? Actually, it is really relevant because very short-term BP can cause subclinical organic damage, cardiovascular events, even renal outcomes. In short term also, again, subclinical organ damage, cardiovascular. So every BP variability leads to some problem or other. So this diagnosis of BP variability is important to find out why the particular person has got the CVA or cardiovascular. Then BP variability in a special population, especially older adults, typically exhibit greater blood pressure variability. Coming to pregnant women, you see, you have to have BP monitoring in pregnant women. There is a separate home BP monitor available for only for pregnant women. And pediatric patients, surprisingly, they also have BP variability. And then BP variability in diabetes and metabolic syndrome. Very, very important, because diabetic autonomic neuropathy and endothelial dysfunction, and the important thing is diabetic nephropathy. All these things can cause a problem. And of course, the mortality of the BP variability the mortality of diabetes is independent of the high BP. So somebody may have high BP, but still they may not develop. But if they have a BP variability in diabetes, they will develop more problems. Then international diabetic evidence. There are a lot of evidences are there. Indoco database, then Ogasma cohort, and then nighttime significance. All these things, especially if you see the Menoscia, Italy, he has said in cyst Europil trial, Ascot BP trial, all that trial says BPV reduction, if you reduce blood pressure variability reduction, can improve the patient's outcome. And then subclinical markers of BP variability, I already told you. If you do a carotid intima thickness, left ventricular hypertrophy, cognitive function. Recently, our president, Jyotirmay Paul, gave a project that, do the carotid media thickness and LVH in the hypertension patients. So subclinical markers, if you see, and it is correlated with the BP variability. Then BP variability and cardiac target organ damage. I already told you, myocardial overload, left ventricular mass index, BP surges and remodeling, and cardiac function status. Then if you take the MRI or image, white matter hyperintensities, cerebral microbleeds, and cortical atrophy also be there in a BP variability. So if you do the imaging, you can see this. And then particular diseases, especially neurologically, Parkinson's disease. Parkinson's disease is known to be an autonomic disturbance where you have orthostatic hypotension and supine hypertension. And then post-stroke, dementia, and then multiple system atrophy. Again, in the kidney, glomerular pressure, afferent arterial damage, inflammatory process, and integrated risk assessment. Then in chronic disease, I told you there is a autoregulation in the kidney. If there is a BP variability, the regulations, intraglomerular pressure varies, so impaired autoregulation, volume status fluctuations, thereby disease progress, and you have to consider treatment, the BP variability in a kidney disease also. And then these are the trials, we have already said, Ogasma trial, Women's Health Initiative, and then post-trial analysis of 17 visit measurements in 397 ESRD patients, third non-study, and Ascot trial. All these trials proves BP variability is the cause for problems. So one must know to detect BP variability. And now the newer methods. What are the newer methods available? This is very important. Recently in 2022-23, we have got so many newer methods called photoplethysmography sensors, tonometry devices, oscillometric algorithm, and there is a lot of cuffless monitoring has come. It's not come here, but in Singapore and all, you can get cuffless monitoring. You can have a ring which records blood pressure. You have a watch that records blood pressure. So that also detects BP variability. And then AI-driven analytics for BPV. You can get data collection, pattern recognition, and also you can do risk stratification with the AI, and with the AI, you can get clinical decision. And cloud-based platform. Nowadays, you would have learned this topic. What is cloud-based platform integration? Then electric health records, smartphone applications, and then remote monitoring capabilities. You see, somebody sits in the home, somebody sits in the hospital, then you can definitely check the blood pressure of the patient. Especially this is very useful in COVID. Ramesh Agarwal took this project when I told him to do in COVID, telemonitoring of the patients. Same way, the clinical applications of wearable BP monitoring, very useful in elderly population, heart failure patient, and for stroke recovery patients. Again, there are limitations of the newer trends because they have to standardize. Though it has come to the market, there are so many difficulties, measurement artifacts, validation standards, calibration accuracy, all these things are there. Then what are the practical implications? Based on BP variability, you have to select the drugs. What is the best drugs? Ambulatory monitoring, if you see in excellent trial, all three drugs produces same blood pressure effect. But amlodipine definitely reduces blood pressure variability compared to other drugs. So you can find out which drug is good for reducing BP variability. There are a lot of trials like Ascot trial. Only because of the Ascot trial, atenolol was thrown out. Compared to atenolol, amlodipine reduced the BP variability. Amlodipine reduces the central aortic pressure compared to atenolol. Then comes the stroke prevention. So if you do all these trials, you know which drug is good. I'm sorry, I'm rushing. So every drug should be, when you prescribe, you must see whether this drug has got long-term effect, whether it can reduce BP variability, like that. Now, the clinical evidence, there were 122,000 patients we analyzed, and 118 trials, all proved BP variability is important, and then updated guidelines important, and need for updated clinical guidelines. I think myself, Jyotirmay Paul are doing Indian hypertension guidelines in the API. We have to include these newer devices and device validation and bring this BP variability in our algorithm. And then personalized medicine approach. Now we talk everything about personalized. Precision medicine for cancer. Same way precision medicine for BPV phenotyping, which is very easily done, you know, in genomics and genetics, so good. So you can find out so-and-so will develop BP variability. So according to that, you can calculate risk and then you can give the treatment. Then patient engagement. You know, we talk so much, patient does not know. He'll say, sir, I was all right all the time. Suddenly, why should I develop? So tell them, educate them, what is BP variability, how to control this BP variability. Then the future research directions, establish BP thresholds, validate wearable device, BP targeted therapy, BP variability targeted therapy, predictive algorithm. So what are the takeaways? You have to develop evidence and you should do continuous development. Technological advancement is there, and I told you personalized approach. So high BPV is associated with development, progression, and severity of cardiovascular, vascular, and renal damage. Increased incidence of cardiovascular events and mortality independent of elevated BP, elevated mean pressure. Record BP as many times as possible. Always compare the previous visit so that long-term variability can be done. Amlodipine significantly reduces BP variability in stroke. Optimize the therapy, confirm adherence. So you see this Lebanese variability. I don't know how many of you have gone to Lebanese. So you go once Lebanese, one season it's full of ice. So you can walk and you can do skirting, everything. And if you go another time, it's full of water. So this is called Lebanese variability. Like this, BP also varies. So, but we are very good, especially APA physicians are always stable. இன்னைக்கு சொல்லிட்டு நாளைக்கு மாத்திரதில்லை, always we are stable and controlled. So thank you very much for the patient hearing. I think if you have any questions, I'll be happy to answer.
Nicely discussed, sir. I really want to say sharp and crisp. Particularly, we talk about or treat the office BP alone. Particularly, we don't say the variability, the significance of the variability in the person with hypertension. The two dippers, as I said, dippers, non-dippers. That's a important one. The CNS part of it. At the same time, as I said, amlodipine, the preferred drug for calcium channel blocker, dihydroephedrine for stroke, as I said. And another thing, the significance of, as I said, education. Educate the patient, the significance. They say that, sir, BP was normal in the home measurements, sir. Why do you want to give the antihypertensive? Like that, the importance of variability should be said, and you have nicely interpreted and discussed, sir. Thank you very much, sir.
In fact, I must thank our Vertigo, scientific chairman. He gave me so many variabilities. He said, your talk is at 3 o'clock in the afternoon. Suddenly he said 5 o'clock. Then he said, near the inauguration. Suddenly I came from lunch. I didn't even wash my hand. He said, come and talk. I said, okay. So the variability is there, but I am stable. So anytime I can talk. Thank you, Vertigo, to test my variability.
Any questions?
So thank you, Jyoti, for staying back. Jyoti Paul. Thank you for staying back, and we'll do a lot of projects on this also. Yeah, I'll join you in lunch. Thank you. Yes, Vetri.
Thank you, sir. Professor Muruganathan, sir. One thing I want to tell all of us, in his monograph, rather, in his manual on hypertension, he has described all the basic things which a clinician should follow. One among that is the hypertension variability, how glycemic variability is picking up among the diabetologists, and hypertension variability is a subject to be known to all, because control of this, when I used to say, if you are a diabetic or hypertension, it is better to have a normotension rather than a normoglycemia. Thank you, sir, for a wonderful
Yeah, not
narration.
only glucose, also anticoagulants. See, when you give anticoagulants also, there is fluctuation, so you must know. Because there is also coagulation variability. As you said, insulin variability, sugar variability, hypertension variability. And also this is human nature, no? We also are variable at so many times. If the food is not good, we get something. If the food is good, we make, and your hospitality makes us very calm, and thanks. Thank you very much once again for your patient hearing. I'll be glad if any one of you are interested to do any research project. As the Physician Research Foundation Director, our API role is to do this. And today evening, we are going to form the Tamil Nadu API wing. So Sedaraman and Gunasegaran must also come out with a lot of projects from Trichy, so that we can do a lot of good things for Tamil Nadu API. So we have a competition between various states, how every state is doing more research. My vision and dream is to have 100 100 research before this year is over. Because in API, we don't do many research. So my policy is publish or perish. Thank you so much.
We are proud to have you, sir, as one of the son of soil, to be in the forefront of world scientists. Thank you very much. Now it's a time to call our, I can tell is the best astute physician from Tuticorin, Dr. Selvaraj, to the dais to deliver the important lecture which have been waited for a long time. Reduce the speed. One has to reduce the heart rate, keep them in the normal space of 60 to 100. Let us witness Dr. Selvaraj's deliberation on the current management of atrial fibrillation. Dr. Selvaraj, sir.
With due respect to Chairperson, dear friends and colleagues, at the outset I am immensely thankful to the organizing team of the TAPICON Vellore and my friend Dr. Vertigo for giving me this opportunity. First I was told for a lecture, guest lecture for 30 minutes, so I prepared slide for 30 minutes. Now it has been reduced to 15 minutes. How Could I finish? Let me see. The first human ECG depicting atrial fibrillation was first published by William Newton in 1906, and subsequently Sir Thomas Lewis brought atrial fibrillation on the world map. The proof of a direct connection between absolute arrhythmia and atrial fibrillation was established by two Viennese physicians, Carl Julius Rothberger and Heinrich Weinberger in 1909. Atrial fibrillation is the most common sustained arrhythmia needing hospital admissions. It is characterized by low amplitude fibrillation on ECG and irregular ventricular rhythm, all you know. The incidence increases with advancing age, as shown in the ATRIA study. Overall prevalence, the atrial fibrillation was 1%. It is classified based on American Heart Association, American College of Cardiology, and Heart Rhythm Society and AF management. Paroxysmal, they self-terminate, that is within 7 days of onset, either by treatment or spontaneously. Persistent, it is defined as AF that fails to self-terminate within 7 days. Episode recur even with pharmacological electrical cardioversion to restore sinus rhythm. Long-standing persistent AF that has lasted for more than 12 months. Permanent AF, this term identify the individuals with persistent AF when joint decision by the patient clinician, then no longer a rhythm strategy is made. Lone AF seen in patients less than 60 years with no evidence of structural heart disease. This entity carries a low risk of thromboembolic complications. Diagnosed, AF is diagnosed mainly by clinical. That is, by clinical history, come for chest pain, dyspnea or palpitation, sometimes giddiness due to tachycardia. The physical exam is very, very important, which is the forgotten art nowadays. Juniors, they don't palpate the patient radial pulse. If you palpate the radial pulse, there is a irregular pulse. It is evidenced by the jugular venous presence, absence of A wave. Auscultation, there is a varying intensity of the first heart sound, the pulse deficit, and they confirmed by ECG, you all know. And the ambulatory rhythm monitoring is very important in difficult cases. Telemetry, Holter, event recorder, implantable loop recorder, pacemaker, defibrillator. Rare cases, electrophysiological study. AF requires rhythm documentation by ECG. You all know there is a irregular RR interval, no discernible distinct P wave. Still, you can have a regular RR interval in case of AV nodal ablation and complete heart block. Silent undetected AF is common when severe consequences such as stroke or death. It is usually diagnosed by ECG presence of low amplitude baseline oscillation, especially in V1, along with an irregular ventricular rate. FFs have a rate of 350 to 600 beats per minute, characterized by variable in their amplitude, shape and rhythm, in contrast to atrial flutter. The ventricular rate in patients not receiving rate control agent usually between 100 and 160. The risk factors are clinical factors, reversible risk factor, non-modifiable risk factor and evolving risk factors. Clinical risk factors like hypertension, diabetes should be kept in mind. Reversible risk factors like your valvular heart is commonest, rheumatic heart disease, aortic valvular disease, and non-modifiable risk factors like age, gender should be kept in mind. Complications of AF, stroke, most serious complication. Blood clots can form in the left atrial appendage due to poor blood flow. AF increases the risk of stroke by 4 to 5 times. Heart failure again can precipitate AF. AF can precipitate heart failure. Thromboembolism other than your stroke, pulmonary embolism rare if AF without prior AST and peripheral artery embolization. Cognitive impairment most common. And the chronic AF has been associated with silent cerebral infarct, impaired cerebral perfusion, leads to higher rate of vascular complications. Myocardial ischemia, rapid ventricular rate AF in myocardial oxygen demand can precipitate angina, MI, increased mortality due to combined risk of stroke, heart failure and other cardiovascular events. Complications from treatment, anticoagulants related bleeding, gastrointestinal intracranial hemorrhage. All the antiarrhythmic, keep it in mind, are pro-arrhythmogenic drugs. The procedural risks from cardioversion, ablation or pacemaker implantation. Management includes prevention of thromboembolism, most important, rate control, restore and maintain sinus rhythm, and treat the underlying cause so as to minimize the risk of thromboembolism. The rate control provides hemodynamic stability, avoiding low cardiac output symptom and prevent the development of tachycardia-induced cardiomyopathy. CCBs are one of the first-line drugs that both in acute and chronic rate control patients with AF. Regarded as class 4 antiarrhythmic drugs, they preferentially affect myocardial tissue with a slow action potential modulated by calcium currents such as SA node and AV node. Amiodarone is against the orally recommended dose is 400-600 mg divided doses for 2 to 2 weeks and maintenance dose 100 to 200 mg and intravenous dose is 150 mg over 10 minutes, then 1 ml per minute for 6 hours, then again 0.5 ml per minute for 18 hours are changed to oral therapy when patient is able to take medication. Contraindications, severe sinus node dysfunction and second and third degree heart block should be avoided in pregnant and breastfeeding women. Commonly used oral beta blockers for rate control include metoprolol, atenolol, propranolol, nebivolol, carvedilol, and bisoprolol, while atenolol, metoprolol tartrate, propranolol are beta blockers used for intravenous use. The rate and rhythm control is an integral part of management of AF patients, often sufficient to improve AF-related symptoms. The pharmacological rate control can be achieved for acute and long-term rate control with beta blocker, digoxin, calcium channel blocker, diltiazem, verapamil, or a combination therapy. A number of antiarrhythmic drugs also have a rate-limiting properties like amiodarone, sotalol, and to some extent propafenone, but they should be used only in patients with rhythm control therapy. In patients with heart failure with reduced ejection fraction, beta blockers, digitalis or other combinations should be used as digitalis and verapamil can be negative inotropy effect in patients with LVF that is less than 40 ejection fraction. Critically ill patients, those with severely impaired LV function, intravenous amiodarone can be used when excess heart rate is leading to hemodynamic instability. Urgent cardio should be considered unstable patients. Beta-adrenergic receptor blockers, monotherapy is often the first-line rate controlling agent largely based on observation of better heart rate control than digoxin. Interestingly, the prognostic benefit of beta blockers seen in heart failure with reduced ejection fraction patients with sinus rhythm is lost in those with the AF. The optimal heart rate target in AF patient is unclear. The RACE2 study randomized 614 patients with permanent AF to either target of 160 per minute at rest or 150 beats per minute during moderate exercise. There is no difference in a composite of clinical events. Catheter ablation or combination therapy is often effective when antiarrhythmic therapy fails. Management including catheter ablation, combination therapy, and therapy leads to reduction in major cardiovascular events. Flecainide and propafenone are effective for pharmacological cardiovascular, but their use should be restricted to patients without structural heart disease. Deflated dofetilide is available, can convert recent AF onset. Ibutalide is an alternative in atrial available, but carries a risk of torsades available only as IV drug. And vernacular can be given to patients with mild heart failure. Amiodarone can be used in patients with heart failure and in patients with IHD. Amiodarone also slows heart rate by 10 to 20 beats per minute after 8 to 12 hours when given intravenously. Both amiodarone and flecainide appears more effective than sotalol in restoring sinus rhythm. Predictors of successful AF ablation include female gender, younger age, paroxysmal AF, fewer AF triggers, and longer interval before AF episode. Recurrent AF is early recurrence less than 3 months, late recurrence 3 to 12 months, and very late recurrence more than 12 months. Prevention of thromboembolic complication contained risk satisfaction. The most important therapeutic goal AF is prevent thromboembolic complication. Anticoagulation warfarin is one of the direct anticoagulation for prevention of thromboembolic complication. However, because of the risk of hemorrhage from anticoagulation, their use should be restricted in patients' risk of thromboembolic complication greater than the risk of hemorrhage. The strongest predictor of ischemic stroke and systemic embolism are history of previous stroke and transient ischemic attack. When patients with AF and previous ischemic stroke are treated with aspirin, the risk of another stroke is very high, that is 10 to 20% per year. Apart from the prior stroke, risk factor stroke include non-valvular AF, that is diabetes, hypertension, heart failure, age more than 70 years. Renal failure is also an important risk factor for patients with AF. At present, CHATS-2 vascular score is recommended for estimation of risk score. That is cardiac failure, hypertension, diabetes, age more than 75 years, vascular disease and female sex category. Each risk factor counts for 1 point with the exception of prior stroke or transient ischemic attack more than 75 years. For men more than 2 and women more than 3 is a class 1 recommendation for anticoagulation. An important consideration patient with oral anticoagulation risk of bleeding. The scoring system with the best simplicity and accuracy is the Hasblat score. The components are hypertension, abnormal liver function, stroke, bleeding history, or disposition, or labile INR are older than 75 years, and concomitant drug or alcohol use. Each of the component is 1 point. As the score increases from 0 to the maximum 9, there is risk also, bleeding risk also increases. Warfarin is found to have reduced the risk of stroke by 61%. The target INR should be 2 to 3. Maintenance of INR at a level of 2 or higher is important. Even relatively small decrease in INR from 2 to 1.7 doubles the risk of score. The strong predictor of major bleeding is INR more than 3. Aspirin is not effective for prevention of thromboembolic complication. Direct acting oral anticoagulants, that is direct thrombin inhibitor factor 10A, has a several advantages over vitamin K: fixed dosing, rapid onset action, and equal or great efficiency for stroke, lower risk of intracranial hemorrhage. Dabigatran oral direct thrombin inhibitor and rivaroxaban, apixaban, edoxan or factor 10 inhibitor are approved by US FDA for prevention of stroke or embolism patient with non-valvular AF. DOC also have the same disadvantage compared with warfarin: higher cost, more gastrointestinal bleeding, the absence of readily available lab tests to verify the complications, and restricted use in patients with it. Use of these agents require great caution in patients with severe renal disease. Reversal agent for bleeding FDA approved is edorasimab, both uncontrolled and bleeding. The onset of action DOCA is approximately 1.5 to 2 hours after dose. Their half-life is 12 hours. The low molecular heparin, because of cost, is not routinely used. Bridging therapy with LMH should be continued until INR is 2.2 or higher. Excision or closure of left atrial appendage, approximately 90% of left atrial thrombus form in left atrial appendage, and therefore successful excision closure of left atrial appendage should greatly reduce the risk of thromboembolic complication. TE should be performed after surgical closure of LAA to confirm successful closure before discontinuing anticoagulation. Recent years, several preventive LAA occlusion and ligation devices have been developed, alternative surgical closure. The FDA has approved 2 percutaneous occlusion devices, Watchman and Lariat. After implantation of these devices using femoral vein access and transeptal catheterization, anticoagulation with warfarin is recommended for at least 45 days, with which time anticoagulants can be discontinued if there is transesophageal echo evidence of peri-device flow. Acute management of AF, patient present with emergency department because of AS who have rapid ventricular rate. Control of ventricular rate is more rapidly achieved intravenous diltiazem or esmolol. If there is hemodynamically unstable, immediate transthoracic cardioversion may be appreciated. Cardioversion should be ideally performed if transesophageal echocardiogram to rule out left atrial thrombus. VAF has been present for more than 48 hours. The duration is unknown and the patient is not already coagulated. If the patient is hemodynamically stable, the decision to restore sinus rhythm by cardioversion is based on several factors. Pharmacological cardioversion has the advantage of not requiring general anesthesia. In addition, probably the immediate recurrence of AF is lower pharmacological cardioversion. Pharmacological cardioversion is unlikely to be effective. Duration of AF is longer than 7 days. The drug has administered intravenously for cardioversion. For AF episode fewer than 2-3 days, 67% for Ebutilate, 42%, 40 to 50 for Amiodarone, 30 to 40% for percutaneous. Acute pharmacological cardioversion AF also can be attempted with oral drugs in patients without structural heart disease. And the long-term management AF, pharmacological rate control versus rhythm control. Several randomized studies have compared rate control over rhythm control. Overall, these studies have demonstrated significant lower rate of dehospitalization with the rate of rate control. And pharmacological rate control, uncountable symptoms and decreased effort due to this heart rate control must be assessed at rest and during exercise. In 2014-2019 ACC and AHA guidelines devise that optimal metric control, rate control is 80, less than 80 for people at rest and after exercise less than 110. Non-pharmacological management consists of stroke prevention, rate control, rhythm control. The modified risk factors contain obesity, hypertension, diabetes, sleep apnea, CAD, heart failure. Catheter ablation is for selected people who cannot tolerate oral anticoagulant drug. Surgical ablation like Mace procedure can be done, but the most dreadful complication is atrioesophageal fistula should be kept in mind. AF and comorbid condition, hypertrophic cardiomyopathy, AF complicating acute coronary syndrome, and hyperthyroidism, beta blockers are the duck of choice. Pulmonary disease, if patient is unstable, you should try the direct current cardioversion. WPW and pre-existing symptom must take careful to give drugs. And heart failure. Again, the heart failure can precipitate the AF. AF can precipitate heart failure. Future perspective, earlier the conversion, then persistence of AF is not there. I will show some 3 or 4 cases. This is a patient 78. He went to the Kodaikanal where patient, not near Salem. He fell in the bathroom. He was found unconscious. He had a subdural hematoma. He was operated there. Then he is near Tuticorin, came to my hospital for post-operative management. Suddenly patient developed breathlessness. Assistant came and told patient breathlessness. Did not palpate the pulse. He had a radial pulse, irregular. Felt radial pulse was irregular, AF. Then patient was given labetalol IV. Patient was converted to normal sinus rhythm, maintained for the next 3 or 30 days. So it is a paroxysmal AF. Again, this is a patient who went for the diabetes with food dysarticulation. Post-operative developed atrial fibrillation, given an IV metoprolol. Patient stabilized on normal cardiac rhythm. This is the patient with the comorbid conditions of increased, came for heart failure with a pleural effusion. So the ECG show atrial fibrillation. Patient was put on the particular drug. This is a patient who was operated for mitral valve 30 years back at Sri Chittaranthirunal Medical Center. He was put on the warfarin, calaptin and digoxin. Patient came for giddiness. This is the overdosage of this drug. Patient developed bradycardia and giddiness. Again, the warfarin stopped for 3 days. Lanoxin also dose reduced. Again, these drugs were slowly reintroduced. Patient came with again 57 pulse with normal things. This is a patient who developed he underwent the aortic valve replacement during post-COVID, developed atrial fibrillation, put again on IV metoprolol, and the rate is now stable, accepted. This is for a postgraduate. Any postgraduate, can you make a diagnosis? This is for you. This is atrial fibrillation in case of WPW syndrome. Again, for postgraduate, this is the Ashman phenomena in patients with atrial fibrillation, where there is a disparity between the rapid heart rate which will not develop aberration, whereas patients with bradycardia develop aberration. What is important in this case? AF with WPW syndrome. These patients should not give amiodarone or calaptin like IV drug, because it will block the AV node and it will divert all rates through the accessory pathway and produce the ventricular fibrillation and sudden death. Again, for postgraduate, what is this? This is atrial fibrillation with a regular RR interval. Patient developed complete heart block. Thank you very much for your patient hearing.
Sir, thank you, sir.
Any doubt? I am happy
sir,
to answer.
Sir, please, sir. Patients presented with, myself, sir. Patient presented with fever of 3 days duration. Then I'm going rounds no symptoms of breathlessness, other things. And going rounds, said, sir, okay, sir, admitted for 3 days fever, now A febrile. And that lady, 60 years old, she was, what to say is, lying like without high fatigability, something like not oriented means not interested in. So I palpated the pulse. It was irregular. Then found AF is present. Another case also, that's what I say to the PGs also. Just palpate irregular, and just ask, keep the state on the chest. You will get irregular heartbeat. That's what we can confirm with the ECG. And another case also admitted for 3 days of fever, but cough was present. On investigation wise, it was developed pneumonia. Then ECG showed AF, sir. No previous admissions or other things. These cases you come across, what to say is, infective cause may be the reason for it, but at the same time, without any manifestations and...
Pulmonary infections very common, AF. Once you treat the infection, AF may revert to normal. It's called the
this lady,
paroxysmal AF.
Lady was UTI, seems to be.
Any infection,
any
infection, especially patient is old age, that may precipitate AF when there is associated comorbid conditions like hypertension or LVH, which leads to LA dilatation. Any patient you do a echo, LA dilatation is more than 45 millimeter. They have got the greater risk for developing AF.
Did you come across the cases like these?
Yes, I showed you.
Okay, sir. Okay, thank you, sir. Nicely discussed.
We'll do the formalities for both the speakers. I'd like to invite our Professor Dr. Muruganathan on the stage. I will call, please. I call our President, Association Physician of India, Dr. Joydev Barpal, to felicitate our speaker, Dr. Muruganathan, sir. I request our chairman to give this memento to Dr. Muruganathan, please. I request Dr. Bala Vignesh to garland our Dr. Muruganathan, please. One of the advisor for the scientific program, being in Tuticorin, Dr. Professor Arul Raj could not come, and his daughter also, who is actively involved in API and RSSDH, could not come because of health issues. Dr. Arul Raj is attending the mixopathy controversy in Kodaikanal, so that's why he could not come. Dr. Selvaraj represents all of them. It is very highly honored to honor Dr. Selvaraj, the past chairman of Tamil Nadu State Branch. With the psalm, I request Dr. A.P. Nandakumar to garland, and request our Association Physician of India President, Dr. Joydev Barpal, to issue this plate to Dr. Selvaraj. Thank you, sir. Thank you, sir. Thank you, sir. Thank you, brother.
May I now invite Dr. Anupam Prakash, who will be leading on the topic Pitfalls in Diabetes Management, Strategies to Overcome Them.
very good afternoon, everybody, and I am sure it is not going to be an easy job talking after stalwarts like Dr. Muruganathan and Dr. Selvaraj. The theme of the conference was From Insight to Impact, Elevating Patient Care. So with that respect, the topic I had chosen was pitfalls in diabetes management and strategies to overcome them. In a brief of 15 minutes, it is not easy to cover all the pitfalls and all the strategies to overcome. So I will touch upon some points. I will begin with this case of a 50-year-old male. This is a very common case. We all get diabetic, diagnosed to be having diabetes mellitus 2 years back, with an A1C of 8.8% at diagnosis. Obese, we had talks in the morning about obesity, preventive mechanisms. Hypertension, Dr. Muruganathan talked about BP variability. He was started on metformin 1 gram twice a day and eplodipine 5 milligram once daily. He came back after 2 years with an HbA1c still around 8% and a blood pressure of 138 by 88 millimeter mercury. So I understand there will be a lot of comments on this case, but we will take this case as an index case and go through the presentation as to what better could be done, because they will be the pitfalls in the management of this case and how to overcome them. So I will talk about the importance of effective diabetes management, consequences of poor management, and the key pitfalls. So this is the first, medication management pitfalls. So anybody can highlight what was the problem in the management. We had a panel discussion yesterday evening also on managing such patients. So one thing is, with an HbA1c of more than 8.8%, 8.8%, as per the guidelines, patient should have been started on 2 anti-diabetic drugs. So that is what at times, so there is a problem at every step. Probably physician inertia, probably lack of knowledge. So I will cover those topics. So one is incorrect dosage or incorrect timing. Even timing is very important. Metformin can be given any time of the day if it is sustained release. If it is not sustained release, ideally it should be given with meals. Similarly, you have a whole lot of drugs. You have to be very specific when those medications have to be given. Like AGIs, alpha glucosidase inhibitors, they have to be taken with the first bite of meal. So although newer drugs you can take any time, but yes, it has to be very important. There are some drugs which need to be given at bedtime, especially if you are giving metformin in single daily dosage. Missed medications is again important. This patient did not come for 2 years. So at times we fail to explain, and that at times patient is also not compliant. Patient feels that yes, medications have been given. At times the finances are restrictive. Patient does not want to go for finances, either to pay doctor's fees or to buy medications. So those are things which are there, and the consequence obviously is the poor glycemic control and risk of hypo as well as hyperglycemia. Now there are issues with medication adherence also. That is why periodic follow-ups are important. If the patient is not coming for 2 years, just like he is missing appointments with the physician, he is also missing appointments with his daily medication. To accept that the patient will be consuming medications on the trot for 2 years without follow-up is highly unlikely. So it is important that we have these challenges, this forgetfulness. I have written, this is not only senile forgetfulness. Even patients who have uncontrolled high blood sugars, they will not understand. At times they have cognitive blurring. So that is also, there are a number of studies. So you need to understand that when the patient has come first to you and he has very high blood sugars, he may not be in the right frame of mind to accept it. Number one, to accept the diagnosis. Number one, to understand the disease. And number three, to understand that his disease will be chronic, despite all the reversal lectures that we have had. The importance of understanding is also important. To understand the disease, its consequences, whether a reversal is possible, and how best to take medications. So these are important. These we need to spend time with the patient, and time is at a premium. We don't have much. So you have counselors which again take a lot of time and money also for the patient. Patient education gaps. So now this is important. I already dealt with it, but we need to make the patients more aware. more aware about everything, not only their disease but also their medications, the side effects, if or not they require insulin, what all medication and what all lifestyle changes and diet they need to entertain. So these are things which we in our busy practice at times are not able to explain. And that is one problem which will remain. So we will need to empower our patients, increase educational resources, enable them to take control rather than keeping the control with us. With the burden of diabetes that every speaker has shown since yesterday, it is not possible for us doctors to take care of diabetes. We have to empower the patient, enable the patients to understand the disease and take control themselves. That is important. Inadequate monitoring again. So how many of us actually advise self-monitoring of blood glucose is a big question. We ask the patient, these are the medications, you go get a fasting PP done after 2 weeks or maybe 2 months and come back. So that is again a problem. So there is a big mismatch with what we study in conferences, maybe BP variability, maybe glycemic variability, but we don't ask our patients to measure. We need to tell them the importance of self-monitoring of blood glucose, how to do it even in a low resource setting or a resource poor setting. The staggered self-monitoring of blood glucose pattern, we have to say maybe before breakfast 1 day, after lunch 2nd day, before dinner 3rd day, any time of the week, any day of the week, the patients can do and bring back that record. Even if they are not coming to the doctor, it serves as a self-motivation. So now, yes, we do have advanced techniques also, but they are costly right now. So lack of regular monitoring obviously will result in uncontrolled blood sugars, increased risk of health complications and demotivation for the patient. We already touched upon that. We had a couple of lectures on exercise, lifestyle also. So this is again important, reinforcement of unhealthy diet, sedentary behavior, poor sleep hygiene. Now we were talking of pulmonary thromboembolism, long hour flight, one gentleman asked, 13 hours long distance flights. But what we advise is for all office workers or sedentary workers or desktop workers or who are having increased screening time, you get up after every 40-45 minutes or 5 minutes to break the monotony, to take care of your eyes, to take care of your sedentary lifestyle also. But how many of us are actually doing it sitting here? I was also sitting since morning. When I went down, my name was announced on the mic. So that happens, but this is part and parcel. The other thing is poor sleep hygiene. And all the persons in the front row, I understand, they have traveled whole day yesterday, reached at 1 AM night. Today again they will be waking up. Dr. Muruganathan, Dr. Bhanumati is there and all these persons. So this is important for our diabetic patients also. You have to have a good sleep hygiene, minimum 6 to 7 hours of sleep. So that sleep also has variability. You need to emphasize on your diabetic patients. And not only total sleep quantity, sleep has to be satisfying for the patient. If it is not satisfying, still it is a problem. I am not going to details of these dietary changes. Yes, cravings, you need to individualize. I have a slide on individualization. This I already discussed. The psychological aspect of the patient needs to be taken care of. Most of us do not deal with it because we think it is in the realm of the psychiatrist or clinical psychologist. But a physician is the best psychologist. You will have to make patient accept the diagnosis and explain all the options of reversibility, long-term complications. These are very, very important. And it is important to understand that a negative impact on self-care, be it examination of toes, screening for complications, or even self-monitoring of blood glucose, will result in a depression or anxiety and diabetes distress. So now this diabetes distress is also a term that all, especially the postgraduates, should know, because it is important. It can come in your examination paper also. So people who have diabetes, they may not have anxiety or depression, but there is a diabetes distress scale that you should be worried about, and you should ideally expose your patients for diabetes distress scale assessment. So this I am not discussing. We all understand stress will beget more hyperglycemia and worsen control. So you need to take care of that also. And partly you will need for integrated care, counselor services, diabetes educators, and maybe if the patient is Further down, you will need to consult a clinical psychologist for your patient or psychiatrist. Support systems are very important. Don't think of support systems outside the family, within the family also. If members of the family do not accept the diabetes status or neglect home advice, self-care examination for the patient is in trouble. Because if the patient has to eat everything that has been made for the family, then how is he supposed to control his sugar? So, support system from the family is very important. Similarly, at times in the office also. So, this is important, this is also an essential part and we are not able to take care of it. So, you need to have the healthcare system also. Apart from social support, the healthcare system also has to be inbuilt. So, limited physician time I already touched upon. Fragmented care coordination. At times you will not have everything at one place where you are treating, but you should guide your patients and provide care appropriately. And accessibility and affordability, maybe financial and non-financial issues. The other is lack of individualized care. This is again a problem with management. So, mostly not as physicians at beginning of our physician profession, and those who are not physicians, there are so many people who treat diabetes. They use this one size fits all approaches, which is not at all the state of the art treatment that needs to be provided. For obesity, there is a different medication that you need to give. For patients who are lean, as you heard in the discussions, there is a different medication. So, this is important. Dr. Muruganathan also talked about precision medicine. So, these are things you will need to take care. It has to be an individualized approach. So, this I will not go. Managing complications. So, number one is, as physicians we should anticipate complications. So, type 2 diabetes may have complications at diagnosis. So, you need to screen your patients periodically for complications. This is important. Not only complications, but comorbidities also. If the patient comes with fasting PP blood sugar, also get a lipid profile. You had a lecture in the morning by Dr. Narsingan, lipid profile done also, as well as screen for other comorbidities, atherogenic indices as well as hypertension. This is a big factor. People were talking about Monjaro or tirzepatide in the morning, semaglutide yesterday. We had so many things, but the cost is escalating. As panel discussion, it was 6,000, 8,000, 10,000 per week. It is not easy. People cannot afford 10,000 even in a month. So, that is one thing where healthcare industry, governments will have to take a call, because it will affect adherence, lead to a poorer glycemic control. So, the consequences of pitfall, this is the last segment of the slide. So, persistent hyperglycemia, increased risk of complications and a poor quality of life. This is what? So, we need to take care of all these things, have comprehensive patient education, individualized treatment plans and regular monitoring. These are the key when you want to improve the healthcare status of your patients. Mental health support we already discussed, but balanced diet and physical activity are important tools which are also need to be emphasized. Access to quality care. So, we need to empower ourselves also if we want that our patients should be educated and empowered. This is what I think last but one slide, importance of coordination, enhanced communication. So, we need to spend time with our patients communicating, listening to them and then reverting back with suggestions individualized to them, which is very, very important. Technological aids are there and innovations are there. We have the continuous glucose monitoring system, though costly, but yes, you have tools which can monitor blood sugars daily. You have artificial intelligence at your service, you have app-based technologies also, and all these things can actually benefit your patients, and apps at times are free also. So, this is very, very important. So, we come back to this case, there are some other abnormalities also apart from which we have discussed. So, lack of knowledge can be there. Amlodipine is not the first line drug when you treat hypertension and diabetics. So, you have to resort to ACE inhibitors and ARBs. So, there are a whole lot of ideas that you have to be there, and we need to empower and understand the importance ourselves before thinking that our patients should follow them. Well, thank you. That's the end of my lecture. Thank you. And grateful for listening and hopefully translating it to the patients also. Well, thank you, Chairperson. I have finished before time, despite 4 buzzers.
Yes, sir.
Preceding lecture had an impact. Once 4 times within my time only.
Really, you have said the significance of understanding, patient understanding, and sleep hygiene, particularly one size fits all. We don't have one size fits all even for diet and even for the drug, but we do follow it, the treatment part of it. At the same time, the significance of what are these factors which will have impact on the treatment part and outcome part. Really, you discussed well,
No, I
but we have to
totally
follow.
agree.
We speak, but how much?
This was a sensitization talk. I just wanted to sensitize people.
Yes, that's what the limited. You have said limited time for physician. That's also a factor. Really, it
Yes.
exists now. So really discussed well, sir.
Well,
Nice.
thank you.
Thank you, sir.
Thank you.
Yes.
May I now invite Dr. Jyotirmay Pal to give mementos to the chairperson, to the speaker, Anupam Prakash. May I now invite Dr. Anupam Prakash to provide mementos to the chairpersons. May I now invite our esteemed chairpersons, Dr. Venkatraman and Dr. Philomena, onto the stage. May I now invite Dr. A. Deva to talk on a topic, role of nephrologist in ICU.
Dr. Deva is a practicing nephrologist in KH Apollo. So he's having vast experience in treating acute kidney injury patients. So today he is going to talk about mainly the role of nephrologist in intensive care unit. Over to Deva.
Good afternoon, everyone. I thank TAPICON organizers and the scientific committee for providing me with this opportunity. Greetings from my institute, Apollo KH Hospital, Melvisharam Vello. I am here to speak on role of nephrologist in ICU. It was a rather intriguing topic because a lot of intensivists, thankfully I am speaking to physicians here, a lot of intensivists actually feel, is there any role for nephrologist in ICU at all? So in 1998, Claudio Ronco and Rinaldo Bellomo, they published an article that critical care nephrology, the time has come, in the journal, in the reputed journal Nephrology, Dialysis and Transplantation. And this is a screenshot of Claudio Ronco is a renowned nephrologist and Rinaldo Bellomo is an intensivist based off Australia. So it is always a tie-up. The nephrologist need the ICU and the intensivist definitely need the inputs from the nephrologist. So as compared to about 3 decades earlier, the critically ill patients are surviving much longer due to the advancements in critical care illness management and also the nursing and home care supports. So the role of nephrologist at a particular venue depends upon the local practice, whether it is a closed or open ICU, and also geography, whether it is a rural or a urban center. So in a rural center, the nephrologist may have to involve himself not only in OPD but also actively in ventilator management and also ICU care. Versus in urban setup, the nephrologist may have to give only inputs or guidelines on what is appropriate for a patient, and he may take a step back and let the intensivist do the job. However, it is unfortunate in many institutions there is collaboration between intensivist and nephrologist is less than ideal. So broadly speaking, the role of nephrologist in ICU consists of evaluating etiology in AKI, AKI on CKD and CKD complications, and implement strategies to mitigate the extent of injury, especially in acute worsening of CKD and also AKI. And more importantly, optimize fluid management. As we all know, even 10% much more increase in fluid from the basal body weight definitely has a long-lasting impact on the patient's recovery from the ICU and also after discharge. And importantly, the nephrologist has to make the decisions of timely, safe and effective renal replacement therapy and address nutrition and drug dosing in renal failure and RRT. So AKI evaluation, the history examination gives about 70 to 80% of clues for clues towards the AKI evaluation in critically ill patients. It is important to note that these patients may be hypovolemic, hypotensive, they may not even have a urine output to do a urine routine. So the history and examination plays a much larger role in these critically ill patients. To differentiate AKI from AAN, acute glomerular nephritis, nephrotoxins, TMA, and also urinary obstruction. Urinary routine is a poor man's biopsy, as always said, is the baseline investigation. Whenever, even if there is a 10 ml, 20 ml urine output, it should be done. And the different types of cause give us an idea about the possible attending etiology in AKI. So the most hyped is the FeNA, that is the fractional excretion of sodium. So how relevant it is in an ICU setting, it is actually not much relevant, and it may not be always possible to do it, especially in the presence of use of diuretics in the emergency or in the ICU by the intensivist. And the novel biomarkers are still for renal injury are still require a lot of randomized control studies. So I would like to bring your attention to this furosemide stress test. So this is a much more of a clinical test which can possibly answer the patient attender's question, sir, how long you start dialysis, how long the patient may require dialysis, is it lifelong? So in patients, in the critically ill patients, about 1 milligram per kilogram IV, if they have not been exposed to furosemide earlier, or 1.5 milligram per kilogram IV if they have been on regular diuretics earlier. So wait for 2 hours. If the urine flow rate is more than 200 ml, it means the furosemide FST, they are responsive. They are 78% of FST responsive patients. they are unlikely to require long-term maintenance HD. So if the output is less than 200 ml, FST non-responsive, they are much more likely to become dialysis dependent in the long term. So the other clinical test is a vasopressor challenge test, in which only for a very shortened duration of time in minutes, we can try to increase the inotropes such as noradrenaline and vasopressin to bring the MAP, mean arterial pressure, to about 90 millimeters of mercury and observe for any improvement in urine output over the next 30 minutes. This is especially beneficial in patients of chronic hypertension and who are on chronic hypertension who are not poorly controlled. This vasopressor challenge test should not be done for prolonged time, and because MAP more than 65 has not been proven to delay or improve the requirement for RRT. So AKI etiology is a very common tabular column which we all know, divided into pre-renal due to hypovolemia and heart failure, liver failure, and renal AKI due to acute tubular injury or acute interstitial nephritis secondary to drugs, and post-renal AKI due to obstruction of the urinary system. So the non-dialytic management of AKI, the nephrologist plays a great role in evidence-based assistance for drug dosing in AKI, identification of the nephrotoxic drugs, management of electrolyte imbalances, acidemia, hyperkalemia, hyperphosphatemia, hypocalcemia, and hypomagnesemia. And more importantly, the volume overload. The nephrologist definitely has a say in assisting and implementing strategies to improve urine output and also the initiation of timely RRT. So AKI staging over the time has evolved from the Rifle criteria to KDIGO and Akin. In all the three classifications, the urine output criteria is the same as stage 1, 2, 3. And what we commonly use these days is the KDIGO and the Akin, divided into stage 3, in which stage 3 is initiation of RRT. So coming to the drug dosing or key medications requiring dose adjustment, commonly used drugs, especially gabapentin, pregabalin, they definitely require adjustments in AKI and also CKD patients in general. And anti-epileptics, lamotrigine. And more importantly, recently we can say that baclofen, which has been commonly prescribed by a lot of GPs for hiccups. In CKD, when prescribed, it can even result in encephalopathy. But unfortunate thing is when we do a dialysis, usually after a single session of dialysis, the patient clinically improves very well after this baclofen-induced neurotoxicity. Not to mention about digoxin, lithium, and the low molecular weight heparin, which all needs dose adjustment. So coming to the most important part of antimicrobials, most of the antimicrobials, they require dose adjustment. However, to note is the loading dose in a septic patient, critically ill patient, should not be changed. The loading dose has to be given as in a normal renal function to achieve the MIC, after which the dose has to be decreased according to the GFR. So if a patient of AKI has a rapidly worsening creatinine, it is not a stable creatinine, we cannot use the routine equation, CKD EP equations for calculating GFR. In such patients who are in AKI stage 3, it should be considered that the GFR is less than 10 and the antibiotic dosing should be done accordingly. And amikacin should be avoided in all AKI patients unless it is the only antibiotic which may work. Even in those cases, the amikacin should be given as a single dose. So it has a long post-antibiotic effect. So you can give it as a single dose. If there is no other antibiotic sensitivity available, then I also prefer local or topical amikacin applications whenever feasible. Better to avoid. So coming to the crux of nephrologist's role in a critical care unit is a fluid management. So fluid management, there are randomized trials comparing various fluids to placebo has not been done. So only in the AKI prevention, after contrast administration, the intravenous fluid versus placebo is done. So to prevent contrast-induced nephropathy, even in patients, CKD patients with say creatinine of 3 or patients with LV dysfunction, if the cardiologist allows, it is always better to give 1 milligram per kilogram per ml, about 60 ml per hour, 12 hours prior to administration of contrast, IV fluid 0.9% saline, and about 12 hours after administration of contrast. It definitely impedes the worsening of the renal parameters. And also to mention the role of sodium bicarbonate and N-acetylcysteine in contrast nephropathy is not very conclusive and may not be beneficial. So who shall we give fluids in patients in ICU? In those patients with a reduced renal blood flow who will respond to a positive fluid, say more than about 2 liters after resuscitation, their cardiac output may improve. Definitely those patients will benefit from fluid resuscitation. So we will see 5 different clinical scenarios. The AKI from true hypovolemia, they are fluid tolerant, usually yes, and they are fluid responsive, yes. Whether there is a sustained fluid benefit, yes, they need maintenance fluids. In a patient with sepsis and no comorbidities, the sustained fluid benefit may or may not be present, and reassessment has to be done at least once in 12 hours. In a patient with young patient with pancreatitis and B lines on ultrasound, the fluid tolerance may not be that great, and because of, as we can see, B lines in the ultrasound, and the fluid responsiveness definitely will be present, but there may be third space losses. And sustained fluid may not be useful. We have to give very cautious in administration of the fluids. This is after resuscitation of 1.5 to 2 liters as per the shock protocol. So in a patient with pulmonary hypertension presenting with nausea, vomiting, whether there will be fluid tolerance? No, they may not tolerate even the initial fluids. Fluid responsiveness may not be present. Sustained fluid benefit is absent. So we have to compare the risk and benefit ratio and administered fluids. In a patient with septic cardiomyopathy and a negative passive leg raising test, the fluid tolerance may be present initially, but due to the poor cardiac function, the fluid responsiveness and sustained fluid is not indicated. So what choice of fluids shall we use? So in the SAFE study, saline versus albumin fluid evaluation, ICU patients who received albumin, they had no great renal or mortality benefit. However, when the volume for resuscitation is more, albumin can bring down the total volume of crystalloids required for resuscitation. And in the crystal study, they compared colloid versus crystalloids in ICU patients. What they found that there was no changes in the RRT, but that 90 days the need for mechanical ventilation and vasopressors was much less. So balanced salt solution versus 0.9% saline. The plasma light compared in a post-operative patient, they showed that the need for RRT was less, but it was a very small study, single center, only with modest resuscitation volumes of about 2 liters. So vasopressors, MAP beyond 65 millimeters of mercury has not been associated with improved renal outcomes, and only in patients with chronic hypertension, a slightly higher MAP of 80 millimeters of mercury may be considered. So vasopressor choice, the low dose dopamine, there is no specific role for renoprotection, and the use of low dose dopamine for treatment of AKI as a renoprotective measure should be abandoned. And norepinephrine, though there is a fear of renal microvascular constriction, it has been shown to improve the renal medullary blood flow. And vasopressin, in addition to norepinephrine, brings down the dose of norepinephrine and also helps in improving urine output. And also adding hydrocortisone in septic patients definitely helps in bringing down the mortality and also chances of RRT. So glycemic control and nutrition are much more important, especially in patients who become dialysis dependent. and in the intensive insulin group, where the sugars were targeted about 110 to 140, the renal injury was significantly reduced. However, the mortality was increased. So the current recommendation suggested a glycemic control target of 150 milligrams per deciliter, and the protein requirements in patients with AKI not on RRT is 0.8 to 1 gram per kilogram per day, and up to 1.5 grams per kilogram per day in other patients, in patients requiring RRT. And the calorie requirement is about 20 to 30 kilocalorie per kilogram per day, and also we have to add micronutrients as required. So bicarbonate does not routinely improve the hemodynamic stability unless in specific circumstances such as the pH is less than 7.1 or serum bicarbonate is less than 12. And use of erythropoietin has not been studied specifically. However, it can reduce transfusion requirements, but there is no effect on the final outcome. So the nephrologist has to be aware of the aware of the machines, filters, dialysis or replacement solutions available in their center, because then only they can administer the particular modality of RRT in a timely manner. So coming to the modality of RRT, IHD, intermittent HD SLED versus CRT. CRT and SLED, they go hand in hand in critically ill patients. Depending upon the availability of the machines, which one can be preferred. CRT is beneficial in critically ill patients. Peritoneal dialysis in these patients, there will be splanchnic vasoconstriction and may or may not be very effective. Peritoneal dialysis in a patient in cardiac ICU may be useful, and we can continue peritoneal dialysis post-discharge in patients with cardiomyopathy. And cytosorb and hemoperfusion, though not under the prerogative of nephrologist as such, cytosorb much more studies are required for as the endotoxin filter, and hemoperfusion, though the nephrologists are doing it, though in assistance with the toxicology department, they may not be, the outcomes may not be very consistent. So comparing early and delayed RRT, I will take just 2 more minutes. This Elaine study alone started patients with the dialysis in patients with the early group. Early group means AKI stage 2. Within 8 hours of AKI stage 2, they had a early initiation. They had showed a greater renal recovery. However, rest of the randomized control trials, AKIKI, Ideal ICU, FST or AKIKI 2 did not show any greater differences between the early and late initiation of RRT. Late initiation of RRT is about 8 hours of setting of AKI stage 3. So in end-stage renal patients, the intensivist should be aware about the CKD patients, CKD dialysis patients are notorious to get into hospital-acquired infections, and the drug dose should be based on the residual renal function and also the mode of RRT in these patients. Nephrology-related focus definitely helps in guide catheter replacement, AV fistula cannulation, and thrombectomy and assessment of AV fistula, and in AKI, if there is any perinephric collection or if there is any.
Dr. Deva, due to shortage of time, please conclude.
Yes, sir. And potential quality metrics should also come under the nephrologist prerogative, because these are required as an outcome of the dialysis unit. We have to maintain these quality metrics in the long term. So withholding or withdrawing dialysis on a fully informed patient who refuses dialysis and who has profound neurological impairment, or he has given an advance directive that he doesn't require dialysis at any point of time, we are not supposed to dialyze. So early nephrologist helps begin conversation with the family about the options, builds rapport with the critical care team, and also helps in assessment of patients regularly and also initiation of early RRT. So thank you for your patience listening. These are my reference articles. Thank you.
Thank you, Dr. Deva, for a wonderful elaborative lecture. I think next we will call upon Dr. Sir. I think we will have discussion in the last. So the Dr.
He was diabetic nephropathy. I should be focusing on the pillars and retarding the progression of diabetic nephropathy. Diabetic nephropathy is usually managed by the physicians. So most of the time we do see the patients at a later stage whenever they come for a dialysis or so. So my topic will be covering on discussion on how to halt the progression of this disease and what are the recommendations. I'll be focusing on some of the important trials, the commonly used drugs and the dose adjustments in renal failure, and what about the precautions you should follow while using this drug. So this is the first slide I usually put in most of the presentation is what is the definition of diabetic nephropathy. It is a clinical syndrome which is characterized by persistent albuminuria, which is there documented at least 2 times at 3 to 6 months apart, and there is a relentless decline in GFR of about minus 10 to 12 ml per minute in a year. And most of the patients do have hypertension or they are non-dippers and do have cardiovascular mortality and morbidity. So a drug which is shown to retard the progression should address in all these issues, like it should reduce the albuminuria, it should reduce the slope of eGFR decline, and patients should have a reduction of BP with the usage of this drug. And of course, you should have cardiovascular protection and mortality benefits. So this is the comprehensive care for patients with CKD and diabetes. So usually the heart and kidney have the common risk factors. So we have to address in all this way. So we should encourage the patient to have regular exercise if the patient is able to do and his cardiovascular condition permits. So you can go for 150 minutes in a week. And we should also address the nutrition, and patient should cut down his smoke and any addictions. And we'll come to blood pressure control. Of course, blood pressure control, you have to tightly control it as close to 130 or 80, and patients, if required, has to be put on lipid management. And most of the patients should receive an SGLT inhibitor and RAS blockade and antiplatelet agents if required. Otherwise, routine administration of antiplatelet agents in the CKD with proteinuria is usually not recommended. So this is the nutritional and lifestyle changes. A patient should be encouraged to have a vegetable-based food with whole fiber, grains, legumes, and unsaturated fats and nuts, and should be of low fats and processed meats and refined carbohydrates. And the protein intake should be cut down. The protein intake should be around 0.8 per gram per kilogram per day for a diabetes who is not on dialysis. And you can go up to even 0.6 gram per kilogram per day. This protein restriction is known to retard the progression of kidney disease. And controlling your sodium intake to less than 2 grams will help to control your BP because so the tight control of BP is always necessary to have retarding the progression of disease, because in a patient with uncontrolled hypertension, there is a very chance that your GFR will quickly fall, and the patient should also be encouraged to have a regular exercise. So we'll go on to the glycemic therapies. The first of choice in patients with diabetic CKD is SGLT inhibitor. You can use it up to GFR of about 20 ml per minute. And you can also add on metformin. If your GFR is more than 45 ml per minute, you can use safely. If GFR is less than 45, you have to reduce the metformin by 1 gram. And if it is less than 30 ml per minute, it's better to stop this metformin because it can produce lactic acidosis and vitamin B12 deficiency on a long period of time, particularly the patient who is more vulnerable. And the next class of drugs that is usually preferred by is as per the trials is this GLP-1 receptor agonist. If the patient is not able to be controlled on these two therapies, we can very well choose the other drugs based on the cost, based on the availability, and based on the patient is able to can use this drug without much of symptoms. So this is the trials. I am just summarizing some of the important trials. This is a Credent trial, which was done in diabetic patients, which has recruited with GFR about 30 to 90 ml per minute. And DAPA-CKD had been done in patients with or without diabetes, and GFR recruitment criteria was about 25 to 75 ml per minute. And EMPA kidney was done in a large number of patients with the GFR recruitment criteria of about 20 ml per minute. So we could see that most of this trial is basically a class effect. They had produced some good benefit on progression of the kidney disease. The renal specific events were reduced by about some 30 to 40%, and so also the cardiovascular benefits were reduced, and the patients' hospitalization for heart failure is also reduced by about some 15 to 20%. So this is the data which is done taken from the DAPA-CKD trial. Usually when you start a SGLT inhibitor, there is a transient dip in GFR, followed by it stabilizes over a period of time, about some 3 months or so. So this is basically due to alteration of glomerular hemodynamics in the early point of time. Then it stabilizes. Even in stage 4 CKD, compared to the placebo, we could see that dapagliflozin, the eGFR slope is somewhat lesser compared to your placebo. So the starting dose for most of the drugs is like for Cana it is 100 milligram per day, and for DAPA is 5 milligram, and for EMPA is 10 milligram. You can choose up to 20 ml per minute, and avoid initiation if the GFR is less than 20 ml, and continue with the GFR falls, and preferably you should stop the drug if the patient is on dialysis. And do not start this SGLT inhibitor if the patient has got an obstructive uropathy or active UTI, or if there is any hypokalemia, or the patient has got an active foot ulcers or DKA. This is the slide telling about the usage of this drug in dialysis patients. The current recommendation says you should discontinue this drug when the patient is started on dialysis. However, there are certain emerging studies telling about the potential benefit of this usage of this drug in dialysis patient, because it tends to preserve the residual renal function. In patients particularly who is initially started on dialysis, they have a good amount of urine output being preserved. This usage of this drug produces some amount of diuresis. It reduces potassium content of the patient, and it also reduces the intradialytic weight gains. Thereby, it translates into improvement in survival. And it also produces reduction of your cardiovascular events and improves the anemia. Basically, most of the effects are mediated by the pleiotropic effects on the cardiac myocytes and endothelial cells. We also need some ongoing RCTs like your DAPA-HD trial, EMPA-HD trial, which can tell about the usage of the drug in dialysis patient. So unless the valid results are available, the usage of this drug in dialysis patient should be individualized, and the patient always needs a close monitoring. So this is the slide regarding the titration of SGLT inhibitor. Always follow the sick-date rule, and instruct the patient to avoid a low carbohydrate diet, and educate the patient about the genital hygiene. And if the patient is going for any major surgeries, you have to stop the SGLT inhibitor just 2 to 3 days prior to surgery and monitor the ketone levels. Next class of drugs are GLP-1 receptor agonists. The drugs can be used with the GFR is more than 50 ml per minute. These are the 3 drugs like dulaglutide, liraglutide, and semaglutide have shown efficacy and safety in patients with moderate renal dysfunction. Usually preferred in diabetic, obese patients with early CKD, promote weight loss. Remember, we should not combine the GLP receptor agonist and DPP-4 inhibitors. So we can see the list of trials, so like your leader, Alexa, Sustain, Excel, and Harmony, Rewind. These trials are basically done in patients to have a primary outcome as the major cardiovascular events. None of these trials are dedicatedly done to assess about the kidney events. In this trial, the leader, that is liraglutide and dulaglutide, have recruited patients up to GFR of about 15 ml per minute. And they could find that the patients, almost all the trial could show the effect on albuminuria reduction, but there is not much of data on the eGFR loss. So this is the FLOW trial which has come out in recent days. This is the first dedicated kidney outcome trial in patients with GLP-1 receptor agonists. It's a multinational trial. They had recruited people with GFR of up to 25 to 50 ml, 25 to 75 ml per minute. And the patients were categorized into 2 arms, that is those who have been given with semaglutide 1 milligram per week and a placebo arm. And the baseline GFR in these 2 groups was somewhere around 46 and 47 ml per minute. And they could find that the major adverse kidney events were lower in the semaglutide arm, and the death from any cause is also lower by about 20%, and there is not much of adverse effects that is leading to discontinuation of this drug. So we have these primary outcomes telling that the kidney-specific events are lower by about 24%, and we can see the GEGFR slope in the semaglutide arm is somewhere minus 2.1, whereas the placebo arm is somewhere around minus 3.36. So we have a slope difference of about minus 1.16 with the usage of this drug. And so all the secondary outcomes are lower by about 18%. That is, the cardiac events are lower by 18%, and all-cause mortality is also lower by 20%. So apart from you are reducing the risk of traditional risk factors by promoting weight loss, glycemic control, reduction of your BP and dyslipidemia, this drug has got some kind of kidney protective mechanisms in the form of promoting natriuresis. It reduces inflammation, oxidative stress, and fibrosis. Thereby, it causes reduction of hyperfiltration, and it promotes the reduction of albuminuria too. So these are all the basic effect that is seen in the kidney with the usage of this drug. These drugs are usually metabolized by the dipeptidyl peptidase and neutral endopeptidase. So they do not require that much of amount of reduction, particularly in advanced renal failure. But the caution says that the GLP-1 receptor agonists can be used safely to GFR of about 15 ml per minute, whereas the exendins like your exenatide and lixisenatide should not be used in GFR of less than 30 ml per minute. Coming to the backbone of treatment of your diabetic nephropathy, the RAS inhibitors, most of the patients should receive a RAS inhibitors, particularly if they have an albuminuria with or without hypertension. But be cautious when you are initiating in patients with GFR of less than 15 ml per minute, because already you have a diseased kidney. Angiotensin tries to maintain the GFR of the patients in a diseased kidney by constricting your efferent arterioles. Once you start the patient on AC inhibitor, what happens? There is angiotensin-mediated vasoconstriction of the efferent arteriole is lost, so there is an acute drop in GFR. Thereby, it can provoke an AKI in a patient with an advanced kidney disease. So once you start, you reassess after 2 weeks, see if this creatinine the creatinine is risen to less than 30%, you increase the dose of AC inhibitor and titrate to a maximum tolerated dose. If there is more than 30% increase in creatinine, you check for any reversible causes like volume depletion or bilateral renal atherosclerosis, or if there is any concurrent medications like diuretics or NSAIDs. If at all, if it is required, you stop or temporarily discontinue if there is a symptomatic hypertension, or if refractory hyperkalemia requiring hospitalization, or in patients who want to delay the initiation of dialysis by treating the kidney failure. So those conditions where you have to adjust this drug. So you have to take into consideration of the other measures rather than stopping this drug. There are certain unique condition wherein you expect to have hyperkalemia in these patients, like your diabetes, patient with volume depletion, advanced age. This is the list of drugs wherein you have to keep it in mind when you are treating a patient with AC inhibitor. There are other drugs that can also produce hyperkalemia in the form of triamterene, amiloride, trimethoprim, and particularly heparin, which is commonly used. And patients on potassium-sparing diuretics like aldosterone and your eplerenone, and even sometimes the beta blockers can impair your renin release, that can cause hyperkalemia. So all these drugs also have to be kept in mind. So there are certain important practical measures wherein you can manage hyperkalemia in these patients, like you have to advise the patient to be on strict low potassium diet, advise the patient to have leaching diet, and other herbal treatments should be curtailed. Patient should be warned on avoiding the usage of NSAIDs. And very importantly, you can instruct the patient to have some laxative so that the constipation is relieved, and the patient should be somewhat excreting the potassium from the gut too. And if the patient has got some urine output, you can put the patient on thiazide diuretic or loop diuretics. That way it helps to promote the excretion of potassium. The recommended bicarbonate levels in the patients with diabetic CKD or any kind of CKD is somewhere around 22 ml. So you can advise 22 millimole per liter. You can advise oral bicarbonate for these patients. We can also use gastrointestinal cationic changes like your pateromer and zirconium silicate, which is not routinely available here. You can continue for about minimum of 12 months or so. Should we need to stop an AC inhibitor as the CKD advances? So this is one Swedish registry trial which was done in about 20,000, which is a cohort trial. Basically, it was studied in about 10,254 patients with less than 30 ml per minute of GFR. And they have categorized into two groups, those who have stopped this drug within 6 months and those who have continued the RAS inhibitors. And they found the mortality is somewhat lower in patients who have stopped this AC inhibitor, and naturally we tend to expect. So also the requirement of dialysis also delayed in patients who have stopped this AC inhibitor. This is in children which had looked into the cardiovascular benefits, and they found those children who had been stopped on these RAS inhibitors, the GFR had acceleratedly declined compared to those children who had been continued on this continued on AC inhibitor. We have a stop AC trial. This is a randomized trial which has looked into the usage of AC inhibitor. It's a 1:1 trial. So those people who had been continued on RAS inhibitors, and it was compared with those who discontinued on RAS inhibitors, and they found there is not much of benefit on discontinuing these RAS inhibitors. So those people who have heart failure with reduced ejection fraction, you can safely continue, and you have to monitor and manage the hyperkalemia. That conditions you can continue this, and you can also suggest this ACE inhibitor in patients with children and young adults. And if you want to have preservation of residual renal function, you can continue this. And you have to discontinue if there is a resistant hyperkalemia and patient has got a severe uremic features and you want to delay the initiation of renal replacement therapy, you can discontinue this ACE inhibitor. So regarding dose adjustment, most of the drugs requires dose adjustment except your fosinopril, which is not removed by dialysis. And coming to ARBs, you can use the ARBs, do not require any dose adjustments in CKD. It's not removed by hemodialysis and ideal for patients with diabetic hypertension. So coming to the last part, like this non-steroidal mineralocorticoid receptor agonist, this is a bulky molecule which has got a unique mechanism. It promotes antifibrotic and anti-inflammatory effects. That's why it's more unique. It is preferred in patients who's having persistent albuminuria despite patient is on ACE inhibitor ARB. And the starting point is that the patient should not have an hyperkalemia. So we have two trials with the fentrinone, that is Figaro and Fedilo trial. We could see the fentrinone had produced a significant reduction of your CV events by about 14% compared to placebo. So also the kidney specific events are also reduced by about 23% compared to your placebo. And this is the indication for starting fentrinone. If there is sustained reduction of your eGFR decline and you want to reduce the progression of kidney disease, and patients with cardiovascular deaths and non-fatal myocardial infarction and hospitalization for heart failure, these are all the indications wherein the fentrinone is being used. So you can start till the GFR about 25 ml per minute and continue till the GFR of 15 ml per minute, and do not continue if GFR falls to less than 15 ml per minute. So coming to the accelerated initiation of these drugs, so you can follow the accelerated initiation of these multiple therapies in a short period of time, particularly in patients with early stages of CKD. But as a nephrologist, I would like to tell, because if you go for an accelerated initiation, there is very chances patients can develop diuresis and natriuresis, particularly if they have a background of some kind of volume depletion, and it can provoke an AK. So it's always better to go with a stepwise sequential approach, particularly in patients has gotten, patient is on stage 4 CKD. And you should always advise the patient about the sick day medication management. These drugs has to be stopped temporarily if the patient has developed any severe diarrhea or vomiting. So these are all the 4 pillars of therapy which can be targeted in patients with early diabetic kidney disease, and it had provided wide range of cardiorenal benefit by reducing the progression of kidney disease, cardiovascular events and deaths. Thank you.
Thank you, sir, for your excellent clinical-oriented talk, and I think it's really a wonderful talk. Thank you, sir.
Any questions in the hall? I think if there is no question, we'll end the session. Especially, the problem is the hyperkalemia. If you are adding ARB, if you have fentrinone, you should be very careful because that is the only add-on drug. But if you do use SGLT with ARB, there is a SGLT will cause a little bit hypokalemia, it will nullify the hyperkalemia. So these are the, as Sir told, these are the 4 drugs we can use to prevent the progression of CKD.
Addition of an SGLT inhibitor will try to help you control the hyperkalemia, and we should also follow the other measures of tackling the potassium control, like reducing the potassium intake. You can use a diuretic if the patient has got a good amount of urine output, and overall you can promote, like if the patient has got a constipation, it has to be relieved.
Another one problem, whenever there is hypertension, most of people, they will take rock salt or Hindu salt, but it contains only potassium, which they should know. They thought that it is good for hypertension, but it's bad for kidney.
Sir, what is the level of GFR you told to initiate fentrinone?
Initiate?
Fentrinone.
Fentrinone is up to 25 ml per minute.
Beyond 25 ml?
Yes, beyond 25 ml. You can, if the GFR is more than 60 ml per minute, you can start with 20 milligram. If GFR is between 25 to 60 ml per minute, you start with 10 milligram. you continue till the GFR is about 15 ml per minute. And it is advised as of now that you should not continue if GFR falls than 15 ml per minute. And preferably you should also have a very close check on potassium levels. If the potassium is rising to more than 6 or 5.5, preferably we can go up to 6. It's better to stop the drug momentarily. You recheck again after a week and then start with minimal dosages. One practical approach, what we say is always start this drug in a small doses and stepwise you escalate, particularly in patients with stage 4 or stage 3 CKD, because many times they land up with worsening of renal values and they can have an AKI also.
I think I request Dr. Deva and Elnil sir to stay here to receive the memento and appreciation award.
With that, we conclude the session. May I now invite Dr. K. Dhananjayan and Dr. K. E. Sambat as chairpersons to the next session. May I now invite Dr. Nandini Chatterjee to speak on the topic CKM syndrome, holistic management.
A very good afternoon. So I will be very quick with the slides because they were made with a view that the talk was supposed to be 20 minutes, but now I find that 5 minutes have been deducted. Anyway, quickly. So we start with a case. A 60-year-old non-smoker male has a history of hypertension, obesity, and pre-diabetes. He presents to the OPD for routine examination after several years because he's been feeling very tired in the recent times. He's not on any medication and is very proud of his morning walk, on which he trusts that would cure him of all his ailments. On examination, it was found that his BP was 146/84 per minute. His BMI was very high, 32 kg per meter square, with a huge waist circumference of 102 centimeters. Otherwise, his systemic examination was non-contributory. So the workup was done and the fasting blood sugar came out to be 130 milligram per DL, ppbs 230, HbA1c much above the cutoff. Lipid profile was deranged. His creatinine was 1.2 milligram per DL and his ACR was around 45 milligram per gram, which was a little above the normal. His echo, ECG and thyroid functions were normal. So this was our first case. I would also like to draw your attention to the second case, who is a 60-year-old male ex-smoker. He presents to the emergency with progressive dyspnea for the last 7 days. He has a history of multiple diseases like hypertension, dyslipidemia, obesity, diabetes, CKD stage 3A, prior AMI, along with a history of implantation of 2 stents to the left anterior descending about 7 months prior. So he is a multi-morbid patient with very high risk factors. His medications included an amlodipine 5 mg, atorvastatin, aspirin, clopidogrel, and metformin. It is our duty to examine whether these drugs were enough to take care of his multiple problems. When we examined him, his heart rate was 110 per minute, respiratory rate was 24, but his saturation of oxygen was really low, 87% in room air. He had a raised jugular venous pressure, and his pulse examination revealed that he had atrial fibrillation. The lung auscultation revealed rales on both the lung fields, and he had edema. His investigations, we found that his creatinine was 1.7 milligram per dl. His NT-proBNP was very high, and echocardiography revealed a reduced ejection fraction of 35%. So these are our 2 index cases, and what is common in the 2? They both are obese, they are hypertensives, they have abnormal lipid profile, they are diabetics, they have renal dysfunction, and one of them has high risk for CVD, another one is an established case of cardiovascular disease. So when we have such patients with a conglomeration of such problems, a new nomenclature is being doing the rounds for the last few years, and that is called the cardiovascular kidney metabolic syndrome. What is this syndrome? It is a disorder which is characterized by pathophysiological interactions about metabolic risk factors, chronic kidney disease, and the cardiovascular system, leading to multi-organ dysfunction and a high rate of adverse cardiovascular outcomes. So there is common pathophysiological factors which lead to abnormalities in the heart, kidney, and in general metabolic profile. It may include individuals who are at risk for CVD or individuals who are already having existing cardiovascular disease. And it has been divided into 0 to 4 stages. The stage 0 is obviously where there are no CKM risk factors, and this gradually increases to stage 1 where the person is obese, no other problems. Stage 2 where along with obesity now various other metabolic risk factors are added, or the patients are having already moderate to high risk kidney disease. Stage 3 is where subclinical cardiovascular disease has started, and stage 4 is an overt clinical cardiovascular disease along with the other metabolic risk factors. Just one slide where the subclinical CVD means that on cardiac CT you get increased coronary artery calcium. On an angiography you get non-obstructive coronary artery disease, or there is peripheral artery disease or subclinical heart failure. So what is the diagnosis of the 2 cases? The first case is a case of stage 2 cardiovascular kidney metabolic syndrome, and the second case is a stage 4 CKM, an advanced condition. Now this CKM syndrome is a progressive condition, begins early in life with various biological, social, and environmental exposures or pressures. Their manifestations are also heterogeneous. We know that some individuals may have few or no risk factors, but they may be excessively obese. On another hand, there may be some individuals who are not so obese, have a little increased waist circumference, but they may be having multiple metabolic risk factors. Moreover, how fast this CKM will progress is also very heterogeneous and often cannot be predicted. Epigenetic changes resulting from genetic, environmental, social, and lifestyle factors together may be the reason for such heterogeneity. And what is the underlying pathophysiology that leads to this? Dysfunctional adiposity or visceral tissue adiposity is one of the main culprits. There, it seems, develops a condition of chronic inflammation in the body, and this chronic inflammation has many effects. There is insulin resistance, there is metabolic dysfunction associated steatotic liver disease, heightened activity of the RAS system, and all of them together at the cellular level lead to oxidative stress and mitochondrial dysfunction. What is the consequence? Well, the consequence is evident in the various organs as I have mentioned. In the heart, if there is ectopic fat deposition, there will be coronary artery disease, chances of heart failure, atrial fibrillation, and even sudden cardiac death. In the kidney, ectopic fat can ultimately lead to glomerulosclerosis, tubular inflammation, and fibrosis. Now, what are the risk factors of this CKM syndrome? Now, as we know that there has been knowledge about various organic risk factors for metabolic syndrome and heart disease. But now the emphasis is on some other factors like social factors. It has been called the social determinants of health. As my previous speakers were also saying, that mental illness, mental health disorders, stress and anxiety in life, poor socioeconomic status, chronic inflammatory conditions, and sex-specific risk enhancers. These are the newer risk factors which are being emphasized. Here I have enlisted which are the things that are being considered as social determinants of health. Financial strain, food and housing insecurity, transportation needs, healthcare access, safety, perceived need for assistance of addressing social needs. These things 2 to 3 decades earlier was not in our awareness, but now they are being emphasized as being very important in ultimately leading to metabolic conditions. So how to manage such patients? First thing is that it has to be a patient-centered implementation, which means that you have to take into account the individualized risk factors of that patient and think of how to manage best. Lifestyle modification is number one in this list, which may prevent progression and facilitate regression along the CKM stages. You have to select cardioprotective agents to prevent the cardiovascular risk. The emphasis on social determinants of health, as I have just mentioned, requires interdisciplinary care. What is interdisciplinary CKM team? Well, it has been said that primary care, cardiology, nephrology, endocrinology, even nursing, as well as social workers and community health workers should come together to holistically manage patients of CKM, and they can be under the care of a CKM coordinator. So only 3 minutes are left. Quickly, I will skim through how to manage the 2 cases that I was mentioning. The first case is stage 2 CKM. Well, in his case, the lifestyle modification with diet and exercise extremely important. One has to manage his lipid abnormality with statins. We have to take care of his albuminuria, which is minimal at this stage, but will progress to higher degrees if we do not give him the proper drugs or the RAS inhibitors. For his diabetic control, the options that we have to choose are the SGLT2 inhibitors, and it is being advocated the GLP-1 receptor agonist, which is quite costly and may not be available to all. In that case, we may take the help of metformin. Of course, it is desirable that there is an interdisciplinary hand-in-hand effort with a CKM coordinator to counsel and help these patients. Let's quickly come to case 2, which is an advanced case with heart failure, atrial fibrillation, and all other factors. Here also, this patient first after stabilization needs to go for weight loss, physical activity, anticoagulation therapy, lipid lowering therapy. The pillars of heart failure need to be given to him. Already a lot of discussion has been done on these topics. Moreover, we have to take care of his diabetic status, but the drugs which are being advocated as good cardioprotective, renoprotective agents are of course costly, so we have to see how that can be managed. Now screening. Now this disorder, once it has advanced, as you can see, there are very less options for us. So screening is very important, and according to an advisory given by the American Heart Association in 2023, screening should begin at childhood, even at the young age of 3, when we have to see whether they are becoming obese or not. So blood pressure assessment, obesity assessment, behavioral health started from childhood. From the age of 9 years, lipid and sugar should be monitored. For adults who are having stage 2 CKM, annual checkup with the ACR measurements and GFR measurements are added to it, and then cardiovascular monitoring is also added. So what are the takeaways from today's talk? Therapy incorporates lifestyle changes along with pharmacotherapy in CKM syndrome. There needs to be a high level of awareness and policy support across the health systems. We need healthy nutrition, neighborhood safety and walkability, and individual level access to community-based care. So all this denotes holistic therapy to address obesity, diabetes, lipid, renal dysfunction, and cardiovascular disease. Prevention, as we have always known, is better than cure for this syndrome. Thank you.
Thank you, ma'am. That was a lucid exposition of the concept of CKM, and we should all be aware of that, and you have touched all the pathophysiology and the stages and treatment. Also, it is wonderful that she has touched the prevention aspect. Actually, when you see that the correlation of these 3 things will be insulin resistance, which starts from early because of our lifestyle. And if we manage our lifestyle, which includes our healthy eating habits and physical activity, lifestyle, sound sleep, prevention of stress, all goes hand in hand to prevent such a situation. That is good. So as a takeaway, we should maintain a good physical, social, and mental health to prevent CKM. Thank you, ma'am.
Thank you. Thank you.
Any questions from the floor? Yes, thank you.
Thank you, ma'am. Next, I invite Dr. Udas Chandra Ghosh from Kolkata to speak on the topic asymptomatic hyperuricemia, when to treat. Welcome, sir.
Good evening. First of all, I convey my sincere regards and thanks to the organizer, this particular scientific group, for inviting me here. My topic is asymptomatic uricemia, hyperuricemia, when to treat, whether it is a revisit of asymptomatic of hyperuricemia. This is my overview of my lecture. And you know that uric acid is a breakdown of product of purine, not protein. Its generation depends directly on both intrinsic purine production and purine intake by diet. And no universally accepted definition of hyperuricemia. And in upper limit for the male is a 7 and the woman is a 6, but it is lower in the children, and it is upper limit is 5. The tendency to develop hyperuricemia increases with age, and in our population, particularly Indian population, near about 25.8% is having a asymptomatic hyperuricemia. Then dietary purine and also tissue synthesis and metabolism result to uric acid pool, and that is excreted by the kidney and the intestine by different urate transporter. And this is the different pathways where the glomerular filtration and reabsorption and the secretion and again the secretory absorption, that is ultimately result the urine excretion. So any defect of these may resulting in hyperuricemia. This is, I am not going to details about the different urate transporter is help in the uric acid rather accumulation in the blood. So it is the either excretion is low or production is high, it is resulting the hyperuricemia. And most causes of hyperuricemia is associated with urate under excretion by the kidneys. So if hyperuricemia develop, then it result to the smooth muscle cell proliferation, vasoconstriction, rash activation and COX-2 activation are resulting with different disease, particularly metabolic diseases associated with that, and resulting the tissue hypoxia, cell death and insulin resistance, and resulting also gouty arthritis. But different risk factors of developing hyperuricemia either endogenously produced or diet, and it is the, I have already mentioned that either overproduction of uric acid or decrease of uric acid excretion, resulting that it is associated with some genetic disorders, and some drugs and alcohol also producing rather hyperuricemia. So why the hyperuricemia is much more prevalent today? This is the longevity of the rather lifespan is increased. Prevalence of hypertension, rampant use of diuretics and low dose aspirin, dietary trends, alcohol consumption, obesity epidemic, prevalence of metabolic syndrome, and survival of coronary artery disease and heart failure, and increased CKD and end-stage renal failure, major organ transplantation. So as they are increased, so there is an increased prevalence of hyperuricemia. Now the problem is what is the approach of asymptomatic hyperuricemia? Just see what is the cause of hyperuricemia, what are the association with these disease, what are the damage of tissue or organs has occurred or not, and then what should be done. So you take a clinical history, whether the patient is symptomatic or asymptomatic, and just see the causative etiology and also comorbid condition. So if you have a patient of hyperuricemia, is check 3 diseases rather than diabetes, hypertension and CKD, whether they are present or not. So you have to take rather a history of whether the symptoms of gout or gout-like arthritis is there, or uric acid nephrolithiasis manifest as a hematuria, pain in the flank, abdomen, nausea, vomiting like that. So take proper history of the particularly in gout arthritis, typically presence of a monoarthritis, and first MTP has the most commonly involved. The most important part is the meat of the food. So if check the food, so if food is rather, I mean, hind foot is involved, that is the spondyloarthritis or gout. If the midfoot is involved, there is a gout or spondyloarthropathy. But if the forefoot is involved, think of rheumatoid arthritis like that. So you have to check any bursitis or tendinitis for the nephrolithiasis. You have to check abdominal pain or not. So the patient present may be present with asymptomatic asymptomatic state for a prolonged time to develop a gout. So hyperuricemia may be associated with the MSU crystal deposition in the body. So asymptomatic hyperuricemia with the evidence of this monosodium urate crystal deposition either microscopically and radiologically, that you have to may search for in some clinical condition. But most important part is that you have to take the history of acute gouty arthritis because it is a clinical diagnosis. It does not correlate with the uric acid. But intercritical gout, it is the stage in between the two players, that is important, but that patient may present with asymptomatic hyperuricemia. Because patient is not having a complaint, so that's why you have to take the history, whether the past history of gouty attacks are there or not. So in the long time, the interval between the flare and the duration of each flare is decreased. Rather, it is, and also clinically, the intercritical phase is clinically disease seem to be quiescent, and MSU crystal formation and deposition may continue. So it is a disease which is you have to treat the patient for a lifelong. So don't rather stop your treatment in a intercritical phase. So you have to examine physically. There is no specific examination for asymptomatic rather hyperuricemia. If the patient have a gout, you may get some features. Particularly gout may affect one joint at a time, but maybe a polyarticular gout is there. Nephrolithiasis is also there. But when you have get the patient of hyperuricemia, please recheck after 1 week. If it is more than 8, recheck. And you check the other count, CBC count, electrolytes, liver function, glucose and lipid profile to see whether it is associated with the other disease or not. So you have to take the dietary habit, whether the patient is having a chronic disease or not, whether the patient is associated with heart failure or use of diuretics and beta blocker and others, associated with the other metabolic disease, any drug history or any history of organ transplantation is there or not. So before treating the patient, you have to take that one. And what are the different association with other metabolic condition? So different metabolic condition is associated with the hyperuricemia that you have to search for. Now question is that if the patient is having a persistent asymptomatic hyperuricemia, it may impair the risk of development of urate and uric acid crystal related clinical events. And respective risk R is associated with the magnitude as well as duration of hyperuricemia. Now the question is arise, should we treat this patient or not? So if the patient with the complication of gout, you have to treat. But hyperuricemia or gout are not synonymous. All hyperuricemic patients are not gout. Most people with hyperuricemia never develop gout, and few gouty patients have normal serum uric acid level. So, but there are different studies of hyperuricemia, asymptomatic hyperuricemia. The studies are about the hyperuricemia in the CNS. It has been seen that hyperuricemia may modestly increase the risk of stroke, incidence and mortality. But if you reduce the hyperuric acid level, there is no beneficial effect. So further research to be needed. So higher level of urate, it is also antioxidant effect. It is a good for the Alzheimer's disease and Parkinson. So whether you have it or not, that it is your choice. So hyperuricemia with coronary heart disease, there is an increased mortality. and development of hypertension and oxidative stress is there, but it is unclear if hyperuricemia has a causal effect or has been more often suggested as simply a marker of other risk factors. So if you treat the hyperuricemia, there is no reduction of the coronary heart disease. So like that, chronic kidney disease, so a causal role of hyperuricemia in CKD has not been established. So CKD is a significant comorbidity in the gout. So urate lowering therapy is needed, particularly moderate to severe chronic disease, particularly CKD stage 3 or more. So there is a different studies, I am not going details about that, that there is a confliction between the two, whether you have to start or not. So in this CKD fixed trial, despite a significant reduction in serum urate, there is no evidence of slower GFR in allopurinol group. So in case of hyperuricemia in chronic disease, it has been seen that in CKD with severity progression, high quality and detailed clinical and basic science studies of hyperuricemia and purine metabolism are needed. They have not given a conclusion. But BMC nephrology, it has concluded that the allopurinol and febuxostate are a urate lowering choice in reducing the composite renal events and improving renal function. And that's why if it is a patient asymptomatic hyperuricemia, most of the patients have never developed gout, so you have to treatment of asymptomatic hyperuricemia carries some risk. It is not considered beneficial or cost effective, generally is not recommended except patient who is receiving chemo or radiotherapy, patient with having a gouty tophi, very strong family history of gout, any intercritical state in between the flare, patient with a history of renal stone. If the patient have a renal stone of calcium stone, there is a chance of deposition of uric acid over there. So you have to treat that patient in that cases. Moderate renal function impairment, particularly stage, CKD stage 3, urolithiasis, uric acid nephropathy, and very high level of serum uric acid. So that I've already said that if you have a tophi, then you have to give the patient. But there is no consensus level in different guidelines. Portuguese guideline says that when it is a uric acid is more than 9, you treat. When it is a Japanese, it is a more than 9, you treat the patient with associated comorbidity, you treat with a 8 milligram. ACR, American College of Rheumatology, it is the guideline says that in asymptomatic hyperuricemia, you never treat the patient. But there is no Indian consensus. There is no guideline still there. So whom do you start this patient, particularly if the asymptomatic uricemia with MSU crystals on the radiology, then there is a lack of compelling evidence whether you have to treat the patient or not. But very high level of hyperuricemia, particularly 12 to 13 in male or 10 milligram, you have to treat the patient. But when the patient of serum uric acid more than 8, you have to just check the 24-hour urinary uric acid level. So if uric acid level overproduction is there, there is a more than 1,000, then you have to treat the patient, and you can take the spot urine, take the fractional excretion of uric acid. If it is less than 5.5, it is indicated as the under excretion. But who are the patients to whom you have to check the 24 hours uric acid? Children and premenopausal women with gout. This gout is very uncommon in menopausal men, premenopausal women. So young onset of gout who have a normal renal function and strong family history, before initiating with uricosuric therapy and uric acid nephrolithiasis without gout, you have to check 24 hours urinary uric acid level. If it is more than 1100 milligram, you just watch the patient, take dietary purine restriction. If it is not controlled, then allopurinol febuxostat should be given. So you can take a help of synovial study, X-ray, and also the ultrasound. So to check the whether it is associated with the different, clinical status is there, and you should take the help of dual energy CT to see early changes of that. But indication of pharmacological urate lowering therapy is that particularly we conditionally recommended ACR, it is a ACR guideline, we conditionally recommend against the initiating of any pharmacological urate lowering therapy over initiation of pharmacological. So there are still ACR guideline till a 2020 guideline don't treat the patient. And they also treat the patient when it is associated with symptomatic. The drug of choice is allopurinol. So allopurinol, though is a first line of drug, you can increase the dose up to 800 milligram. So in what is the take-home message for asymptomatic hyperuricemia, treat or not to treat? Don't use specific urate lowering drugs, treat the asymptomatic hyperuricemia, except special condition that we have already mentioned, but don't ignore it. You should take a follow-up. Hyperuricemia can be a component of metabolic syndrome. So if the patient have a high uric acid level, check the obesity, hyperlipidemia, diabetes and hypertension. So whether they are present or not. Phenylfiprate and losartan may be appropriate agent in a treatment of hypertriglyceridemia and hypertension respectively. And if the patient has with asymptomatic hyperuricemia with some crystals, so you have to check whether the patient is symptomatic, and particularly the radiology and ultrasound give you help to treat the patient or not. And you have to treat the patient in these following conditions. As again I am repeating, uric acid is more than 10, presence of CKD, radiographic damage of attributable to gout, presence of tophi, prevention of tumor lysis syndrome during chemotherapy, presence of uric acid stone, and 24-hour uric acid level is more than 1100 milligram with recurrent stone. Thank you very much.
Thank you, sir. It was a complex topic made very simple and comprehensive. And it was categorical also, so that it was very extensive. Any questions or additions from the floor? Thank you, sir. Thank you.
Thank you, sir. Next, I invite Dr. Lavanya to speak on the topic entrapment neuropathy and approach. Welcome, ma'am.
Good evening, one and all over here. First of all, I would like to thank the organizing committee for giving me this opportunity to present the topic here. I'm going to talk about entrapment neuropathy. Entrapment neuropathy is nothing but the compression or irritation of a nerve when they pass through a narrow anatomical space. It is otherwise known as nerve compression syndrome or pinched nerve. Yes. The main etiologies of entrapment neuropathy are repetitive motion. That is, like when you use a muscle, certain group of muscles repeatedly for a long time, as in case of some occupation, will lead on to this entrapment neuropathy. And any traumatic injury causes this. And at any abnormal anatomical factors. Third, in certain medical conditions like diabetes, hypothyroid, and in genetic predisposition causes this entrapment. And now coming to the pathophysiology behind this entrapment neuropathy. So first, what happens whenever a nerve gets trapped or compressed, there will be ischemia developing in that region. If the compression is not been released, and then this ischemia will not be reverted. If then it will start into a dysfunction of the nerve-blood barrier leading on to edema. That in turn will compress the nerve and will cause intraneural as well as extraneural fibrosis and further demyelination and axonal degeneration. That in turn will cause influx of immune cells leading on to neural inflammation and altered axonal transport. And basically these peripheral nerves and central nervous system, they form a functional unit, and if there is any injury in the peripheral nerve, will in turn cause central nervous system changes. Now leading on to the clinical presentation, normally they present with pain, numbness, tingling, burning sensation, muscle weakness, atrophy, impaired movement, sensitivity to cold, and dry thin skin. And how do we diagnose entrapment neuropathy? Basically the clinical history is more than enough, and physical examination, electrodiagnostic studies, and imaging studies. Going to the treatment, like in all, like mostly all the entrapment neuropathies can be treated conservatively, and immobilization, physical therapy, medications, lifestyle changes, and a last resort is the surgical treatment. And now coming to the common types of compressive neuropathy. Common types are carpal tunnel syndrome, cubital tunnel syndrome, radial tunnel syndrome, thoracic outlet syndrome, and meralgia paresthetica, peroneal entrapment, and tarsal tunnel syndrome, and sciatica. And those compressive neuropathy that affects the upper limb are carpal tunnel, pronator teres, radial tunnel, cubital tunnel, and thoracic outlet syndrome. And those that affect the lower limb are meralgia paresthetica, peroneal nerve compression, sciatica, and tarsal tunnel syndrome. Now going to the case scenarios. A 35-year-old pregnant woman presents with sudden onset of severe pain and swelling in her dominant hand with numbness and tingling over the fingers, especially the middle finger. And the next case, a 45-year-old office worker experienced gradual onset of tingling and numbness in their thumb, index, and middle fingers, noticeably at night and when using computer. They may also report clumsiness and a feeling of swelling in the hand. Third, a 47-year-old woman with hypothyroid presents with a year-long history of paresthesia, numbness, and pain in her thumb, index, and middle finger. Does all these three cases denote a simple single pathology or different pathologies? Can any PGs guess? So all three cases denote carpal tunnel syndrome only, but of varying etiology and varying onset. So let me see the first case. First case is a 35-year-old pregnant woman, which they present with an acute onset of severe pain. They'll be presenting with an acute onset of severe pain due to the carpal tunnel syndrome. And next case is a 45-year-old office worker who uses a mouse with a direct pressure on the wrist that compresses the median nerve at the carpal tunnel. And the third case is a hypothyroid patient who will have a long history on and off with paresthesia, numbness, and pain over the thumb. So this is due to imbalance in the fluid balance. And let me see the carpal tunnel. Carpal tunnel results from the compression of median nerve within the carpal tunnel. This is the most common compression neuropathy in the upper limb. The contents are the median nerve and the tendons of flexor digitorum, superficialis, and the profundus, and in a common sheath. And how do we get this syndrome? Carpal tunnel syndrome. What are the etiologies behind this carpal tunnel syndrome? See, whenever there is decrease in the size of the carpal tunnel, that may be seen in case of any anatomical abnormalities or in case of acromegaly, or increase in the contents of the canal. When there is increase in the contents, for example, in case of trauma or subluxation or dislocations, or in case of aberrant muscles, there will be increase in the content of the canal that in turn compress the median nerve. Then in case of any neuropathic conditions like diabetes, or alcoholism or double crush syndromes, in those conditions also we'll have this syndrome. And any inflammatory conditions like rheumatoid arthritis, polyarthritis, and external forces like direct pressure or vibrations, and alteration of fluid balances as in case of hypothyroid, renal failures, pregnancy, menopause. All these cases will cause alteration of fluid balance and in turn causes this compression, carpal tunnel syndrome. Now coming to the signs, how do we elicit this, how do we diagnose this carpal tunnel syndrome? We have two tests. One is the Tinel sign and another one is the Phalen's test. So Tinel sign is what do we do? We'll just press the median nerve. Just tap the median nerve at the flexor retinaculum, and that the patient will have numbness or tingling sensation over the median nerve distribution. And this is the Tinel sign, tapping over the median nerve at the flexor retinaculum. It elicits a tingling sensation over the distribution of the median nerve. And that is a Fallon's test, wherein you have to flex both the wrist and causing the compression of the median nerve, leading on to numbness over the median nerve distribution. That confirms the diagnosis of carpal tunnel syndrome. So for diagnosis, these clinical history as well as the physical examination is more than enough. In case of severe cases and in some traumatic cases or in some cases, we need nerve conduction studies and certain laboratory tests like to diagnose diabetes, renal failure and hypothyroid. And coming to the treatment part, you have to treat the underlying cause, and we have to modify certain activities, and splinting, local steroid injections are needed in case, and if it is not getting resolved by all means, then the patient, they have to undergo surgical management. Now coming to the differential diagnosis, brachial plexopathy, cervical spondylosis, compartment syndrome, diabetic neuropathy, thoracic outlet syndrome, and tenosynovitis. And prognosis, mild to moderate cases, positively they respond to conservative management, and those who are secondary to diabetes or risk, they often have a very less favorable outcome. And if the carpal tunnel syndrome has not been treated, irreversible median nerve damage will result in permanent impairment and disability. And moving on to the next case, a 45-year-old male weightlifter complains of pain in his right forearm, especially on the medial side, and difficulty in gripping the objects. He reports that he has been having trouble with exercise that requires strong grip like deadlifts, and he noticed he can't pinch a piece of paper between his thumb and index finger. He also mentioned some clumsiness when trying to button his shirt or tie his shoes. So this denotes there is some median nerve entrapment only. But the site of median nerve entrapment varies in this. So why? Because this is caused by anterior interosseous nerve compression. So anterior interosseous branch of median nerve will be compressed by the fibrous bands of flexor digitorum superficialis and pronator teres. So at the forearm level itself, the median nerve will be compressed by these two muscles or any anomalous muscles or tumors or thrombosed vessels, causing these symptoms like that of median nerve. So the clinical features, how do we elicit the sign? Like when you ask the patient to say okay, they will not be able to flex the interphalangeal joints of the index as well as the thumb, because those will be paralyzed by this compression. So this is the sign to elicit the anterior interosseous neuropathy, because these flexor pollicis longus of the thumb will be supplied by the anterior interosseous nerve, and the flexor digitorum profundus will be supplied, and if it is paralyzed, they will not be able to do that action, and we can elicit the sign. And the treatment is the conservative, and if not, surgical exploration. Next case is a 45-year-old chef presented with forearm pain, numbness in the thumb and index finger, weakness in hand grip, impacting their ability to perform tasks like chopping the vegetables or holding the utensils. Can anybody guess this? So this is a pronator syndrome. See, all these three different case scenarios, they involve only the median nerve distribution, but at different sites. This pronator syndrome, this is caused by the compression of median nerve by the pronator teres muscle in the forearm level. So what happens? Because of repetitive pronation and supination action causes this pronator teres muscle hypertrophy and entrapping the median nerve here. And they manifest as pain over the volar aspect of the forearm, and they will be having numbness over the fingers also, fingers and hand also, and apart from that they will be having pain over the volar aspect of the forearm. And we can elicit by the Tinel sign. And this is the pain distribution. And this shows the difference between the pronator syndrome and the carpal tunnel syndrome. In pronator syndrome, what happens? The pain distribution will be over the forearm, whereas in carpal tunnel syndrome, the pain will be over the wrist. And numbness and tingling will be over whole of the palm on the lateral side of the hand, whereas in case of carpal tunnel syndrome, it will involve only the fingers. And typical nighttime symptoms will be there in only carpal tunnel syndrome, but it will not be there in the pronator syndrome. And the case scenario, a 22-year-old baseball pitcher complains of pain in lateral elbow after a series of intense pitching sessions and is aggravated by throwing, especially when extending his wrist and forearm. He also experienced a decrease in throwing velocity, possibly due to weakness and pain in his forearm. Any guess? Nerve involvement. It's a radial nerve involvement. So it is radial tunnel syndrome. This is a rare compressive neuropathy of posterior interosseous nerve, which is a branch of radial nerve. As it passes through the radial tunnel, results in the pain without any motor or sensory dysfunction. This radial tunnel is situated between the radiocapitular joint and the supinator muscle. Yes, this is the space of the radial tunnel. So when you do the repeated pronation and supination action, there will be hypertrophy of these muscles causing the posterior interosseous nerve getting trapped in that muscle, causing this symptom. And this is a difference between there is a correlation between these symptoms, because even the tennis elbow will manifest like this, but only difference is that they present with the pain over the forearm area, whereas in case of tennis elbow, they will be telling the pain over the lateral epicondyle. In this case scenario, a 26-year-old female beauty therapy student experienced tingling and dull ache in her left arm, particularly when raising her arm above her shoulders. She also reports numbness and muscle wasting in her hand with a decreased sensation to pinprick. This case denotes a neurogenic thoracic outlet syndrome. Here we can see the compression of the nerve between the clavicle and the first rib. There is a brachial plexus compression between the clavicle and the first rib, causing the symptoms. So it can be caused by any anatomical abnormalities, repetitive motions, poor posture and traumatic injuries. And this is the pain distribution. And the next case scenario, a 35-year-old cyclist. He participates in long-distance road cycling events. After a 100-mile ride, he began to experience numbness and tingling in their ring and little finger on his left hand. Also notices slight clumsiness when using his left hand when trying to grip objects. Case 2. 18-year-old boy who was fond of playing video games developed numbness and tingling in the ring and little fingers with pain in the elbow, forearm and hand. These two cases denote compression of the ulnar nerve, but at a different level. Ulnar nerve usually gets entrapped at two common sites. One at the elbow, that is called the cubital tunnel syndrome, and one at the wrist, that is at the Guyon's canal, called the ulnar tunnel syndrome. So cubital tunnel, this is the second most commonest nerve entrapment of the upper limb. Compression of the ulnar nerve at the elbow causes the symptoms of pain and numbness along the medial half of the forearm and medial half of the fourth digit and the fifth digit. And there will be loss of sensation. The clinical features can be elicited by the tinel sign asset of the median nerve. And it is most common those who are playing with the video game that they press the elbow for a long time, that will lead on to this compression of the ulnar nerve, causing this. And coming to the ulnar tunnel syndrome, it is this here, the ulnar nerve is compressed as it passes through the Guyon's canal in the wrist, in this region. And see, ulnar tunnel syndrome, it is otherwise known as cyclist neuropathy or a handlebar palsy, because cyclists, they will be like putting all the pressure on the hands, and that will in turn compress the ulnar nerve at the wrist place. This in turn causes palsy. Even sometimes it may cause even motor sensory or even both. And now we can coming to the compressive neuropathy of the lower limbs. First one is the meralgia paresthetica. So everyone know this meralgia paresthetica will be coming across in our daily day-to-day practice. It is most common in the diabetic patients. So it is due to the compression of the lateral femoral cutaneous nerve. Like when it passes underneath the inguinal ligament, it gets compressed between the inguinal ligament and the sartorius muscle. So what are all the etiologies? Mostly it is of mechanical, metabolic or iatrogenic. Mechanical, so whenever there is increase in the intra-abdominal pressure, when there is increase in intra-abdominal pressure, whereas in case of obesity, pregnancy or 2 minutes. Pregnancy, obesity, and if you wear tight clothings or belts, pubic symphysis dysfunction, and metabolic in case of diabetes, hypothyroid, and alcoholism, and iatrogenic in case of certain pelvic surgeries. They will have to do, spine surgeries, they have to do prolonged traction that also causes this meralgia parasitica. How do they present? They will have a typical presentation of causalgia and paresthesia and hyperesthesia over the upper lateral thigh. And typically they will be unilateral and it can all be relieved by sitting or standing posture. And diagnosis by means of pelvic compression test. How do we diagnose this meralgia parasitica? Like by means of pelvic compression test clinically. Like what do? Like we will ask the patient to lie with the unaffected side on the floor and affected side upwards, and you have to compress the pelvis from above downwards. Like if the patient gets relieved of the symptoms, it confirms the diagnosis of meralgia parasitica. And the main treatment is patient reassurance only. Mostly it is a benign and self-limited condition of spontaneous regression. So we have to reassure and educate the patient and advise the patient for weight loss and abdominal exercises. And next comes the sciatica. Sciatica, it's due to the compression of the sciatic nerve mostly due to the herniated lumbar disc or by the lumbar canal stenosis. So how do we diagnose this sciatica? By means of slight raising test. Here, like when we raise the affected limb above 30 degrees, like 30 degrees to 70 degrees, the patient typically they'll wince of pain in the buttock region of that involved site. That confirms the diagnosis of sciatica. And the treatments or the routine patient education, medical therapies, and surgical evaluation and correction. And next, coming to the peroneal neuropathy. This is the most common compressive neuropathy of the lower extremity, and this third most common. And the risk factors, or since because it is more superficial, it is more prone for traumatic injury. And behavioral causes, like when we use cross leg posture for a long time, they are more prone for peroneal. And surgical causes, when we do surgeries, when they do surgeries in the knee or in the thigh, they are more prone for surgery and diabetes. And when we use tight compression stockings or cast splints, and that in turn compress this peroneal nerve easily. And the typical clinical presentations are weakness of ankle dorsiflexion, great toe extension, foot eversion, and sensory loss over the dorsum of the foot. And in severe cases, they will lead on to foot drop. Diagnosis by Tinel sign. Initial treatment is non-surgical, and in further, if the not treated by bracing or observation, the patient has to undergo hydrodissection and finally surgical decompression. And last is the tarsal tunnel syndrome. The tarsal tunnel syndrome, it is due to the compression of the posterior tibial nerve in the tarsal tunnel. Tarsal tunnel is medially by the medial malleolus, and the roof will be by the flexor retinaculum. And through that, the tibial nerve, tibial artery and vein will be passing. And it is due to the compression of this space by means of ill-fitting shoes or any traumas, post-surgical scarrings, pedal edema, and tenosynovitis. All these causes this syndrome. And the patients typically will be having a perimalleolar pain and burning sensation in the ankle, and they'll have paresthesia, sensory loss, and they'll have foot muscle atrophy. And you can easily evaluate by means of dorsiflexion and eversion test. And if you do dorsiflexion and eversion, if the patient winces of pain, that confirms this diagnosis. And for evaluation, ankle and foot radiography is the investigation of choice. And in extreme cases, USG and imaging will be helpful and can be treated by the medical therapy and good fitting orthotic shoes, and if not, corticosteroid injection and surgical treatment. Thank you. Thanks for giving me the opportunity. Thank you.
Thank you, madam. That was an elaborate lecture on intraopen neuropathy. I think PGs might be useful for them. It was elaborate. Any questions? Adding on to it, there is biomarkers which are on the vogue for intraopen neuropathy, and in the management, there is stem cell therapy for axonal regeneration, but all in the experimental stages. And there is a device also ergonomically designed to tell you that you are doing a same repetitive movement.
Yes, please. Since shortage of time.
Yes. Thank you. Thank you, ma'am.
Thank you.
Thank you, ma'am. I now request our chairpersons to extend a token of appreciation to Dr. Lavanya for her insightful and engaging presentation. I now request Dr. Bharani to felicitate our chairpersons.
We'll go to the last session for today. I request Dr. Satish Kumar K and Dr. Gobarni Madam to take the stage to chair the session. I request Dr. A. Rajshekharan sir to take the dais for the first session on non-resolving pneumonias.
Shall we start? Respected chairpersons and esteemed colleagues and senior friends, and it is a very good opportunity. At the outset, I thank the organizing team of TAPICON 2025 Vellore for a wonderful academic feast for the past 2 days. And special thanks goes to Dr. Satish, the secretary of this conference, and also the scientific chair, Dr. Vertigo sir, and for this wonderful opportunity to deliver this topic among the august audience at the Premier Institute of Vellore in the Scudder Auditorium. And this non-resolving pneumonia is always a clinical dynamo, and it is an area of pulmonologist interest also. And the outline of my presentation is what is the definition of a non-resolving and slow-resolving pneumonia and its various etiology, a few case scenario, and the point of care for PCR-based test, what are all the tests available, and to propose a final diagnostic algorithm with a non-resolving pneumonia, what test to ask, when to ask, how to do, why about. Sorry. Among the community-acquired pneumonia, 10% of the community-acquired pneumonia and 60% of the hospital-acquired pneumonia show an inadequate response to empirical antibiotic therapy initiated. Initially, any pneumonia, we are initially according to our experience and also the area of area where we are practicing and the organisms which are very familiar to that particular region, all those things we decide our antibiotics. So most of the time the pneumonia we are not establishing initially the causative organism, and we taught an empirical therapy. And coming to the definition, it is a clinical syndrome in which the focal infiltrates begin with an association of an acute pulmonary infection, and in spite of 10 days of antibiotic therapy, the pneumonia does not resolve, or it will not show a remarkable recovery, a radiological clearance, and the opacity fails to resolve within 12 weeks of time. And normally you all know that the normal resolution of pneumonia, these are all the various symptomatology, the fever, tachycardia, hypertension, tachypnea, and also the biomarker like C-reactive protein, all will be there for about 2 to 4 days, and cough will last for about 4 to 10 days. And the chest X-ray abnormality usually lasts for 4 to 12 weeks. This is the normal duration of symptomatology of any resolving pneumonia. And there are various factors which decides the non-resolving pneumonia. For example, younger age group, the resolution will be better, and older age group, more than 60 or 65. That's why we bother about the pneumococcal vaccine in older age group. And comorbid illness like COPD, asthma, diabetes, and smoking, and defect in defense. If our patient is already on endotracheal tube, tracheostomy, and immune compromised state like HIV and diabetes, malnutrition, all will predispose us to non-resolving pneumonia. And there are, according to the virulence of the organism and also the resistance of the organism, the duration of the illness also determined. For example, you can suspect streptococcal pneumonia if the patient gives a history of beta-lactam treated with beta-lactam for within 6 months of time, and closer exposure to young children. Young children will be the streptococcus is a commensal, and any household age-old contact person who are very close to the children may have a chance to get the streptococcal pneumonia. Pneumonia in the last 1 year, and hospital-acquired pneumonia in the last 2 months. These are all situations may predispose, but it is only we cannot conformly say about it, but it is, we can presume that it can be a streptococcal pneumonia. The same way the methicillin resistant pneumonia, if the patient is advanced age, prior antibiotic coverage, indwelling catheter, and dialysis, burns and wounds, any area of sepsis, there is a chance for MRSA organism. And usually the hospital acquired pneumonia, the patient will have an MRSA or the Pseudomonas or Acinetobacter is the causative organism. And there are also a lot of unusual organisms like atypical mycobacteria, even tuberculosis will have a prolonged course, and nocardiosis, actinomycosis, pneumocystis, and fungus like Aspergillus, Cryptococcus, Schistoplasmosis, coccidomycosis, and history of exposure to animal. For example, Coxiella barneti and Citasi, Chlamydia, all these organisms are very unusual, but they may give a long, prolonged course of illness. And depends upon the anatomical involvement or radiological involvement, whether it is a multilobar involvement or a bilateral involvement with pleural effusion, and if it is associated with bacteremia, and also empyema, abscess, and metastatic infections like source like infective endocarditis, all may cause delayed clearance of the pneumonia. And also these non-infectious causes. We think that by default, even in our undergraduate days, pneumonia means we commonly think about only infection. Majority of we are all tuned, and by default we think in infectious. But actually there is 20% of non-infectious causes of pneumonia is non-resolving pneumonia is non-infectious, among which the neoplasm, the bronchoalveolar cell carcinoma, lymphoma, lymphangitis carcinomatosa, inflammatory disorders like systemic vasculitis, connective tissue disorder, diffuse alveolar hemorrhage, and bronchiolitis organizing obliterans. Now the terminology has changed to cryptogenic organizing pneumonia, sarcoidosis, and some history of drug intakes. For example, amiodarone, nitrofurantoin, methotrexate, that will produce a pulmonary infiltrate which will mimic like a pneumonia. And cardiac causes, pulmonary thromboembolism, congestive cardiac failure, in which the pulmonary edema will mimic like a pneumonia, and especially in COPD patient, because of the perfusion defect, the pulmonary edema will present in an atypical way, and the fluid will accumulate in the fissure that will appear as a pseudo tumor, that is called the vanishing lung tumor. And the clearance of the organism also, when I look into it, the pneumococcus, bacteremic, non-bacteremic, and Haemophilus, chlamydia, Staph aureus, all will have a duration of 2 to 5 months. And the mycoplasma will have a 2 weeks to atypical pathogens, mycoplasma 2 weeks to 2 months, and Legionella 2 to 6 months. So with these various factors which determine the non-resolving pneumonia, now I present some case scenario. This is a 32-year-old male, diabetic, uncontrolled, active smoker, and cough with mucopurulent sputum for 2 months, and fever for 2 months with chills and rigor, breathlessness on exertion for 1 month, and loss of appetite and significant weight loss of 15 kg in 1 month. This patient was presented to an outside hospital where they have taken an X-ray, and also they have done a sputum culture, and they have done a ball also there. And this culture turned out to be E. coli and susceptible to levofloxacin. The CT thorax at the time showed a left lingular and lower lobe consolidation. And after 10 days after the clinical worsening, and the patient, initially it was the ball culture at that hospital was about Pseudomonas and the sensitive to meropenem, and treated for 14 days. But his symptoms did not subside, and hence he presented to our hospital. And further we have done this is an X-ray at the time. We showed hydropneumothorax, which was undergone an ICD, and the pleural fluid was predominantly lymphocyte, but at the same time the ADA level was very low. And here again ball was repeated, that is suggestive of actinomyces, and the patient was later given 14 days of penicillin G and later switched over to oral amoxicillin. And empirical ATT was also given along with antibiotics. And patient clinically, after 1 month of appropriate antibiotic, the last X-ray what you see is showing a radiological resolution of the left heterogeneous opacity. This is a case scenario of a second patient. He is a 41-year-old male, non-smoker, uncontrolled diabetes, HbA1c is 11.3, mucopurulent sputum, fever for 3 weeks, and sputum results were inconclusive. And this chest X-ray shows a left mid-zone opacity, and there is, if you look into it, there is a fluid level. But when it was, the CT was taken, that shows only a cavity with the adjacent consolidation. And the sputum culture, you can see that the aseptate ribbon-like hyphae, which is a classical feature of a mucor, and the diagnosis of mucormycosis was arrived. After a cumulative dose of 2 grams of liposomal amphotericin, the patient did not improve, and cardiothoracic opinion was obtained, and then he undergone a left upper lobectomy, and total of 4.5 grams of liposomal amphotericin followed by oral isoconazole for 6 weeks was given. And this is a third patient, and then 50-year-old male, farmer, uncontrolled diabetes, and the loss of appetite and significant weight loss of 5 kg, cough for 2 months, and the recent onset of wheeze and shortness of breath. Initial chest X-ray, there was a faint right opacity, sputum report inconclusive, and we went ahead with the PET CT, and then the right, it has shown a right lower lobe spiculatal lesion, SU uptake of 3.5, and necrotic mediastinal node. The largest one was the subcranial, and multiple splenic infarct. Patient underwent an endobronchial ultrasound transbronchial needle aspiration, and it turned out to be suppurative infection, and the ball culture turned out to be Acinetobacter, and he was treated for Acinetobacter and later discharged with ATT, and after 2 weeks call from microbiologist. It is a Burgholderia pseudomalae, and actually was further given ceftazidime, and clinically patient improved. This is a female, no known comorbidity, 57-year female, presented with a dry cough and outside hospital for 2 weeks, and shortness of breathlessness for exertion of 10 days, and along with the history of left shoulder pain, and it is diagnosed as CAP, and all investigation including respiratory panel was negative. And then the treating physician at the time of discharge found that the saturation was 88%, and she reassured the patient that he will be okay with the steroid. And after some time, the patient brought to our emergency room with increased shortness of breath, and with a grade 4 MMRC scale of dyspnea with cough, and increasing left shoulder pain with a saturation of 60% at the time of presentation. And this was the CT chest taken at the time, shows bilateral ground glass opacity with interlobar septal thickening, suggestive of an ILD. So an ILD workup was done, and then R12 and PL12 was positive, strongly positive. So the patient initially a diagnosis of amyopathic dermatomyositis was made, as the CPK was normal. But after that, myositis was profile was, as CPK was normal, we did a myositis profile, and the diagnosis was revised as anti-synthetase syndrome. And MRI of both thighs were suggestive of atrophy and of the posterior compartment of both thighs with inflammation. The patient was treated with a pulse dose of methyl prednisolone for 3 days, followed by oral prednisolone 60 mg was continued, and along with the rituximab was later overlapped with the prednisolone. And there is a drastic clinical improvement with a saturation of 88% at room air. This is a case 5. The 40-year-old female, the patient was initially presented to a neurologist for chronic migraine. And the neurologist taken an MRI with whole spine screening, and it found to be, incidentally, they found a chest lesion. So they revert for opinion and further evaluation. And here he has underwent a ball. Improbase MTB was detected, which was rifampicin sensitive, and he was started on ATT. And after 2 months, there is no improvement. So we proceeded with a CT-guided biopsy, and the CT-guided biopsy was turned out to be a mucosa-associated lymphoma. It's a maltoma. And this is a case 6. This is a 55-year-old man, high-grade fever, cough with expectoration for 10 days, treated with broad-spectrum antibiotics. His chest X-ray on admission shows left mid-zone and lower zone peripheral consolidation. Despite treatment for more than a week, the patient continued to have persistent symptoms. And this was the CT chest at the time showing a left upper lobe consolidation. In the meantime, the C-ANCA was found to be positive, and he underwent a biopsy. The histopathology showing a granuloma, necrosis surrounded by a granuloma, and a vasculitis, vaginous granulomatosis was diagnosed, and patient was treated with pulse steroid, and then later switched over to cyclophosphamide, and later on he was switched to azothioprine. So this is a case 7, 37-year-old male, a dry cough and shortness of breath, and there is a CT showing bilateral patchy ground glass opacity with the centrilobular nodule, and this is an eosinophils ball was showing 30%, and it is a case of eosinophilic pneumonia, and he was improved with steroids and symptomatic supportive treatment. This is an asthmatic, complaints of wheeze and increased shortness of breath and expectoration. CT shows a left upper lobe high attenuation mucus suggestive of mucus plaque, and he was also the serum total Ig was elevated grossly about 47,000, and aspergillus specific Ig was also elevated. So then ABP, allergic bronchopulmonary aspergillosis was diagnosis was made, and he was initially started on steroid. Further, he was added with itraconazole, and patient clinically improved. So this is actually a case of nocardiosis, but I'm not going into the detail. That patient has presented an immune compromised patient, but initially presented as a bilateral bronchiectasis along with sputum culture suggestive of nocardia. And also nocardia will have a varied presentation apart from skin manifestations, left lung collapse with cystic bronchitis, mosaic attenuation, and bilateral lung parenchyma, subpleural honeycombing with this architectural distortion. Among all these varied panoramic case presentation, what I want to stress to this audience here is the non-resolving pneumonia may not only infective, it may have a varied etiology like vasculitis, allergic bronchopulmonary aspergillosis, eosinophilia, and also drug-induced. So we have to keep in mind to work out the case. And with this, what is the role of a bronchoscopy? This is actually this study, there are regarding the role of bronchoscopy, the studies are very positive, studies are available. This one study was done in the eastern part of the India, R.G. Garg Medical College, where they have done about prospective observational study, 60 patients, and predominantly the lesion was found in the right lung and right upper lobe, and then the 53% are pyogenic infection. Bronchogenic carcinoma is about 26.7%, and 16.7% of tuberculosis. And if there is any inconclusive due to bronchoscopy, then they proceeded with CT-guided biopsy. And CT-guided biopsy, the diagnostic yield is 91%, and bronchoscopy, the yield is about 85.7%. And regarding this rapid PCR test, a word about rapid PCR test, now it is actually coming up in a big way. But it has its own limitations, but anyhow, it is the cost is the pitfall is the cost, but it gives an advantage of rapid diagnosis, rapid detection of resistant genes, and the turnaround time is very short, just 1 hour to 5 hours, but conventional culture is very much delayed. And you have an advantage to escalate and de-escalate antibiotic, and detect organism treated with prior antibiotic. The sensitivity is about 98% and specificity is about 76%. So with this, when you have a case of persistent pulmonary opacity, you have to go for a clinical evaluation, assess the comorbidity, and sputum, gram staining, pap staining, and adequate antibiotic therapy. After adequate antibiotic therapy, if there is a radiological recovery, yes, it is a resolved pneumonia. If it is no, then you have to go for a bronchoscopy, CT, protected breath specimen, transbronchial biopsy, sputum smear for IAB culture, fungus, unusual pathogens. And if you are able to arrive at a diagnosis, then you can treat accordingly. If diagnosis is not reached, then there is a role for CT-guided fine needle aspiration, peripheral and echo, and blood-based tests like C-on-Ca, and if you suspect a sarcoidosis, ACE level. So like that, we can have a diagnostic approach of a non-resolving pneumonia. So with this, I conclude my takeaways. The non-resolving pneumonia is a clinical common entity, and algorithmic approach helps to establish the correct cause. The pneumonia does not mean it is always infective. To avoid this confusion, it may be better approached as a non-resolving pneumonia syndrome rather than as a pneumonia as a single entity. Once we start looking beyond infective case, because we shall recognize many missed non-infective conditions. Thank you very much for this very good golden opportunity. These are all my references. Thank you, the chairpersons and the
Thank
August
you very
audience.
much, sir.
Thank
It was a very informative. We are delighted to listen to you. Thank you, sir. Any questions?
Questions in the last part.
Okay. So at the end of the session, we'll have questions, sir, if any. Next speaker, please.
I request Dr. James Prince to deliver his talk, a pleural effusion, simple, safe, and fast diagnostic algorithm.
Good evening. It has been a long day, so I'll keep it short, don't worry. I want to thank API Vellore branch as well as Dr. Vertigo, Dr. Satish, and for inviting me for this wonderful conference. So task for us is management of pleural effusion. We will just quickly look into that, how to keep it simple, safe, and how to get the diagnosis very quickly. So we look at the problem and then we see, normally we do thoracocentesis, so how to make thoracocentesis more safe. And then we look into the pleural fluid analysis, what are the new things which we can do to get a quicker diagnosis. And then thoracoscopy has come in a big way, and that's the test for pleural effusion management at present. And then we look at the current algorithm. So effusion can present in multiple ways. It's free flowing, it could be loculated, and sometimes we get bilateral. And what do? We do usually a diagnostic aspiration, sometimes very big, then people do therapeutic also. You can put a chest tube and drain it. Thoracoscopy is one option, as well as sometimes surgeons do thoracoscopy, we call it VETs. So multiple options available. What should we choose? We look into that. Most important is thoracocentesis, because with which we evaluate the pleural effusion. So how to make it safe? This slide says that even the senior physicians, when they do without ultrasound guidance, number of times we injure the lung and create pneumothorax, and sometimes we injure the diaphragm and other organs. While you give ultrasound in their hand, and then the incidence rate come down. So that underlines the importance of ultrasound, and ultrasound has come in a big way. You can see this picture, sometimes effusion, this picture only X-ray shows a haziness over there. It could be pneumonia. We can't put a needle over there, lung will get injured, but ultrasound clearly shows there is an effusion and can be aspirated. So ultrasound guidance at present, is mandatory for thoracentesis. Nobody should put a needle on a patient chest without ultrasound guidance, and what we are talking about is a real-time guidance, not the radiologist marked a site and send it to our procedure room and then we are trying to aspirate. It's a real-time ultrasound. When we are going to put a needle, we are having ultrasound probe in our hand, and under guidance we are aspirating. So whether you take British Thoracic Society, European Respiratory Society, or American or even Indian Chest Society, there is a strong recommendation. Without ultrasound guidance, we should not attempt a pleural fluid aspiration. Pleural fluid aspiration, this can be divided etiology into transitate and exudate as we know the list. So, and the Light's criteria is an age-old one. We do the protein LDH, absolute value of LDH, and divide whether it's a transitate or exudate. However, as we are doing the analysis, a lot of things we have to send, as I already said, sugar, protein, albumin, LDH, and other things, and differential count cytology. Usually when we are sending, you should try to send it together so that the whole diagnosis comes in one way and not the part by part. Most important of all these tests has come up as an expert MTB, which we will be discussing in the coming slides. Despite doing this full analysis shown in previous slide, diagnostic rate of pleural fluid analysis is around 10 to 20% only. That was before 2010 when expert wasn't come. So AFB positivity will come in some 2 to 5% cases at the maximum, and most of the time exudative you will end up with the lymphocytic exudate, and you put the clinical together and maybe a PPD and try to make a diagnosis. It could be TB. Can be true in a primary or secondary healthcare center, but surely not in a tertiary care center. How to fix the diagnosis now, how to be very confident about the diagnosis, whether we are working in the primary or secondary care or in a tertiary care. TB is one of the most common cause for tuberculosis in our country. And if you see this slide, these are the data from the expert, and then nowadays we have expert ultra, and you can see this initial data from CMC, around 14% times fluid was positive. But recently, it is when the studies are done, numbers are going up 48 and 50%. And with the new generation expert, it has reached from 42. If you do it in the pleural tissue, it becomes 83%. So with the expert ultra, you can, in 50% of cases of pleural effusion, expert ultra picks up the mycobacterium and gives the diagnosis, which is a direct diagnosis. Just aspirate, send the sample to the microbiology lab, run an expert ultra, and 50% of the cases you don't have to do thoracoscopy or any other procedure, you have the diagnosis. And if the thoracoscopy is being done, then what happens in our lab and all, in our system and all, that when we send the pleural biopsy sample, most of the time before the pathologist say they are showing granuloma, our microbiology lab says that in 83% of the cases, within 2 hours, the diagnosis is TB. So it helps in a big way. So I will suggest look into the microbiology lab of your hospital and try to send pleural fluid samples for expert ultra. Gold standard is midget culture for TB, but you can see the numbers. Midget culture is 33% positive in the pleural fluid and 44% in the pleural biopsy. So actually, expert has exceeded the sensitivity of midget culture, though the midget is still gold standard, we call it, but expert is much more better test than the midget also. In case we don't get the diagnosis or diagnosis is not TB, then we have to find out the diagnosis. The second most common diagnosis becomes like either pneumonia or infections, or it is a malignancy, and the pleural biopsy has a big role over there. Multiple ways you can do it: in Abraham needle biopsy, CT biopsy, guided image, ultrasound, and the thoracoscopy. The major difference between the surgical thoracoscopy, or we call it VATS, is a huge cost fact over there. Patient gets admitted in ICU. While medical thoracoscopy, a pulmonologist can do it for our patient in 30,000–40,000 rupees as a daycare procedure. And the diagnostic yield of medical thoracoscopy is really, really high. It reaches 98, or you can say almost around 100%. If the patient undergoes, you will surely get the diagnosis. And what the patient feedback regarding all these procedures, aspiration, guided biopsy, thoracoscopy, when to put together, most of the time, most of the patient says, just do one procedure. Don't aspirate and then wait and then do thoracoscopy and keep doing multiple procedures. Save the time, give the diagnosis within 1 day, and save the procedure also, and keep it safe as well. These are the few pictures for medical thoracoscopy. Because you are entering the inside the pleural space, you can see the costal pleura, you can see the visceral pleura here, you can see the diaphragm, you can see nodules sitting over there. Ultrasound can show sometimes there are adhesions sitting there. You can even clear the adhesions with the help of thoracoscopy. This is a thoracoscopy picture of adhesion. So even that can be cleared, which will not get cleared by the chest tube or just the aspiration. Nodules are directly visible on the costal pleura, and this is the thoracoscope inside. You can biopsy and fix a diagnosis. And that's the reason thoracoscopic biopsy diagnosis reaches around 99–100% around. That's very typical appearance of TB on the thoracoscopy. But as I said, collect the sample from this nodule, give it to the microbiology. Within 2 hours, they give the diagnosis. The expert is positive. So what's the current algorithm? I'll say do the chest ultrasound. If it is anechoic effusion, it says directly transitate. No need to put any needle over there. If the patient has a kidney, heart, or liver disease, no need to aspirate. Do the fluid restriction, give diuretic, repeat the ultrasound after 2 days. Patient is improving. Treat the primary cause, which is heart, kidney, or the liver. No need to do any procedure on the patient. If it is exudate, try to send the whole pleural analysis, focus on expert ultra, try to get the diagnosis. If it is not TB, plan for medical thoracoscopy. Diagnosis will come really, really fast. That's a little bit of video. If it runs, I'll just show you how the new... I'm sorry, I'm unable to run it with this thing here. Anyway, these are the new aspiration needles. Our worry during aspiration was that needle goes inside, it can touch the diaphragm, it can touch the lung, and we do not know what it is injuring. So these are new needles. You can see they are blunt. So when you press on the chest, the sharp end comes in and then goes in. The moment it reaches the costal pleura, enters the pleural space, the blunt end come forward. So by no means somebody can injure the lung or diaphragm, any visceral thing. And it is one-way valve over there, so even the air can't go back inside. So all those things can be covered with the newer kind of pleural aspiration needles, and we use it, and I will suggest you look into that and try to acquire newer needles to make the procedure more safe. And these are the chest tube drainage set. When I was doing MD, this was the chest tube drainage bottle. We call it underwater seal bottle, and then Spectra. This is being used. It is same like this, but in a plastic bottle which is manufactured. And these are the newer bottles, because these bottles, if they tilt, when we are shifting the patient from ward to the radiology or somewhere we are always worried the bottle tilts, falls down, fluid goes up, and then how the air will go inside the patient chest. No worries about this newer bottle. This has no water, there's no underwater seal, there's a valve. You can leave the bottle in any way on the patient trolley, it will still function. And it has a control valve over there. No extra suction can go to the patient chest. So very, very safe bottle which we are using in these days. And it also helps in knowing the lung is expanded or not. You press this bulb here. If it doesn't come back, it means lung is expanded. So no need to repeat X-ray after every 3rd day, 4th day to know a lung expanded or not. Just press on the chest wall this bottle bulb and you know lung expanded or not. So pleural field effusions, I'll say use the ultrasound as much as possible, or mandatory. Always assess effusion with ultrasound. Analysis, do the complete workup, use expert as much as possible. And if the ultrasound is saying it is transitate, no need to aspirate. Treat with a diuretic and fluid restriction, redo the ultrasound after 2 days. If expert is negative, send the patient for medical thoracoscopy. That's the most safest procedure and highest diagnostic yield procedure at present. And try to acquire newer techniques, aspiration catheters and drainage bottles, which helps the patient keep it safe. Thank you. Any questions? Most welcome.
Questions we'll keep to the last, sir. Thank you, sir. Many people do not finish on time. Very, very few people finish before time. Thank you very much.
I think it's a very short and sweet lecture and crisp lecture. So next we will request Dr. Satish Kumar from Vellore. So he is going to talk about snoring is not just sound, it can be serious.
Good evening, everyone. Late in the evening. First of all, I thank the organizing team of TAPICON and our HOD for giving me this wonderful opportunity. So here am I today to throw some light on snoring. It's not just a sound, it can be a sign of something serious. So I hope for the next 10 to 12 minutes, no one has OSA in this hall. So we are going to see about the pathophysiology and the risk factors associated with OSA and some of the comorbidities linked with OSA and the management plan and an example of case about severe OSA. So, going into the definition, obstructive sleep apnea is a sleep-related breathing disorder characterized by repetitive episodes of complete or partial obstruction in the upper airway during sleep, usually associated with oxygen desaturation, arousals from sleep and leading to fragmented sleep, and daytime symptoms such as excessive daytime sleepiness. Coming to the epidemiology, globally around 9 to 38% of patients has OSA. In India, recent study shows that 9 to 33% patients has OSA, but most of them goes underdiagnosed because they do not seek the help of medical facility, and most of the patients just ignore snoring as just a sign of sound sleep. So going to the pathophysiology, the factor behind OSA is that the anatomical narrowing of the upper airway, which in turn, along with the decreased upper airway muscle tone during sleep, especially in the REM sleep, leads to airway collapse, and especially in the supine position, causes repetitive obstruction, leads to hypoxia, and in turn which leads to increase in the sympathetic tone, and this cycle goes on and patient has a fragmented sleep and the consequences of that. So the site of obstruction may be multiple. The first picture shows the normal upper airway anatomy. The second picture shows the site of obstruction, which may be at the level of base of the tongue or the soft palate or the lateral pharyngeal wall. So the site of obstruction may be multiple, so it may not be in single site. So even in sometimes surgical management or mandibular devices may fail to improve the symptoms. But CPAP therapy usually splints open all the sites of obstruction and relieves the symptoms and improves the outcome of OSA. Risk factors, when we say about the risk factors for OSA, there are lots of risk factors. Whatever the risk factors we say for obesity, hypertension, diabetes, all fits in with OSA. Any male patient who is obese, whose neck circumference is more than 17 inches, and who is an alcoholic and smoker is a high-risk patient for OSA. So as physicians, everyone knows about Syndrome X, but when it combines with OSA, it is the deadliest combination because it is known as Syndrome C, where one another diseases increase the risk of other disease. So as a whole, OSA is not a disturbed sleep, it is an amplifier of metabolic and cardiovascular morbidity and mortality. So we'll see some of the coexisting diseases along with OSA. This is one of the short study where they involved 12 patients and screened them for OSA and treated for 1 week of CPAP therapy. It drastically improved the fasting glucose metabolism and even reduced the dawn phenomena. So this short-term therapy, if it can improve the outcome of glycemic control, so we can think it in a long-term therapy, how it may improve the treatment outcome for patients with uncontrolled diabetes. Next, OSA is also a silent risk factor for cardiovascular diseases. As it increases the sympathetic tone, it increases the heart rate variability, leads to resistant hypertension, and causes arrhythmia and even ischemic strokes in patients who do not seek medical attention. So we need to look upon this OSA as a serious factor, and snoring we should not neglect them and screen them for this OSA and treat them accordingly. Next is hypertension. If we zoom into this hypertension, there may be a synergetic effect if we treat these patients who is having resistant hypertension, and these drugs which is being used like losartan can have a synergetic effect and improve the outcome, especially in young patients who is not responding to the maximum medical management. And OSA is also more frequent in patients who has stroke. This is a meta-analysis showing that 70% of the patients who has stroke is having an unmasked OSA. So if we treat this OSA in these patients, it may improve the treatment outcome, improve the recovery time of stroke, and increase the rehabilitation performance so that patients will have an AC recovery and will improve in due course of time. And it may even reduce the recurrence. So these are the effects of OSA, which is a pathological cascade. As a whole, we told about that the repetitive obstruction can have this hypoxia happening in a cyclical way, and it can increase its oxidative stress, which is the most common risk factor for all the metabolic diseases. So as a pulmonologist, COPD is in our hearts, but some of the COPD patients who land up in ICU with type 2 respiratory failure and who has recurrent exacerbation, when we have a close examination and when we look back the history, if he is an obese patient, we might have an unmasked OSA, because in these patients, because of this emphysema predominant COPD, there may be gas trapping, and even this nocturnal desaturation may mask this OSA because of low AHI if we even screen them for this with the sleep study. So we should have a little bit of clinical suspicion and then suspecting these patients and treat them with optimal CPAP therapy, and it may overall increase the treatment outcome and even prevent the future exacerbation in these patients of COPD. So how do we screen these patients? We have different types of screening questionnaire. Most commonly used is the stop bank score, which includes 8 questions which need to be asked, and the patient says yes or no. And we can easily pick up the patient who is low risk and intermediate risk and high risk for OSA. There are other questionnaires also, which is Berlin questionnaire, Ipswich sleepiness scale, and NOSA score. When we use this Ipswich sleepiness scale and stop bank score along with it, it increases the predictive value for assessing patients who is in a risk factor for OSA. We are conducting a study on this, and these results will come up in a few months of time. And how do we diagnose the patient? Polysomnography, it is the gold standard mode of diagnosis, and it includes 9 to 10 parameters where we do EEG, electroencephalogram, electrooculogram, electromyogram, and ECG as well, and some airflow, and respiratory efforts like thoracic and abdominal effort, and saturation, heart rate, and the level of snoring and body position. So we look into these parameters, we see the number of apnea, hypopnea happening, and we score them the sleep stages, and then we see whether it is REM predominant OSA or whether it is happening because of any other risk factors. We categorize them and give the diagnosis. So this sleep is an emerging field. So we have, as of 2016, we had data around 500 sleep labs, but the specific data is not available. Estimated in this 10 years of gap, it will be around 800 sleep labs. But only 15% of the sleep labs do level 1 sleep study, which is the gold standard. So most of them go for level 3 or level 4, where we can miss this mild OSA. So we have to improve this number of sleep labs and sleep technologies so we can easily pick up this mild OSA and improve the overall outcome of these patients. How do we diagnose? There are many factors. To be simple, we see the AHI. When it is less than 5, it is normal. It is 5 to 15 mild and 16 to 30 moderate, and more than 30 it is severe. How do we manage these patients? The single best mode of therapy is the CPAP, where most of the patients will do well with CPAP therapy, but few cases where they might require higher pressure, where they have other comorbidities like cardiovascular diseases, or they have OHS along with it, which is obesity hypoventilation syndrome, where land up in type 2 respiratory failure, we might use BiPAP. But most of the patients do well with CPAP therapy. And the next major hindrance in treating the patients is the acceptance. Because the very first question where patient asks after initiating therapy is that, how long do I use this CPAP machine? Because most of them think like it is an antibiotic which is being given for infection. They use it for 1 or 2 weeks or 1 month and stop it. And we have to give a proper counseling to the patient and closely follow up in the initial 1 or 2 weeks or in the 1 month time. So if the patient is using in the initial days, he will use it for long term. If he's not using in the initial 1 or 2 weeks, he will definitely miss out in using this therapy and will have a worse outcome and land up in ICU in type 2 respiratory failure. And how we can improve the acceptance is by tailoring the therapy with different types of masks and straps available. And thanks to the technology available, so we have different types of nasal pillows, nasal mask, full face mask, and we can tailor the therapy according to the patient's factors. And this is a state-of-art level 1 sleep lab, where this patient is a 36-year-old male patient who came 6 months back to our OPD and for a master health checkup where he was going abroad. We screened him for this OSA and suggested sleep study, but he did not turn up. After 6 months in abroad, he came back and along with his wife. His wife was the one who brought him to the OPD because in the 2 days of time after he's coming back from abroad, his wife could not sleep. Because this OSA can not only affect the person himself, he can affect other person who is sleeping beside also. That's the factor he came to hospital. And this is the report we give to the patient, where we have a comparison table which speaks by itself, where the patient without CPAP had an AHI of 74.1, And with CPAP, it increased to 0.7. So it speaks by itself, and it is very helpful for us to explain to the patient and how it is important to use this PAP therapy. And we also have this in-lab titration where we have round-the-clock sleep technicians doing this titration, and we optimize the pressures according to the HF values and the REM sleep, and we give the optimum pressure to the patient so they can show this report anywhere in the world and get the PAP therapy. To conclude, OSA is common, dangerous, but it is treatable. So if you come across any patients who is not under control with maximum medical management, you have to screen them for the OSA and treat them appropriately. Thank you.
It was a very good presentation, Satish. I'm very happy. It's my student.
Dr. D.P. Singh. Next talk on precision medicine in asthma care by Dr. D.P. Singh.
Good evening, everybody. This is the first time I visited the most prestigious institution, that is the Christian Medical College Fellow. I'm thankful to the organizer, especially my friend Dr. Palaniappan, Dr. A. Muruganathan sir, Dr. Rajshekhar, and other friends. The topic today is the precision medicine in asthma care. As you know that the precision medicine is also called personalized medicine or individualized medicine. And in the asthma, you know that a physician has to take the comprehensive examination, history taking, and then tailor the treatment according to the specific individualized features, that is called the phenotypes, rather than one treatment or one size fits to all. That is usually we do. Asthma, as you know, is a chronic respiratory disease. Over 300 million people suffer from it. And it is a reversible airway disease with dyspnea, with wheeze, tightness of chest, and cough. And the airway inflammation, that's a very this characteristic pathological hallmark. And leading to hyper responsiveness of the airway, increased mucus productions, and all contributing to the airway, variable airway obstruction. And combination of these features, because they are variable, so there are different clinical presentations, so there are different clinical phenotypes. And as you know that the pathophysiology has been very much understanding has gone down, and there are different clinical biomarkers we have in the form of IgE level, this FeNO test that we do, FeNO, and the sputum eosinophilia or peripheral eosinophilia, that usually, that's the old biomarkers, that usually even the asthma is called, people will say, I am suffering from eosinophilia. The concept of asthma now considered is a heterogeneous group. Some patients, usually the patients are the children's, adult may also suffer from it. There are certain occupations that can have the asthma. So this is a heterogeneous group, and the phenotypes underlie the need for personalized asthma therapy, because in contrast to the previous approach, treatment must be tailored to the individual patients. Dr. Hansky says that every man sitting in the hall is unique and non-recurrent creation in the history of human evolution. So every patient should be taken care of, individualized characteristics should be taken in the consideration before you start the treatment. And determination of the patient's asthma phenotypes is therefore essential, sometimes may be challenging, especially in the elderly people. And especially when you go for the pathophysiology, there are the two phenotypes, that is type 2 inflammation and type 2 low inflammation. And usually this type 2 high is very common, very characteristic, very classical, in which the allergens that stimulate this thymic stromal lymphopoietin, giving rise to NAV TH2 cells being activated and giving rise to these different interleukins. And that is the very important, you know, that in the targeted therapy, this biologicals, that is still anti-IL-5, anti-IL, this 4 or 13, 33. So there are different drugs has been discovered and giving rise to targeted therapy. And that is the way that we have to classify that asthma, whether it is type 2 high and type 2 low asthma, and in which this type 2, this interleukin 4, that is responsible for the antibody production and giving rise to allergic reactions, early this preform mediators release and other things. And especially this interleukin 5, that's very, very important because it activates the eosinophilic pathway. And eosinophils, that is set with the hallmark of this asthma. But in contrast, in the type 2 low type, that's the neutrophilic asthma, where the Th17 cells are activated by interleukin 33. Th1 cells are also activated. So in this group, in all these inflammation will give rise to hyperresponsiveness, remodeling, mucus production in smooth cells, especially this interleukin 13 giving rise to this goblet cells activity and this hyperresponsiveness. So Th2 high is especially more severe variety of asthma. Th2 low may be less severe, but because the inhaled corticosteroid is this mainstay in the treatment of asthma, type 2 high will be responsive in that, but not the type 2 low. So many cases of asthma, you will give the inhaled steroid, even to the optimal dose, patient will not respond. So we have to find out the phenotype, you have to find out these markers, and you have to treat according to that. And these are the 4 types of biomarkers that usually we find out in any case of asthma. Serum IgA level is measured, and we say the low, medium, and high. Blood eosinophils level, that's very common, that you usually know. Sputum eosinophilia, that is not given due respect, but we have to find out. Pheno is nowadays, every physicians or even this pulmonologist, they usually test this pheno test that it is done. Although it is not specific, but that will give that patients can have this eosinophilic asthma. So this is the approach of asthma phenotyping. It's the age of onset. Everybody knows that childhood asthma is very, very common, but there is late onset of asthma is also there. History of age, smoking, exposure of different allergens, BMI, infections triggers that you have to take in the history. How many exacerbations patients have, what is that clinical phenotypes in the patients. And so you just classify the asthma into type 2 asthma or non-type 2 asthma. And in that you find out whether it is allergic or late onset asthma, exercise-induced asthma, aspirin-induced asthma. And depending upon that, even in this type 2 asthma, you will have the responders to the inhaled steroids. You will find the late responsive to that. You can find out the refractory to ICS. But usually this type 2 low, that will be unresponsive or less responsive to that. Even this uncontrolled asthma, difficult to treat asthma, there are different terminology. In that there are a bit of difference. In that also severe asthma, which is uncontrolled despite adherence to maximum optimized therapy, and treatment is of the contributory factors, and even worsens when the high dose treatment is given. Withdrawn. This approach to asthma phenotypes, this allergic asthma is early onset, childhood symptoms, seasonal variation, elevated total IgE level, eosinophilia is present, increased FeNO, requires systemic allergen sensitization testing should be done. While obese type phenotype, that usually adult onset is there, non-eosinophilic, high medical usage, this pro-inflammatory diet, you know, that this fast foods and others, common comorbidity is very high, GERDs, OSA, and depressions. Fungal hypersensitivity is also there, exercise-induced bronchospasm, aspirin asthma. There are different phenotypes, especially this asthma COPD overlap syndrome is very, very common. 5 to 35% of the patients. So this one type of treatment, this having the good response, but if the patient has COPD, you may not have the response. So that phenotype directed, extrapolated asthma COPD regimen you have to give. Asthma again in the elderly will have certain problems. So whenever you get a case of, or even the GINA says, the GINA guidelines say the personalized treatment is very, that is the need of ours. You must assess, you must adjust, you must review. So any patients of asthma, because it is not a test that any test can say it is asthma. You have to find out the reversibility, variability, typical history of asthma. Then the symptoms also you have to assess whether the symptoms is the nocturnal awakening is there, how much symptoms on the most days of the week, or it is the awakening is just few days in a week. Whether the patient's getting the much more reliever therapy. You have to consider the inhaler techniques and adherence. That is very, very important. Whenever we teach our students that whenever you advise any patient's inhaler, must teach the technique. If you do not teach, don't advise. Because many patients in the rural area, they will go on inhalation therapy, even some capsules, oral capsules, that they will using the swallowing these capsules, this dry powder inhaler. So how it will be effective. So teaching, education of the patient is very, very important. The patient's preferences and goals should be important. And once the patient has got you have to adjust the dose. Everybody knows, everybody say high dose, this steroids you give. You must know what is the dose of high, just not only the 2 puffs 3 times a day. So doses should be modified. Non-pharmacological strategies should also be taken. Lifestyle modification, very, very important. We are talking, this is today the International Yoga Day. Yoga, role of yoga, exercise, fruits, foods, that you have to take care of. Asthma medication, especially the inhaled corticosteroids, that should be properly given in the adequate dosage. And even this reliever therapy, the salbutamol and other therapy, that is, nowadays we say that it may have side effects although. Even you have to review the exacerbation, side effects, lung function test, biomarkers, patient satisfactions also. So when the patient has got nowadays track 1 GINA guidelines that we should meter dose inhaler, that is MARD therapy that we use it, depending upon whether it is mild asthma, this moderate asthma and severe asthma, and that we see. And in this, when it is stage 5, all this biologicals you can use. But before using the biologicals, you must confirm that in the stage 4 to 5, must confirm the diagnosis of asthma. Always look for the poor, whether it is the poor device technique, poor adherence. Always see the comorbidity. The 70 to 80% of asthma patients can have this associated allergic rhinitis. Very, very common. Allergic rhinitis starting this asthma aggravation. Similarly, the sleep apnea, just we have listened the talk to the OSA. GERD, very common. You have to give this PPI in that cases. Triggers, you have to take history of the triggers. History of beta blockers. NSAID, that is allergic exposures. Tiotropium you can add in that. But you always, the weight loss is very, very important. Yearly influenza vaccine, pneumonia vaccines, this immunotherapies and other things that you have to do. If the patient does not respond, then you go for the phenotyping and the others, whether the patient is type 2 low, type 2 high, and depending upon that, you start using the biologicals. So biologicals for the management of the severe acute asthma and the factors governing the choice of it reduces the exacerbation, reduces the steroid dose, reduces the side effect, improves the quality of life, and it can prevent asthma for longer periods. So these are the different biologicals that we are using. Omalizumab, that is a very important drugs in which the IgE level is high. Majority of them, you can start from 6 years and older. This regelizumab, 18 years adult ages. Majority of them have these subcutaneous doses. One is intravenous also. So all these drugs have been proven that they are very effective. Dupilumab is a very wonderful drug, can be used in the eosinophilic phenotypes and oral steroid-dependent asthma. Dazepilumab is also very important. And this omalizumab, that reduces the exacerbation, reduces the hospitalization, and very, very good drug, especially in the patient. Mepolizumab is also very important drug, especially in the eosinophilic asthma. Regilizumab, another anti-IL monoclonal antibody, is also very good drug for the blood eosinophilia or so eosinophilic asthma. This drug should be given. And the targeting the IL-4 and 13, a new frontier in the severe asthma, role in asthma, dupilumab is again very wonderful drug in patients of severe asthma with blood eosinophilia. These are the two other drugs that is also good, and it is under the effects. Another IL-13 in the neutrophilic asthma, exploring the new frontiers. That is shortens this patient is response to that, but it is under the investigations. Non-pharmacological treatment, you always take care of the lifestyle modifications, GERDs and others. We have already talked about this. Thermoplastic can be used in this type 2 low asthma because it's a very good modality, non-drug, it's non-pharmacological treatment, uses heat to reduce the thickness of airway, smooth muscles in people. Indications 18 years and more, and those not responding to stage 4 and 5 in medication. Studies have shown that BT can improve asthma-related quality of life, reduces this exacerbation, reduces hospitalization. So my dear friends, future of asthma treatment is moving towards more personalized treatments, more precision therapy, more targeted therapy for better control and patients, even remission for some of the patients. Biologicals have revolutionized severe asthma care. You have to use it in the selected cases. Anti-IgE and anti-IgL and others biomarkers. Omalizumab, mepolizumab, and others biologicals are very good, and newer biologicals are also coming. Phenotypes and biomarker-based selection, eosinophil count, pheno, exacerbation history is central to tailor the asthma therapy in predicting biological responsiveness. Oral probiotics, some research suggests that modulating gut microbiota with probiotics could potentially play a role in managing asthma. More research is needed. Non-pharmacological treatment like BT may be an option in some of the patients, but this today is the day of precision therapy, selected therapy, personalized therapy, individual therapy. Thank you very much.
Thank you very much, sir, for unrevealing the newer aspects of this problem, a old problem. Thank you very much, sir. We have one more talk. Dr. Rajbir Singh is on the way. Meanwhile, we'll discuss the other topics with the other faculty. Dr. Rajshekhar, sir, I have a question.
Variant strain, we have to protect the old age people, especially associated comorbid illness also, COPD, asthma.
Dr. Rajshekhar, is there any case of histoplasmosis in non-resolving pneumonia you have encountered in your practice?
We have, after this COVID epidemic, a lot of mucormycosis we have seen, not with histoplasmosis I have not come across. And also this actually depends upon the laboratory support. That also very important. It is not that what you are doing by intervention, what the fluid you give or whatever that precious sample has to be looked into the proper laboratory, and then the result has to be proper. And it is a quality control lab. We have to select and we have to send the samples accordingly. Otherwise, and also most of the time the pulmonary medicine and any part of the investigation, the pathologist report is very valid. even a lymph node FNAC or a subcarinal node, in spite of very difficult, we are doing that. That report is very important. That is on the eye behind the microscope.
Thank you, sir. We have a question for Dr. Satish also. He said, you had said you can do an ultrasound and find out if it's a transudate and exudate. Is it quite sensitive that we don't have to do a pleural diagnostic type? Dr. Prince Pius, I'm sorry.
Ultrasound sensitivity is very high. However, we are clinicians, not radiologists. So I presume that most of the time we know the diagnosis because patient has a cardiac failure in history. And you know patient has come with effusion. Most likely this patient has cardiac failure related. But you have to prove it because he's in emergency and he has effusion and they are saying effusion, you do something. So ultrasound gives very specific diagnosis. It can diagnose that pulmonary edema also because it shows multiple B lines. So there are B lines, there is a history, that patient has cardiac failure, he has a pedal edema, JVP raised, and you did the ultrasound, found out B lines, you found effusion is there, but it's anechoic, it's everything fitting in one direction. In that case, no need to put any needle there. Just give the diuretic and wait for 2 days. Most likely, B lines will also decrease, effusion will also decrease, patient will be better. We have a diagnosis, we don't have to do much over there. So in that way, it saves a lot of interventions. In a sterile area, why to put a needle when you can fix a diagnosis without putting a needle?
Sir,
thank you, sir.
Your question.
Regarding the allergic asthma, do you find diethyl carbamazine citrate, will it be useful in eosinophilia? In those days, we used to give diethyl carbamazine for allergic asthma. That one question. Second question is, can you give Leukotriene, the Montelukast, can you give continuously up to how many months or how many weeks? The patients themselves are asking, sir, and the matra nalla kekkudu. They are telling. So, how long we can take the tablet, Montelukast? And regarding diethyl carbamazine, what is your advice? In our days, I think 40 years back, we used to give diethyl carbamazine whenever the patient is having allergic asthma, provided the eosinophils is within the normal count. Do you advise the patient, can I give diethyl carbamazine? It's old, right?
So whenever we say the patient say, are you getting asthma? The patient will say, no, I'm suffering from eosinophilia. Even if it is a correct diagnosed cases of bronchial asthma. So that name and this pathophysiology or whatever you can solve relationship of eosinophilia is very much there. But now as a pulmonologist, you are sure that tropical eosinophilia is different. And unless you say that it is a tropical eosinophilia, why you will use the diethyl carbamazine? Because the mainstay in the treatment of asthma, bronchial asthma is the inhaled steroids. If it is this allergic rhinitis is there, you can give these anti-allergics and other things. You can give the anti-allergic inhalers or steroid inhalers in that. But as such, if it is approved cases of bronchial asthma, why we should use diethyl carbamazine? Empirically, we can use no harm in that. So what is the drugs? Which drugs you are telling?
Heterazone. 100 milligram, 3 times.
Heterazone is a
for
DEC,
21
sir.
days we used
Heterazone
to
is
give.
diethyl carbamazine.
Usually it used to give filariasis, for filariasis.
Usually, earlier we used to give empirically used to give it, but nowadays we don't give it. No, sir.
So what about the Montelukast, sir? How long we can give, Montelukast?
How long?
That is Leukotriene. Montelukast.
Montelukast, usually we can give 3 months or so, but usually not for lifelong. We can't give this.
Okay.
But usually this anti-allergics, Montelukast, etc. But it is a drug that can be given. But usually whenever you give, even the steroids, when you say that if you are giving the steroids, patient is stabilized, monitor for 3 months. If the patient is stabilized for 3 months, then taper the dose. If the patient does not need it, after 3 months, you can taper the dose or omit the drugs.
In between, the Montelukast came into the news.
3 months is adequate time that we can give.
In between, Montelukast came into the news because of increased incidence of depression also with that.
Sure.
So, sir, there was an increased incidence of depression with Montelukast. So it came in the news and people started becoming scared of using it prolonged.
Should not be given prolonged time, yes.
This is a very practical question for Dr. Prince James. See, whenever we encounter a little above the normal value of eosinophilia, we test the absolute eosinophil count. If it is more than 400 or 440, whatever may be,
yes.
Suppose 700, we give diethyl carbamazine, but that doesn't decrease the count to the larger extent. Previously, we used to have a combination of diethyl carbamazine with a steroid, sorry to mention the name, unicorpazone port, which has worked well. What is the advice you give when you want to give, to reduce the AEC, absolute eosinophil count? Is it very important or little significant?
Age.
Absolute eosinophil count, more than 400.
Yes, we do give this diethyl carbamazine. We are using because we are in the tropical countries and we get a lot of cases. Many cases, whenever the eosinophil counts are high, we give diethyl carbamazine with steroids and the patient responds very well. With steroids, yes, of course.
One thing, sir, as the lecture sir has already presented, that eosinophils have a role in asthma, but tropical pulmonary eosinophilia is very different disease. So for that, diethyl carbamazepine is okay. But a patient comes with asthma, we don't have to chase eosinophils. So the 300 or 400 or 700, more important is the spirometry test, how much is the obstruction there. And nowadays we do pheno also. So pheno is a better marker of the eosinophilic inflammation. Blood has eosinophils, but how much it is going in the lung and causing inflammation, pheno will measure it. So depending on the pheno value, 50, 75, 100, how much it is, you can plan your inhaled corticosteroid therapy. As sir said, the primary treatment is inhaled corticosteroid. How much should be the dose? You can see the pheno help and see the FEV1 patient symptoms. We call it a scoring, ACT, and by that you determine. But primary treatment for asthma is inhaled corticosteroid only. There's no role for a diethyl carbamazepine at present. Last 10 years, I will say, by God's grace, these filariasis and other things have come down in country. We haven't written a prescription of DEC also in last 10 years because patient doesn't come at all nowadays. Maybe getting treated in the primary center. So that disease has come down. Asthma is going up. And primary treatment is do the spirometry at least, if possible, pheno, plan inhaled corticosteroid. That's the main treatment. But I totally agree with you that patient keeps seeing the blood report and keep chasing eosinophil count. I still have 16%, it didn't come down. More than eosinophil count, we say don't chase the eosinophil count. You look at the symptoms and see the spirometry, that should be normal. So lung function normal, patient symptoms are good, quality of life restored, that's the goal of therapy.
One more question, sir. Certain sections of magazines or research review says asthma, COPD, overlap syndrome. Is it still in use or has become obsolete?
What he says, the asthma, COPD, overlap.
Yes.
The recent GINA, that is removed. Yes. But the overlap is very, very high. I have shown you that 5 to 35% patients they have in the adults or in the age more than 40 years. So you get the patients of adult asthma, you can get the COPD, and that overlap is there. So that is a special phenotype, we can say, that we are talking about. This is the day of phenotype, not the overlap syndrome, but the name, what is in the name? Shakespeare says, roses are roses. It is the overlap. It is the combination. And so you have to think that whether it is asthma predominant or COPD predominant, so in that way you have to treat the patients.
So you meant to say that still asthma or COPD overlap is still in
Yes,
practice?
yes, of course. I have shown one of the slides that 5 to 35% patients has got overlap is there, but the name in the GINA is removed. There is no name in that. Earlier it says there is, the cheetah and tendua leopard, they're just like that. that overlap syndrome was very, very common. We have given so many lectures on that, but nowadays, no, that word is removed.
Sir, we'll call it, we'll finish that because the inaugural function is there, sir. If he comes, we can give the talk. So we can start giving the memento and all. Okay.
That will be better, sir.
Dr. Venkatraman, can you send the mementos?
The speaker to come to the dais for facilitation.
It is pleasure to honor the speakers. I request our Professor Kobarni Madam to felicitate our guest speaker, Dr. D.B. Singh from Bihar, with a memento. D.B. Singh. Certificate? Yes, yes, we are visiting. We are visiting. I request. Yes. Come, please, sir, come. Come. I request our organizing secretary, Dr. Satish Kumar, to hand over a memento to Dr. Professor Prince James. I request Dr. Venkatraman to hand over the memento to Dr. Satish Kumar, the pulmonologist from Narvi Hospital. CMC. Narvi Hospital. I request Dr. Manikandan sir to come to the stage to hand over a memento to our young, energetic pulmonologist from Erode, Dr. Rajshekhar. Very intelligent talk. Hearing aid. It's a time to honor our chairpersons, Professor Dr. Kobarni Madam and Dr. Satish Kumar with this. We'll wait for few minutes for arrival of Dr. R.B. Singh. He's coming. He's in Bagai.
We'll come up after that. We'll arrange the stage for us.
சார் சதீஷ் ஒரு நாள் நீங்கள் பண்ணிட்டு போயிடுங்க. நான் எவ்வளோ கட்டமா மணி 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 சார் பாலா இளங்கோ 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 வாங்க வாங்க இளங்கோ. We wholeheartedly welcome Professor Rajbir Singh, the senior pulmonologist of Main Apollo Hospital. Please come, sir, deliver the lecture on organizing pneumonias.
Thank you very much indeed. I apologize for coming late here for this session. I'm really grateful to the organizers of TAPICON for inviting me here to speak today on organizing pneumonia. It's always a great pleasure to be here at the Scudder Auditorium. Organizing pneumonia, of course, is a very important subject because it's not an uncommon condition we encounter in day-to-day practice. And what I'm going to do is, because I'm already late, I'm going to skip through a lot of slides and cut to the chase. So I think the speakers before me might have already introduced you to this subject of unresolving pneumonia, where the condition continues to produce a problem with hypoxia and other clinical symptoms. So we understand pneumonia as an abnormal response. So if you see, I don't know if there's a pointer, but anyway, it's an abnormal response which produces a lot of pathological changes which are characteristic, but it also produces non-specific changes radiologically and clinically. So the question is, do we always have to biopsy the lung in order to make a diagnosis of organizing pneumonia? And the answer we will get to a little later on. The normal stages of pneumonia I'm going to skip through, and the history we can skip through. The pathology, I think you're familiar with the Masson bodies, which are basically inflammatory cells and fibroblasts and collagen, which are laid down in air spaces, preventing aeration and oxygenation. And this produces the clinical features of a pneumonia, which continues even beyond infection. So these are the air cells in which you can see the arrows pointing towards the Masson bodies, which are buds, inflammatory buds, which are filling up the air spaces. Sometimes this will lead to fibrosis, which of course is irreversible, and most of these are non-specific injuries or triggers which bring about these changes in the lung. So these are the three things that you can see. The first one shows Masson bodies, and the second you can see collagen being laid down with fibroblast, and eventually fibrosis taking place. Now this is essentially what we try to prevent in clinical practice by the use of corticosteroids. In other words, even though there is infection, we are not worried about the infective agent multiplying and overwhelming us, but we are worried about the host response, our own immune mechanism, which is actually producing an exaggerated response and damaging our own lungs. And therefore, the main treatment will be aimed at suppressing this inflammation and preventing further damage and fibrosis. So there are different causes of a secondary organizing pneumonia, and as you can see, infection, ILD, inhalation, aspiration, and so on. Infection is very often characterized by a persistence of hypoxia and clinical symptoms beyond what you would consider the usual course of a pneumonia, which is usually about 2 weeks, but you will see that the person remains hypoxic and the X-ray and CT scan remain abnormal, and this is the time when we consider organizing pneumonia. Now, when there is no obvious cause, we call it cryptogenic. This is often due to things which we have not yet identified. It might be an unknown infection, it might be connective tissue disease which we have not identified yet, which will eventually become clear as we go on. And strangely, this organizing pneumonia is less common among smokers. There are very few respiratory diseases which are less likely to happen if you happen to be smoking. So that's quite strange. But anyway, there are also variants of organizing pneumonia which sometimes can present rather fulminantly and rapidly progressive, almost like an ARDS-like picture. Sometimes you get more fibrosis, like a fibrous COP, or a fibrinous organizing pneumonia, which is partly fibrous. So the causes of, possible causes of cryptogenic organizing pneumonia, as I've said earlier, it could also be refluxed from the gastroesophageal reflux, which can produce chronic respiratory disease, which is being increasingly recognized. The clinical features, I think, are basically like pneumonia, and the only thing is you may not find fever very commonly, and you don't find clubbing, and you do find that the lung function tests are abnormal, and hypoxia is often persistent. It's necessary to do certain investigation. The chest X-ray is often done because that's how we usually diagnose a pneumonia. And a CT chest does not have to be repeated, but it's very helpful in making the diagnosis early on. A lung function test is often abnormal earlier than when CT changes occur, and serial PFTs are often helpful in identifying whether the disease is improving or not. Oximetry is useful to find occult hypoxia, so a person has to be exercised and the oxygen saturation measured. Bronchoscopy is useful to exclude other causes. It's not particularly useful in identifying organizing pneumonia, but you can exclude infection, exclude eosinophilic pneumonia or alveolar hemorrhage, and sometimes it's possible to do a transbronchoscopic lung biopsy, but the specimen is often too small, and we need to do an open or a VATS lung biopsy to get a better specimen. And this is the CT scan, which shows that the pattern is often consolidation with ground glass opacities, often confined to the lower zones, the bases, and posteriorly. And it's this type of appearance suggests that this was likely to respond to steroids. But as the disease advances, you'll see more of fibrosis, and sometimes you can also see the reversed halo sign up there with the arrow. And these are all peculiarities of the organizing pneumonia pattern. And this kind of nodular appearance sometimes occurs in cryptogenic organizing pneumonia, and this is often difficult to recognize. This is not a typical picture of the CT scan, so we do have to biopsy this in order to make a diagnosis. And this does not actually respond to steroids that clearly. The treatment is obviously oral corticosteroids, and it's given for several months, at least for 2 months or 3 or 4 months. There's often a spontaneous remission, but we really don't have the luxury of waiting to see if that would happen. So most patients, almost all patients, will be started on oral corticosteroid. And even though the response is very, very characteristically good, it may produce relapses even while you're still continuing the steroid. So in such a case, you may have to revise your diagnosis. If the response is not good, or if it keeps recurring, you have to make the diagnosis more clearly. And sometimes you have to resort to other drugs like cyclophosphamide and other immunosuppressant drugs, or rituximab and macrolides. Bearing in mind that some of these drugs can actually produce lung damage themselves. Rituximab for example, can produce ARDS-like pictures sometimes. This is just an example of a 45-year-old lady who presented with very severe illness, very hypotensive and hypoxic, and she had a very bad X-ray, and despite antibiotics, she didn't really improve after several days, and therefore she had a PET scan done. And you might ask, why a PET scan? A PET scan is important when we are going to biopsy a part of the lung, and this often gives us a picture of which part of the lung we should really be biopsying, because you can clearly see here that where the arrow is pointing, there's a lot of metabolic activity, but there's also a lot of darker areas which suggest inactive necrotic areas, which if you did biopsy, it would not have given us a picture. So a PET scan is preferable when you're trying to biopsy. And after this, we did a bronchial wash, which is negative for malignancy and pathogens, and the CT-guided biopsy also showed only inflammation. The autoantibodies, because vasculitis is another thing that we have to consider here, that was also negative. So the patient was put on steroids, and she improved quite dramatically. Everything started to improve, the renal function, clinical situation, hypoxia, everything improved, and she got discharged within a few days. And a few weeks later, we followed her up as in the OP. She was remarkably well, and you can see the X-ray has cleared quite dramatically. There was another patient who had a similar picture with a PET scan showing similar features, but in this case, a bronchoscopy showed actually an obstruction, which looked initially like a tumor. In the lower picture, you can see that. So we biopsied that, and that turned out to be an inflammatory lesion. So I next thought of a foreign body. So we posted him for a rigid bronchoscopy to remove all the debris and the foreign body. But on the day of the procedure, he coughed out a peanut. So after that, he improved quite clearly. One of the concerns we have is, should we be giving steroids in what could potentially be an infection which can spread and overwhelm us potentially? So the answer to that is that most of these conditions of infection, we need not worry about giving steroids concurrently. So here there are some studies which have looked at the use of steroids while the patient is still having an acute pneumonia. We, of course, are aware of the fact that there is immunosuppression, and the person who's chronically on steroid is more likely to develop infections like TB and fungus and so on. But when you're actually having an acute, severe community-acquired pneumonia, actually steroids are indicated. So these studies have shown that in community-acquired pneumonia, it is important to give steroids in severe pneumonia, perhaps not in milder pneumonia, and certain conditions of sepsis and ARDS also it can be useful. So in summarizing, the organizing pneumonia is an abnormal response, an inflammatory response of the lung parenchyma. It is non-specific, clinical and radiological, but the pathology is fairly specific. But usually we don't do a biopsy. Occasionally it becomes necessary. Steroids usually helpful, and sometimes we may have to give a trial when the diagnosis is unclear. Bronchoscopy and other investigations are often helpful to exclude other conditions. And if the person is not responding to steroid, think of some other diagnosis and start initiating investigations for that. With that, I come to an end, and thank you very much for listening, and thank you for waiting to listen to this talk. Thank you very much indeed. Yeah, you can.
That is the cutting edge of the professor's talk. I am very happy. Professor is always smilingly associated with us. Now we call upon our chairman of the Tamil Nadu State Branch of Association Physicians of India to felicitate. I request all the speakers from Pulmonary arena, please come to the stage, including Dr. Prince James and Rajsekhar, and if somebody is there. Satish is there? Okay, please come. I request Professor Bharani Madam, Dr. Anita, we let us celebrate our the final speaker. Please come, sir. Please come. I request Dr. Sukumarji to garland our. Please. Yes, yes. Illana, solve. I request Professor Prince James to felicitate the speaker. In this famous Scudder Auditorium, we started with the young and energetic Dr. G. Elangovan of Kadalur, And we end with Dr. Professor Dr. Rajbir Singh, sir. Thank you very much. Thank you very much.
சார் அது அப்படியே எழுதணும் சார். நடுவில் சும்மா வச்சிடலாம் சார். இது கவர் மாட்டேன்.
You gotta put your pants behind you. Things happen. You can't tell you anything about that. When the world turns its back on you, you turn your back on them. That's not personal. You need to listen. We have to make Hakuna Matata. Hakuna Matata. Ready for some drinks? Stay into the fire. I'd love to see your answer. We should probably, when the sun goes down and time slows down, it's too crazy if we decide to stay forever. Decide to stay Feedbacks and leakage providing skin irritation. Comfortable outcome ஆரி acting பண்ணணும்ல. இப்ப acting என்னா போதும். Stay free set or excel இருக்குல்ல.
Check. Check, check. A very good evening, one and all. A very good evening, one and all. Distinguished guests, faculty, students, and friends. It is with immense pleasure that we gather here today for the TAPICON inaugural ceremony. And it's my pleasure and honor to invite the dignitaries to the dais. May I invite our APA Tamil Nadu State Chapter Chairman, Dr. N. Balamurugan sir, to the dais. APA Tamil Nadu State Chapter Secretary, Dr. M. Gunasegaran sir, to the dais. May I request our APA Tamil Nadu State Chapter Secretary, Dr. Gunasegaran sir, to adorn the collar to APA Tamil Nadu State Chapter Chairman, Dr. N. Balamurugan sir.
May I invite the chief guest for the evening, Dr. Jyotirmoy Paul sir, APA National President, to the stage. May I request a former health secretary and present chairman and managing director of Tamil Nadu EB, Mr. J. Radhakrishnan sir, onto the stage. May I request Dr. Satish Solomon, the Vice Principal of CMC Vellore, onto the stage.
I request APA Tamil Nadu State Chapter Academic Committee Chairman, Dr. V. Palaniyappan, to the stage. And I request TAPICON Scientific Committee Chairman, Dr. N. Vertigo sir, to the stage. I invite TAPICON Organizing Secretary, Dr. K. Satish Kumar, to the stage. Now, let us all stand for double bow. Please be seated. I invite our Scientific Committee Chairman of TAPICON, Dr. N. Vertigo sir, to deliver the welcome address.
Good evening and warm welcome to one and all present here. It is with great pride and immense pleasure that we welcome you to TAPICON 2025, 21st Annual Conference of the Tamil Nadu State Association of Physicians of India, hosted by the Association of Physicians of India, Vellore branch. This year, we gather at the historic Scudder Auditorium, Christian Medical College, Bahayam campus, Vellore, where tradition meets innovation in the art of academic excellence. We are honored by the presence of our distinguished dignitaries, senior physicians, guest speakers, chairpersons, delegates, enthusiastic postgraduates whose commitment to internal medicine on ongoing learning continues to inspire us all. In this occasion, we feel immensely pleasure to welcome our Association Physicians of India, Tamil Nadu State Chapter Chairman, Dr. N. Balamurugan sir, and API TNSC Secretary, Dr. M. Gunasegaran sir. API Tamil Nadu State Secretary should adorn the dollar which the function took place. I invite immensely the chief guest, our President of Associations of Physicians of India, Dr. Joydirmar Paul, to this occasion with folded hands. I invite the guest of honor, Dr. Radhakrishnan, the former Health Secretary and the present Chairman and Managing Director of Tamil Nadu State Electricity Board. And I invite with gratitude and pleasure the Vice Principal of CMC Bahayam, Dr. Satish Solomon, Vice President of CMC Vellore. And we invite with pleasure our API Tamil Nadu State Branch Academic Committee Chairperson, Dr. V. Palaniyappan. And I welcome with folded hands the eminent Organizing Secretary, Dr. K. Satish Kumar. TAPICON 2025 is more than just a conference. It is a celebration of collaboration, knowledge sharing, and the collective spirit of medical professionals. This year, we are proud to host over 180 other states and regional speakers, chairpersons, and guest faculty, 130 scientific paper presentations, 430 posters presentations, showing case, original research, and case studies, and participation of from 160 plus delegates, over 500 postgraduate students from across the Tamil Nadu. Over these days, we look forward to thought-provoking sessions, cutting-edge updates, and meaningful dialogue that will elevate patient care to the clinical practice across our state. On behalf of the organizing committee, I extend our heartfelt gratitude to each one of you present here, my fellow colleagues and others, ladies and gentlemen. Your presence and support is the strength of us. Let this conference be a platform not just academic enrichment, but also nowadays new ideas, friendships, and inspiration. Once again, we welcome you with all spirit and innovation together to this enriching conference, TAPICON 2025. Let us join together, make this memorable event, impactful event. Thank you once again to all.
Thank you, sir. Now I welcome our organizing chairman, Dr. Sukumar sir, onto the stage. Now I request our API Tamil Nadu State Chapter Chairman, Dr. Balamurugan sir, to address the gathering.
Good evening, respected colleagues, friends, my dear students and mentors. My special thanks to President, National APA, Dr. Jyotirmay Paul, and our special guest, the People's Collector, Dr. Radhakrishnan sir, and all the senior members on the dais of the dais. It's both a privilege and a responsibility for me to stand before you as a chairman of Tamil Nadu Association of Physicians of India. As physicians, we are united by a single calling: to listen, to learn, to heal, above all, to serve. Last few years, we had troubles both in scientifically, socially, some ethically also. Yet, though we had tough times, we had seen something constant in this community: the integrity, compassion, and resilience. It reminds me that medicine is not our profession, it's our way of life. Moreover, it's our moral commitment. As we move forward, our goals must be clear: to uphold evidence-based medicine, at the same time to support experience-based stories, anecdotes, and innovations, to advocate for patient care, physicians' well-being, and healthcare policies too, to mentor the next generation because they are or they will be our own physicians, as we were once mentored. Let us not forget that behind every clinical decision, there lies a human story. Behind every case file, there lies a life. And behind every white coat, there lies a beating heart 24/7 into 365 days, not for money, not for fame, just for saving other life, just for passion. At the same time, I thank each one and of you for the responsibility given to me and for your dedication, for your exemplary example and your trust. Let's move ahead stronger, wiser, and together. Thank you.
Thank you very much, sir. Now I request our APA Tamil Nadu State Chapter Secretary, Dr. Gunashekaran, to address the gathering.
Respected National President, Association of Physicians of India, Dr. Jodhim Maipal sir, our former Health Secretary, Additional Chief Secretary, Chairman and Managing Director of Tamil Nadu Electricity Board, Mr. Dr. Radhakrishnan sir, other dignitaries on the dais as well as off the dais, and postgraduate students. As a honorary secretary of APA, it is my pleasure to appreciate this exciting event of TAPICON 2025 organized by Vellore City Branch. As a team, they have executed in a fantastic way with more than 150 speakers and 300 chairpersons and more than 1,000 delegates. The organizing chairman, Dr. Sukumar sir, even though a senior, but for this conference, he acted like a very young boy and coordinated in a beautiful way. The scientific committee chairman and my brother Vertigo sir meticulously chosen the topic till the day before the conference for the benefit of delegates. As an organizing secretary, Dr. Sadiq sir is a very humble person, and our convener chairman, Dr. Anida, took all the efforts in odd times, coordinate with all the postgraduate students and all the college professors, and conduct the TAPICON gold medal exam as well as poster and paper presentation in a fantastic way. I would like to take a moment to express my deepest gratitude to our national president, Dr. Jodhim Maipal sir, for the tireless efforts as well as visionary leadership in Association of Physicians of India. Under our president guidance, our APA has made significant strides growth in membership drive, postgraduate CME, and the first president who is wonderfully coordinated with all the state secretaries. I am inspired by the president's passion for the initiative and commitment to advance the APA into the new heights. Thank you, one and all.
Okay. Now we have the installation and the introduction of the APA TNSA Chairman-elect 2025 to 2026 proceedings to happen.
This is the first time the APA chairman going to installed in a fantastic way. Our Tamil Nadu APA chairman 2025-2026 was born in Madurai city, and he has completed MBBS from Madurai Medical College in 1987 and MD from Madurai Medical College in 1991. And he is in government service for 35 years with more than 25 years of teaching experience. He was the Dean of Kanyakumari, Dean of Salem Mohan Kumaramangalam, Dean of Government Theni Medical College, and Dean of Tanjavur Medical College. And he was the Director of Medical Education and retired. Currently, he is the Professor of Medicine, Chettinad Hospital and Research Institute, Chennai. He is our EC member, and he was Organizing Secretary of TAPICON 2019 and Governing Council member of IMA, Life member of Hypertension Society, Indian Academy of Geriatrics. He was the undergraduate as well as postgraduate Tamil Nadu Dr. MGR Medical University examiner, as well as JIPMER Pondicherry University and Vinayaka Mission Bharat University examiner. And he received Tamil Nadu Medical Council Best Doctor Award in 2021 and District Collector Award from 2018 to 25, and Best Performance State Government Awards for Organ Transplantation Program consecutively 3 years for 2023, 2024, and 2025. And he contributed to APA textbook of medicine, poisoning, and snakebite, and national journals, and orator in TAPICON 2023, a man who brought smiles to patient. மதுரையிலேயே பிறந்து மதுரையிலேயே வளர்ந்து மதுரை மருத்துவக் கல்லூரியில் இளநிலை முதுநிலை பயின்று மதுரை மருத்துவக் கல்லூரியிலேயே உதவி பேராசிரியர், துணை பேராசிரியர், பேராசிரியர் என்று இருந்து மதுரைக்காரனாக இருந்தாலும் அந்த புன்முகத்தோடு அனைவரையும் அந்த ஸ்மைலி கான்செப்டோடு வரவேற்கும் எங்கள் சேர்மன் 2025-2026 டாக்டர் பாலாஜிநாதன் அவர்களை மேடை கலைக்கிறோம். Now, I request Dr. Palamurugan, the current chairman, by adorning the collar to the new incoming chairman and become the past chairman. May I request our national president to be the incoming chairman. Thank you.
May I invite Dr. Radhakrishnan, sir, former Health Secretary, Chairman and Managing Director, TNEB, to address the gathering.
அனைவருக்கும் வணக்கம். A very good evening to everybody. First of all, I thank the entire team here because I have gate crashed here. I am here more as a parent, but I have very, very pleasant memories about all of you because of my very prolonged tenure of almost a decade with all of you. So first I will start by addressing our chief guest, Dr. Jyotirmay Paul, National President of Association of Physicians of India. He's done remarkable work all over India, and of course he's leading it in a very tough state which faced a lot of challenges, and the way they have brought it up. So it's a privilege that Tamil Nadu Association is having him as the rightfully as the chief guest. So we welcome you on behalf of State of Tamil Nadu. Then of course our Dr. N. Balmurugan, who who just now handed over his charge after doing an excellent work to Dr. Balaji Nathan, who is again an equally known person who has dedicated his life to this. Then of course a team of others, whether it is Gunashekharan and my all are my friends and known people, Dr. V. Payaniappan, Dr. Adaga Venkateshan, Dr. Senthil Velu, Gopalakrishnan, Dr. Subramanyam, Appa Raj, Rajavel Murugan, all of them, Dr. Ashraf, all of them who are in front. If I take back, it looks as if I am back as the health secretary with all of you. Then my own dear mother-in-law is there. Her husband, late Dr. V. Nagarajan, was a very active member of this Association of Physicians. And of course, young students are there. And most importantly, our vice principal from CMC Vellore is there. And again, our colleague, I think West Bengal Health Secretary's brother, he is also here. And I just now wished your friend also there. So it's a great honor to address you all in this conference. Most importantly, it is being done in a very, very historic and healing grounds of CMC Vellore. Why I am saying that, Tamil Nadu boasts of the largest number of government medical colleges, one of the largest number of deemed universities, but you as medical professionals have really contributed a lot, and physicians in particular, have really taken the treatment to a very, very different level by facing, beyond textbooks. That is where you have all taken it, and very, very happy that it is being done in academy. You are going to look at the clinical advancement, collaborations, and excellence in whatever you do. So I am actually, I would like to gratefully acknowledge the leadership of the office bearers of API Tamil Nadu State Chapter, whose dedication and teamwork has made this possible. And I am not associated just now as a gatecrasher, but from 2012 I have been observing. Earlier, Dr. Muruganathan used to be there, Tirupur conference, or for that matter, Nagapatnam, where I addressed during through video conference, and the collector there, who was again a doctor and now looking after NHM, Dr. Arun Tambaraj. We have all had very pleasant experience. I will not go beyond because it's an inaugural function, but I will just touch upon certain things. First, our gratitude to physicians. I started in the height of dengue, I was appointed, and I could see as how you transformed from a time where deaths used to happen off and on, and people used to look at only platelets. Physicians came and told, please don't look at hematocrit, look at hemoconcentration, hemodilution at the time of recovery. I was permanent. I always feel I was like an eternal CRRI. Because I always used to see and how they saved lives, whether it is Rajabalan. I have seen Kanmunadi, Ninga Uira Kapathirkenga, and you arrived at a protocol which resulted in dengue being there, but live deaths came down drastically. Same way, swine flu, though we tend to say that the pandemic was in 2009, we had challenges in 2012, we had challenges in 2015, we had challenges in 2017. I have come to Vellore during that time where, every other, all over India, people come, even Bangladesh, they come, and suddenly there will be challenge. That again, you created a protocol. So as physicians, you have always raised the bar. So this is where I think you have all got your duties, and every time, and I think the President will himself say, the kind of work which they did in West Bengal, and you all did when I was brought back during COVID. I can just say thanks. Everybody asks me that, who actually did it. I always tell, I always say, we relied. COVID was a standing example where bureaucracy or political leadership had to rely on medical expertise. எப்போவுமே நீங்கள் பாருங்க, நான் பேட்டி கொடுத்துருப்பேன்னு சொல்லுவாங்க, ஆனால் எப்போவுமே மருத்துவ வல்லுநர்களின் கருத்தின் அடிப்படையில் நான் சொல்கிறேன். I as an individual cannot have a view. So you as doctors found ways and means to bring it back, whether it is vaccination, whether it is. So now what is it that we are looking at? You still have challenges. Biggest challenge which we have is, I would bluntly tell, the biggest challenge doctors you are facing. If you look at demography, the average lifespan of a doctor is, if I am correct, much lower than common people. You are saving everybody but neglecting yourself. So that I will personally feel that we should be, and same thing is happening with jobs. Everybody is stressed. So other nama ellarma we'll have to tackle, create a system where from the student days to the daily working days. You look at the challenge the doctor has. No, he has no time. Every time at midnight somebody calls, he cannot say no, whether it is senior doctor, junior doctor, or anybody. So these two things would be there. Next would be going beyond evidence-based thing. A thing has come where we have to look at something beyond. Because I have seen people, they not only look, feel that you are the gods. Because God, you can just pray. But when somebody, I have seen in cancer treatment and all, stage 4, but I used to interact. Shanta madam, I'll go and sit for some time with her and all. Stage 4 patient kuda ungala nambranga. That naanga vandruvom, ana ninga avangale. Now that stage 4 system, stage 3 has changed. You have got to know specific medicines for many cancers. So you have been continuously raising the bar. That is what you have to do. Second is ensure that that equity is there. We always say that no, utopian, ellame universal healthcare. It's utopian. But that utopian goal, at least you can make it achievable. From government side, my experience is on insurance, we have to come down. Everybody is talking about insurance, but it is limited. Many times, many physicians' cases do not get covered. Health is health. It cannot be only surgical, has to be covered in insurance. So we all should work together. As TAPICON, you should come up with recommendations. I'm sure I've got a very good colleague there, Dr. Sendil now. And of course, present health minister or past health minister, and for that matter, government. Even yesterday, I had a very big national meeting on Viksit Bharat 2047, where we are talking about cell and gene therapy, personalized therapy. The next meeting, we are going to chair and bring more experts. So sky is the limit for physicians. People believe you. Today, if Tamil Nadu is viewed or India is viewed for the growth, it is courtesy people like you. How now, actually, na kadasila sila controversial solittu poren. Cardiothoracic surgery ki we are not getting people. Because entire thing cardiology has taken over, intervention cardiology. So physician, if I go to, I recently also, my mother-in-law had a calcaneal fracture, so I was spending some time. And I'm again telling you, we go to government setup, not that we don't believe private setup. I end by telling, please, if you have time, please go through the experiential center at the entrance of CMC Vellore. You can see how those times they have developed it. I've seen the doctors from Vellore even in Meghalaya. Similarly, our doctors, we all should work together, and this is one area teamwork succeeds. Multi-purpose health worker, sanitary worker, nurse, pharmacist, lab technician, specialist, student. Anybody works, we all could do something in my decadal experience with you, because we all work like a team. I once again thank that, finally I thank that you are encouraging, uniquely I saw that you are encouraging young talent to compete all over Tamil Nadu and showcase their talent. Even those who have got award or they have not got medal, they got an experience to see clinical cases. With these few words, your role is to guide youngsters also. இப்போ நான் யங்கர் எலிமெண்ட்டை பார்க்குறேன், பெயின் கிளினிக் போக மாட்டாங்க, நாங்கள் இருக்கும்போது ஊசி போட மாட்டேன்னு சொல்கிறாங்க. நீங்கள்லாம் சீனியர்ஸ், பாலாஜிநாதன், நீங்கள் எல்லாம் இங்கே இருக்கீங்க. ஆல் ஹீஸ் such a senior person from West Bengal. You all need to do. From our end, doctors should be protected, that they should not face any harassment. Though we passed an act in 1998, Government of India is coming with thing. These are all areas we should work together. I'm again grateful and thankful to all of you that even as a parent, when I came, you have acknowledged my presence. But hats off to all of you, all the new office bearers and the present office bearers who have taken this. Association of Physicians has never stopped or left. Whenever the crisis is there, they have been in the forefront. It is my personal example. I thank everyone. I wish all of them all the best. And of course, I wish CMC also. They have done exceedingly well. I was very actively involved in your new campus construction. You please have a look at the new campus if you get time. Let us share experiences, government, private, ellarum share pannikanga. And ultimately, from prevention, let us go to wellness, and let us ensure that people are made aware of the risks they have. Thank you.
Thank you very much, sir, for your inspiring and encouraging words. Now I request Dr. Satish Solomon, Vice Principal of CMC, to address the gathering.
Good evening, everyone. Distinguished guests, members on the dais, esteemed faculty, my colleagues from CMC, and all dear participants. It is my great honor and privilege to stand here on behalf of CMC to welcome you all to this Vellore chapter of TAPICON 2025. This conference, we believe, is not just a conference, but it's going to be a celebration of collaboration of work that you've done, sharing of experiences, presenting your work, and learning from each other, ultimately to improve patient outcome, and not just in India, but around the world to improve the quality of healthcare. I would also like to extend my gratitude to all the speakers who have agreed to be here, the panelists who have worked through the conference, and all the organizers who have worked tirelessly to put up this conference into a great success. To all the participants and the delegates, again, we are delighted to welcome you all to CMC Vellore, and we hope this conference will not just be an experience to come here, but you will take away ideas, insights, and make multiple connections to develop your work in the future. With no further ado, on behalf of CMC fraternity, I once again welcome you all. We wish you the very best, and the third day of the conference be productive as the first 2 days. Thank you. Welcome again to CMC.
Thank you, sir. May I invite Dr. Jyotir Maipal, API National President, to deliver his speech.
Dr. Balaji, State Chairman, API Tamil Nadu Branch. Dr. Gunoshekaran, Secretary, API Tamil Nadu Chapter. Dr. N. Balamurugan, my very good friend, neurologist, great academician, immediate past chairman. Dr. Radhakrishnan, Additional Chief Secretary, Electricity Board. Dr. Mr. Vice Chancellor, Sir. Dr. Palaniappan, my friend and Vice President of API Central, and the Vellore Branch API Secretary, Chairman, and all the dignitaries of the dais, delegates, students, ladies and gentlemen. It is really my pleasure to be present in inaugural session of TAPICON. For last 7 to 8 years, I constantly coming in the annual conference, also in midterm program. The uniqueness of the program of Tamil Nadu is huge presence of the students. That I have seen nowhere. And also the webinar, if I get times, Dr. Palaniappan from the COVID time, seriously and meticulously and regularly he is conducting the master class. And whenever I get time, I join. And there is a huge attendance of the students. Even in Bengal, my colleagues are there. I told the huge presence of teachers in the program. Because it is not that I am teachers, I know everything. A teacher also should be a student. I am not expert on everything. But in Tamil Nadu program, I really seen the teachers also attend the program. They ask question. They participate in the program. This is very uniqueness and very much student-friendly program, the master class, what I am experiencing last 4 to 5 years. So I am very and really happy and congratulate. I always say Tamil Nadu State Chapter is an example in academics in the API, and other states also should follow. We do the annual conference, and also another, I know many of you, whether you know or don't, I don't know, this is the birthplace of API is Chennai. In 1944, in an annual conference of Indian Medical Association, in month of November, Dr. Jibraj Mehta, along with other 8 founder member, and he declared that API will be a body, there is no conflict with the IMA, and this body will work for academics, medical education, publication, and research. Who for the last 80 years, API is doing great job for the academics, publications. I will not say so much for the research. We are, India is ahead in all aspects, from technology, defense technology, IT technology, vaccinology, so many aspects, but not so good in medical research. So I'll come later on this aspect, what is our association's duty. So first I say why we do the conference, we assess or evaluate what we have done in the previous years and how we plan for the future activities. So in my journey in the API for 20 years, what I have experienced that our organization's duty have a great role in academics because now India there is a mushrooming of the medical colleges and there is a scarcity of teachers. Many of the district colleges teachers are very less, maybe 3-4. Also teachers don't stay 5 days or 6 days in a week. So students really suffers from the academics. So during COVID, we learned the online system. So API should come forward, organizations, different state, city bodies to fill up the gaps. Because in a college, district college, maybe in the far district college, maybe 200 kilometers away from the capital city, may not have so much expertise, may not have cardiologists, neurologists, nephrologists, but organization has the all specialists. So from the organization, if we can supplement the deficit of the students, those who are studying in the district periphery medical colleges, this will be the great help for the nation because students are our future. So if they are trained in better way, they will serve the mankind in the better way. And that is the motto of the government, that is the motto of our organization. Same motto. We are working in the same pathway. Our duty is to serve nation. Anyway, through academics, through research, through publication, whatever may be the modality. If doctors are trained well, they will train the mankind better. That is the goal. That is goal of everybody's. So for the CME organization, we are doing almost every state. Huge organization CME conference are doing. But my humble request to all scientific secretaries of all the state, be very meticulous when you are planning the scientific program. There should be a balance between the clinical approach and the update. Because in our country, 144 population, even till now 40% people are not so poor, cannot afford so much updated medical facilities. So clinic-based system can only give or train the doctor to treat in a more rational way and people spending the low cost, less money, can get the best medical facilities. So clinics should be the heart of our medical education. So when you are formulating the CME program, be very cautious so that some on the clinical part and some of the update, there should be a good balance. And also remember that there should not be no less external influence. Your program will be based only on scientific, based on your guideline. External influence should be minimized. Regarding research, I told that this is the area we should focus. Not only the government definitely has focus, government have a resource, government have a capacity, but association has a less capacity, but we have also some duty. Because what guideline we are making in India or on behalf of association, this is based on the Western guideline. That may not be appropriate in the Indian scenario. So because we have no data, we doctors are not habituated to do the research work to keep your data. So we are basically depend on the Western countries. But research, if you think today, we cannot change the research scenario tomorrow. If we think today, work sincerely, it will take 50 years. But you have to start today. So our organization have a less money. We have not so much money like government. We cannot do so much research work, but at least we should infiltrate the idea of research among the next generation. So you do the repeated course of research methodology. That is most important. Scientific chairman of every state should do the research methodology course among the doctors, physicians, particularly the younger generation, so that we can keep data properly. That will be helpful to publish the article, publish the journal and to formulate so that maybe in 20 years we can do our guideline on your own. I know you have a grievance that you are not getting JAPI, our publication, regularly, and also if you submit the article, it may take 2 years to publish. I know the grievance. Last few months, I know you have not received the JAPI. That was one technical problem, some issue with our postal system vendor. So that issue has been sorted out. From July, again, JAPI will be posted and you will get the JAPI. And one grievance definitely, if you do the good work, if it is not published, there is no gain. So that is why we are very soon from this year, along with JAPI, we are going to launch another issue, that is the case report section of the API, like the BMJ Annals of Internal Medicine. Because India original research till now not of that quality, but India is a treasure of the cases. So much good cases, variety of cases, I don't think is there anywhere in the world. So our dedicated case report journal will be there. So your best cases that you experience, you treat in your practice life, you can publish there. And I am sure in the each section we will take at least 20 to 25 cases. So that if you submit the article, particularly the case report, it will our target is to at least to publish by 6 months, next 6 months. So the younger generation will be boosted to write the case report and to publish in our API journals. So another aspect I want to highlight, that nothing, whatever we are doing, we are learning, we are doing, it is for the mankind, I told in the beginning. So association, though on the BART, Jibraj Mehta told our three motto, one is the academics, one is the publication, one is the research. But at this present, doctor-patient relation is very important. So that is why association have to do some work that directly touches the people. We are doing academics, we are treating the patient, that is okay. But direct, when the people is in distress, we should do that. That is why being the president, I have given due stress on the health awareness program. There are the different health days, maybe asthma day, maybe hypertension day, diabetes day. On the particular that day, you go directly to the people. Prevention is better there. This preventive aspect is basically neglected in India in our medical education. So all of you, I request all organizations should concentrate, do some active work, do spend some of the whatever was surplus money, spend for the people, do some public awareness program, be in touch with the people. Then only the organization will be accepted by the people. So whatever maybe the criticism have against our organization, we can remove. And our doctor, very important, doctor-patient relation. Unless patient has a confidence on you, you cannot give the best treatment. So with these few words, I hope all of you are learned member and you are working excellently for the organization. You strengthen your city and state branch. I do not feel that being a president, I will take the decision and you will implement. I feel, in my experience, if the grassroots level, you have more experience than me, but you are working in the city branch, you have more experience. So you convey your decision, your message, your wishes, your grievance. Our duty only to implement. So central, state, city branch, if work together, the glory of the API, what the Jibraj Mehta that has a dream will be fulfilled. I hope all of you will give the cooperation what you have given in last 8 years. And with this small prayer, I best wishes to all of you. Thank you. Jai Hind, Jai API.
Thank you so much, sir. May I invite API TNSC Secretary to announce the prize winners.
Before going to the prize winner, the winners of our heart. So I invite the organizing committee, all the members to come to the stage. Let's give a standing ovation for the excellent work they have done for the hospitality and the academic feast. The organizing committee, please to the stage. Let's give a standing ovation. Please. The API, Vellore, and the organizing committee, please to the stage. என்னன்றி கொண்டார்க்கும் உயுண்டாம் உயில்லை செய்நன்றி கொண்ட மகற்கு.
As our national president said, city branches are the pillars for state, and state branches are the pillars for central. So APA Tamil Nadu State Chapter recognized the city branches for the Best Branch Award. Once our national president assumed the office, he communicated with all secretaries to do public health activities and do reach the public by APA. That is the aim of our national president. So the city branch awards are based on not only CME, medicine update programs for the postgraduate, as well as community health activities. Based on this, the best city chapter runner award goes to Tirunelveli city branch. And the winner is 16 monthly CME programs and 1 endowment lectures with 1 annual medicine update with more than 200 postgraduates and renovation of student class at Mahatma Gandhi Medical College for around 5 lakhs and contribution to IMA Hall Trichy about 5 lakhs and donation to Sweet Registry for free insulin to type 2 diabetes about 1.5 lakhs. So APA Tamil Nadu State Chapter, the winner award goes to Tiruchirappalli City Branch. Next award, TAPICON Gold Medal for Clinical Excellence. More than 52 medical colleges participated and the preliminary round selected based on the MCQ type and clinical examination conducted in 10 zones and 2 students from each zone selected for the Tamil Nadu APA Gold Medal Clinical Excellence Examination. And all the students are like getting gold medal because they have done excellently in the zonal level examinations. I have given not as a prize, first prize, second prize, it is only position. It is your position in the gold medal examination. The 10th position goes to Harini from SRM Medical College. Someone from SRM Medical College may come and take. 10th place. 9th position goes to Sivaprakash of Government Kilpak Medical College. And 8th position goes to Sagida of Sri Venkateswara Medical College. Sagida. And 7th prize goes to Aruneshwar of Tirunelveli Medical College. Aruneshwar. No. And sixth position, Joseph Liaskar from Christian Medical College, Vellore. And fifth position, Veera Sivabalan from Government Stanley Medical College. And fourth position, Dr. Mohalapu Sai Samhida of Madras Medical College. And third position goes to Yamuna from Coimbatore Medical College. And second position shared by two persons with only 0.5 mark difference. That is 76 as well as 76.5. Only 0.5 mark difference. I don't know the examiner who put 0.5 marks. And second position shared by Dr. Aravind Radhakrishnan from Chettinad Hospital and Research Institute. Another second position, Dr. Thirumalai from Government Vellore Medical College. And first position goes to Prakash Raj from Government Mohan Kumar Mangalam Medical College. And gold medal for poster as well as paper presentations. And API Tamil Nadu chapter has 19 gold medals. All the gold medals are contributed. Remaining students, please come to the stage very fast. Dr. Prai Sudan. Dr. Prai Sudan, Government KAPV Medical College. Dr. Raman Kumar, Government Thiruvarur Medical College. Raman Kumar. And Dr. Kanjan Vasa Satyendra. Dr. Modi Sri from Centrifugal Medical College. Dr. C. Kamalakannan from Centrifugal Medical College. Angelian, please. Dr. Abbas from Meenakshi Mission Hospital and Research Center. Dr. Meka from Melburutur Adiparasakti Medical College. Dr. Meka, Melburutur. Dr. Yogida Balamurugan from Savida Medical College. Dr. Gaudam Raju from Tirunelveli Medical College. Gaudam Raju. Dr. Monisha from TSG Medical College. Dr. Mugilan from Indira Gandhi Medical College. Mugilan. Dr. Ravi Varman from Government Stanley Medical College. Dr. Sivagari from Sivagangai Medical College. Next paper poster presentation winners. We have 19 awards. All the awards are contributed by our past chairman as well as EC members. And I request the awarder to give the medal to the students. The first prize, first award, Dr. S.N. Narasingan Young Researcher Award in Hypertension and Lipidology by Alcy Roy Watson from CMC Vellore. May I request Dr. Narasingan sir, please. Madam. Dr. M.S. Ashraf, Young Researcher in Internal Medicine by Dr. Pritiga, PhD, Coimbatore. Certificate will be issued in the validity function. Ashraf sir. Pritiga from PhD Medical College. Sir, sir. Any other from any other
from PhD Medical College?
Okay. Next, Dr. Vijay Viswanathan, best paper. Dr. Kadiresan from Government Vellore Medical College. Dr. S.S. Lakshmanan, best paper in clinical medicine by Idan Poldan of Chettinad Hospital. Chettinad Hospital. Dr. Palaniappan, best paper in cardiodiabetology, Dr. R. Santosh Kumar. Santosh Kumar, Mohan Kumar, Mangalam Medical College. Dr. S. Seduraman, Best Paper in Clinical Medicine, Dr. Nagarjun, PhD Medical College, Coimbatore. Dr. K. Balakrishnan, Best Paper in Cardiodiabetology by Dr. Shashank, Madras Medical College, Chennai. Dr. Parandaman, Best Paper in Emergency Medicine, Dr. Balaji, Coimbatore Medical College. Dr. Kumaravel, Best Paper Presentation in Endocrinology by Dr. Parthiban, Coimbatore Medical College. Dr. R. Rajshekhar, Best Postgraduate Student in ECG Quiz by Manoj Keswara, Stanley Medical College. Dr. M. Chenniyappan, Best Postgraduate Student in ECG Quiz, Dr. Priyadarshini, Madras Medical College. Dr. N. Kasirajan, Best Postgraduate Student in Internal Medicine by Dr. C. Anthony Pius, Government, Thiruvarur Medical College. Dr. A.R. Vijayakumar, Best Poster Presentation in Clinical Medicine by Dr. Pratyusha, Stanley Medical College. Dr. Thirumalai Kolundu Subramaniam, Best Poster Presentation in Medicine by Dr. Dinesh, Government, Tarbapuri Medical College. Dr. T. Tinagaran, Best Poster in Nephrology, Dr. Kogul Priya, Government, Viluppuram Medical College. Dr. R. Gunasekharan, Best Poster in Non-Communicable Disease by Dr. R. Gautam, Kilpak Medical College. Dr. S. S. Annamalai Sami, Best Poster in Clinical Cardiology, Dr. Hamid Mujamil Khan from Madurai Medical College. Dr. K. Sanmukham, Best Poster Presentation in Clinical Medicine, Dr. Sriram, Madras Medical College. Dr. Isaac Christian Moses, Best Poster in Clinical Cardiology, Dr. Rajshekhar, Madras Medical College.
Now we have the announcement for the quiz, for the prizes for the quiz. We had a preliminary round where more than 100 PGs participated. It was organized by the Meenakshi Medical College General Medicine Department headed by Dr. Anbar sir. And today we have the final round of quiz where we have 6 finalists just conducted by the General Medicine Department of CMC Vellore headed by Dr. Samuel Sir. So we are glad to announce the top 3 winners. The first prize goes to Dr. Preeti and Dr. Akshay Kumar from Madras Medical College. Second prize is backed by Dr. Prasanna and Dr. Dinesh Kumar from Madras Medical College. And Third prize is backed by Dr. Iyer Vignesh Mohan Ram and Dr. Jacob C. Jacob from Government Mohan Kumaramangalam Medical College, Salem. So we will also like to give the participation prizes to the next winners. The fourth place was backed by Dr. Sailendra Prasad from Coimbatore Medical College and Dr. Karthik from Stanley Medical College. They participated as a team. Fifth place is backed by Dr. Vignesh A.S. and Dr. Madhumita R.M. from Kaveri Hospital, Chennai. And the sixth place was backed by Dr. Nikita from SKS Hospital and Dr. Sneha from Stanley Medical College. Definitely 6 teams out of the 50 teams, which is great performance. We congratulate all the finalists on behalf of the organizing team. Now we like to have honoring the team on stage by the organizing committee. So I request the organizing chairman of TAPICON 2020